year through the life. But in females, that doesn't happen. The female just keep losing the follicles all through a life. So I think controlled ovarian stimulation, the word itself is a misnomer. What are we controlling? We don't, otherwise we wouldn't have had OHSS. We wouldn't have so many problems. So what are we really controlling when we say controlled ovarian stimulation? So what could be the other word for use control? I think funnily, somebody suggested me, can we use wild ovarian stimulation? Probably yes, we are stimulating the ovaries very wildly. Then how to counsel the patient? Well, madam, I started these drugs and you responded very wildly, and she'll be surprised why doctor is using such terminologies. So I think better be with controlled ovarian stimulation. But again, it's a misnomer. The right terminology should be single follicle recruitment or rescue. We are just rescuing from death. So single follicle rescue or multiple follicle rescue would be the ideal terminologies of what we practice, and not ovarian stimulation. We are not stimulating anything there. So this is the fate of follicle, which takes place from the birth of 1 million to menarche. It comes to about just 0.5 million. About 1,000 follicles are lost every month and 400 ovulate in a lifetime. In all science, we are just debating and arguing and discussing amongst each other about this fate of these 400 follicles or 400 ovulatory cycles. And most of the cases, when we study AMH and AFC, well, Dr. Shari is going to elaborate that on more, that they do not correspond to each other. And how they don't correspond to each other, Dr. Shari will let us know about it. AMH comes from the secondary oocyte, the prenatal, preantral follicle and the early antral follicles, but the late antral and the pre-ovulatory follicles do not secrete AMH, they don't express it. But the antral follicle count is from 2 to 9 millimeter, wherein there are a lot of antral follicles. There could be early antral and late antral, and also a few follicles which tried their best to move ahead. They went on all the way to 12 and 14 millimeters, but they could not be selected to become a pre-ovulatory follicle, and they became atretic, and they settled down probably to 7 and 8, and they will be undergoing atresia. So AFC is a mixture of a few of atretic follicles and few of the antral follicles. So I want you to look at the red thing, which is saying atresia. So whenever the follicle gets recruited from the primordial to primary oocyte or secondary oocyte, at every point of time, its fate is written. It has more chances to become atretic and apoptotic than less chances of going ahead in life and becoming a pre-ovulatory follicle. And that is, this atresia is something which try our best not to occur when we try to use all the pharmacotherapy for ovarian rescue. We keep on saying that this is an FSH independent phase of development, but no, it's FSH regulated phase of folliculogenesis. If you don't have FSH at all, even a primordial follicle can't become a preantral follicle. And Dr. Shari will elaborate that further. These are the different terminologies which we are going to use in our practice. And one is recruitment. The recruitment takes place from the primordial follicle onwards, and cohort when a certain amount of FSH threshold is reached. So the recruitment which is taking place from the primordial follicles, so the preantral follicles, it is not under our control. So it is not FSH responsive, but it is FSH regulated. We're not doing much about it. But what we do is recruit the follicle from the preantral follicle further. That is called FSH responsive follicle, and that is the science which we're going to discuss over the next 2 days. Once the follicles get recruited, a herd of follicle will get recruited. A lot of them will become atretic, but then there will be a dominant follicle which will go 14 millimeter and above, and that is selection of a follicle to become dominant. A cohort and wave is the same. A wave of follicle gets recruited. And the subordinate follicles are the one which went all the way to become 14 millimeter, but did not go further, and they became dominant, but they did not go become a pre-ovulatory follicle, and they are called a subordinate follicle, though this terminology is not commonly used by all of us. So when it comes to an ultrasound measurement, when it is 2 to 9 millimeter, it's antral follicle count. And when it is 10 millimeter, it is recruited follicle, and 14 millimeter is a dominant follicle. So let's say you put your patient onto some stimulation regimen, and you see the patient on day 8, day 9 of the cycle after 5 days of FSH. If you don't see a single follicle, which is 10 millimeter, that means the herd of follicle has not reached the FSH threshold. It has not yet been recruited by the given dose of FSH by you. So that follicle has reached 10 millimeter by about day 5, day 8 of stimulation, makes you say, well, I have stimulated. I've been able to successfully recruit follicle. My dose is correct. And this 14 millimeter is the one which is dominant. It is now it has a chance of becoming a pre-ovulatory follicle. And that's what we understand with these terminologies. So when a certain amount of FSH is reached in a circulation, which is a pulsatile fashion, that FSH reaches a threshold of a follicle, a herd of follicle, and the whole herd follicle starts getting stimulated. So what does this FSH do? The FSH induces aromatase activity, and aromatase will convert androstenedione into estradiol. Estradiol is a mitogenic hormone, causes a lot of protein synthesis and causes proliferation of the granulosa cell. At the same time, it causes more and more FSH receptor formation, attracting the FSH to that particular follicle. So all the herd of follicles starts developing, and they become from 2 to 10 millimeter size. And then at a point, as the follicles are going ahead, inhibin comes in. The inhibin will act into the pituitary, decreasing the FSH level. So you'll have an early follicular phase with a good high FSH level, and the late follicular phase, which is going down on the FSH, but still the recruited and the follicle which has become dominant keeps on growing. So a dominant follicle will have an estrogenic milieu. So why a particular follicle becomes dominant? Let's say there are 4 follicles developing. Why this particular follicle became dominant? Because it develops LH receptor first. Then who synthesizes LH receptor? Estrogen, which is a mitogenic hormone, synthesizes an LH receptor. So once the LH receptor is synthesized, now the LH is coming down. That is producing more amount of androgen, that is androstenedione. A lot of substrate is made available, and that substrate is readily available to get converted to estradiol by the FSH-induced aromatase activity. And this two-cell, two-gonadotrophin theory goes on hand in hand to make the dominant follicle more estrogenic. What happens in the subordinate follicle? The subordinate follicle lacks to develop an LH receptor. Because of that, the androstenedione, there is not much. Okay, and the FSH receptors, so the estrogen production is less, so FSH receptor population also comes down. So the less FSH comes to that particular drug, aromatase goes down, androstenedione accumulates then, and that follicle becomes an androgenic milieu. So all the atretic or the subordinate follicle have an androgenic milieu, while the pre-ovulatory ones will have an estrogenic milieu. So once the follicle tries to become dominant, but cannot become a pre-ovulatory, it will be between about 10 to 14 millimeter, and it will start regressing. As it regresses, don't expect it to come to 2 millimeter. It will come to 7, 8, 9 millimeter. So in a bunch of AFC, from 2 to 9 millimeter, part of the 7, 8, 9 millimeter valas are atretic follicles. They are not expressing AMH, but they are there seen on ultrasound. While part of the 7, 8, 9 valas are just trying to develop, they're minimally expressing AMH, but the main AMH comes from 2 to 6 millimeter follicles, which has been studies which are beautifully done by Didier Divilly from Lille, France. He said that when you do a sonography, look at the follicles of 2 to 6 millimeter. Don't look at from 2 to 10 millimeter. And this 2 to 6 millimeter is the one which is going to tell you more about the ovarian response or the ovarian reserve of this particular patient. So try to dissect it further. I think this is the most important part of my slide. When the follicle is between 2 to 6 millimeter, 90% of the follicle has FSH receptors and 10% are LH receptor. So when you start the stimulation, even if the LH is very small in amount, because you're supplying good amount of FSH, the follicles will grow. But when it comes a 10 millimeter, when the follicles get recruited, 50% of the receptors are LH receptor. Now you need the two-cell, two-gonadotropin theory. You need that LH to come down, produce a lot of androstenedione, make a nice substrate available to make the whole estrogen mechanism going on further. But look what happens when the follicle becomes 15 millimeter onwards. Only 10% are FSH receptors, while 90% are LH receptor. So the growth of the follicle beyond 15 millimeter is LH driven and not FSH driven. And this will come very predominantly to you in a patient of hypogonadotropic hypogonadism. If you keep stimulating them with recombinant FSH alone, you will grow follicles till 15 millimeter and the process will halt. Why the LH is necessary? We're going to visit further. But what this tells us, that we are unnecessarily probably giving a lot of FSH once the follicle has become dominant in our practice. How about a stimulation regimen wherein we keep giving FSH till the time the follicle is 14 millimeter. And once you find a herd of 14 millimeter, why not give LH and stop FSH altogether? Don't confuse yourself. This is the truth. Human Fatemi has and Barbara Lawrence have recently published a paper that revisiting the FSH values in IVF cycle. Why do we get a lot of progesterone in the late follicular phase? Or why do we get a lot of progesterone at the time of HCG? on the trigger day. That's because you're pumping in FSH after FSH. So they did an interesting study where last 3 or 4 days, they gave HCG, a small amount of HCG, wherein they never gave FSH, and the progesterone levels did not go up, and they could do more fresh embryo transfers. So this particular mode of treatment of stimulation will come to us, because if we can do more fresh embryo transfers, we are making the cycle cheaper. If you're using HCG in the later part of the stimulation, we are making the cycle cheaper, and our time to pregnancy will be reduced, and our cumulative live birth will be still equal, because you are giving a better maturation of the eggs by giving good amount of LH. HCG is an LH surrogate. So again, I'm just revisiting. 2 to 6 is AFC, 7 to 9 is AFC, plus a few atretic, 10 to 14 is recruited follicles, and 14 millimeter onwards are the dominant follicles. So these are the FSH levels in the menstrual cycle. In the start, it will be on day 1 before you have started any stimulation, it could be just 4 IU, and the luteofollicular transition has taken place 4 or 5 days before, and the FSH is peak up. And the day 6, by the time the FSH value is 6 and beyond is 3.3 MIU. So in the late follicular phase, your FSH level is going to drop down. And all these beautiful, interesting studies have been done way back when Serrano produced a molecule of HMG. I think it's called Personal. And they put it to the International Standards Laboratory. They donated some amount of Personal. And then they said they did initial studies in hypoc patient. And the international standard determined that we need to achieve a good amount of FSH level in the first phase to push the follicle. And once it is dominant, your FSH can be low. So the concept is reach the threshold and be at the threshold. Don't reach the threshold and keep crossing the threshold. You just keep recruiting herd of follicles, herd after herd, which are not going to be of any use to you at a point of time. This is a little colorful picture by the Picasso, just gifted this to me, and I just put the words there. This is the follicular apparatus. Just close your eyes and imagine this is follicle. Truly, it looks like a follicle. Okay. So this is the oocyte, your cumulus. These are the antrum, the green is the antrum, and these are the mural granulosa cells and the theca cells. What am I trying to tell you? I'm telling you that the theca cells are next to the vessel. The follicle doesn't have any blood supply. There is no follicular artery there. The follicle is just in the ovary. It is receiving all its nutrition by diffusion. So it is the theca cell which is next to the medulla or the cortex of the ovary, which has the blood supply. So the blood comes to the theca. Or the earliest diffusion of the endocrine factors and the growth factors from the blood occurs at the thecal level. The mural granulosa cells have large amount of LH receptors, and they're the ones which are driving the 2-cell 2-gonadotropin theory, and they're putting a lot of estrogen in the follicle, and also putting the estrogen to develop the endometrium, etc. What about the cumulus? Cumulus is that umbilical cord, which is taking the nutrition received by the follicle to the oocyte, and that's the core of it. It needs the best nutrition. But you know something? Cumulus doesn't have LH receptors. We keep talking of PCOS with high LH, and that it will affect it will have a bad oocyte quality. No, forget it. The cumulus doesn't have LH receptor, and that is what is going to determine the oocyte quality. So let be any amount of LH high. It just tells you this patient has more amount of androstenedione. It just tells you we need a push in the aromatase activity to convert that androstenedione into estradiol. So high LH just tells you need a higher dose. That's all. Your oocyte is still going to be good, better probably, and giving you pregnancy. The problem is you give a small dose with a high LH and we come into a problem. So remember, the cumulus doesn't have LH receptors. So the dominant follicle will get the LH receptor first. The LH will affect the growth, estradiol levels, and getting nutrition to the oocyte. You know, oocyte has to get the best nutrition. It is the God has made oocyte the largest cell in the body and the highest amount of cytoplasm all over the cells. It has to put so much of nutrition and Golgis and mRNAs and everything has to be huge there, because this oocyte will be liberated in the space. The sperm will meet it. It will form an embryo. The embryo is going to go for 5 days, and then that embryo will get implanted. For those 7 days, the oocyte has to not only survive, but repair the bad sperm also. He's smoking. He has to repair the bad sperm and keep the embryo growing into a best embryo and implant. So all that depends on the oocyte nutrition. So that's why oocyte is the biggest cell in the body, having so much amount of cytoplasm to survive for those 7 days. Now, the problem is why? The female always thinks this way. The female will say, why this dominant follicle, why she got LH receptors first and not me? This is the question asked by Miss Atretica to Miss Dominica. The story starts at the oocyte itself. The oocyte determines who wants to become a dominant and who doesn't want to become dominant. And all that comes from the different factors which are there in the oocyte, GDF9 and BMP15. This research has been done by Epic and Marzuk laboratories, and these two laboratories, one in the US and one in Europe, at a point they collided, came together, and that was the ovary was one of the biggest websites in the world in those days. This is a story about 3 decades back. And all those studies have been done by these people, Epic and Marzuk, and they talked about GDF and BMP15, which there's released from the oocyte and doesn't allow it to grow. But as this GDF has to diffuse from here all the way to theca. But in the process of diffusion, the amount of GDF9 reaching the theca will be less. So the theca is not under the inhibition of GDF9. As soon as it receives the FSH, the theca starts growing further, or theca or the granulosa cells start growing further. So the growth starts from periphery. And as the antrum gets secreted, less and less amount of GDF9 and BMP15 can have a negative effect on the granulosa cells, and the follicles keep growing further and further. So how many cells will remain with the cumulus and how many cells will become the mural granulosa cell? It depends upon the competition between the FSH and the oocyte factor like GDF9 and BMP15. And higher FSH doses will put less cells with the cumulus because most of the cells will then move towards the mural granulosa cells. And this FSH will drive the follicular growth and a faster growth will take place. But then the maturation will be in question because less amount of cumulus cells will be there. And that is the one which is getting nutrition to the oocyte. So if you have a stimulation regimen where your follicles have become dominant, it's just in about 8 or 9 days, because you're pumped in a lot of doses, probably your oocyte competence could be affected. But sadly, we do not have a measure of oocyte competence in our science, and we have that lack of knowledge. What about follicle waves? We understand there is always a follicle wave which starts with the luteofollicular transition taking place about 4 days prior in a normally menstruating woman, and somebody who's beyond the age of 35 or older age of the low ovarian reserve. This could start about 7 or 8 days prior to the onset of menstruation. The corpus luteum becomes corpus albicans, the LH and progesterone, estrogen comes down, and there it starts with activin, the FSH starts going up, and the FSH goes on further. And this FSH goes into the follicular phase and starts a wave of development and the follicles grow. And these were some interesting studies done in the past where they saw 2 peaks of inhibin. One inhibin peak noted after the first wave then became dominant, and the next inhibin peak noted in the early luteal, the mid luteal phase. And they said that there could be something, a new wave is created there. And what could be the reason of that? Follicular waves, synchronous growth of antral follicles will be there, occurring at regular intervals in a menstrual cycle. There will be generally 2 waves. First is ovulatory in the follicular phase, and the second is anovulatory in the luteal phase. In about 75% of these waves will be anovulatory. And there could be even 3 waves, early follicular, at ovulation, and mid or late luteal, especially seen in older women or women with diminished ovarian reserve. And the luteal wave will be wave which is generated in high progesterone and LH atmosphere. With high progesterone atmosphere, this wave will be anovulatory and it will not ovulate. Only the follicular wave will be an ovulatory wave there. I want you to concentrate on what happens at the trigger. There is a small nick in the FSH rises. What is the role of this FSH? This FSH role, Dr. Goody is going to explain more about it in his trigger lecture, is to make a follicle more mature. But at the same time, it assures a certain more follicles reach FSH threshold, and the forthcoming cycle, a few follicles are ready to develop. So it guarantees development of few follicles in the next follicular wave. I'm sorry, I'm jumping ideas. I'm going from apples and oranges, but that's the way we understand because it's very difficult to go through in a systematic fashion. The ovarian physiology is something we can have a conference on that. A certain amount of FSH is needed by the follicle to grow. That means that FSH will induce aromatase enough to convert androstenedione of that follicle into estrogen. And that level is called FSH threshold. This is a hypothesis. We only know who will have low FSH threshold, so that they will form follicles faster, and who will have high FSH threshold, who will form follicles. It will be difficult to form. So one young women would be young, normal BMI, normal AMH, normal FSH, LH, and AFC between 10 to 15 would be good patients, while these patients with high threshold would be one with difficult to stimulate, and they would be of advanced age, low or high AMH, low AFC, obese women, they will be difficult to stimulate. What about LH? Follicle has a development-related need of LH. If the LH is less than 1.2, this is called low LH. And this is 1.2 on day 2 of the cycle. This is called low LH, and follicles develop in low LH pool. The follicles are developing in a low LH pool, and your 2-cell 2-gonadotropin theory is not acting very well there, and there will be less oocyte yield. So whenever we embark on the stimulation, especially if we are given a pre-treatment, we see to it that we want to know at the LH level before we start the stimulation. If the LH is between 1.5 to 6, well, thumbs up. You're doing everything in a good LH pool, and your follicular generation will be very good. But if the LH is beyond 10, or some people take a cutoff as 12 on day 2, that's called hyper LH. And hyper LH typically means you are having a lot of androstenedione there. And that you need to induce higher aromatase activity to convert it. So hyper LH just tells you this is going to be a resistant patient for stimulation and nothing else. So in a low LH, you will have all these problems. There will be an impaired follicular development, a compromised oocyte maturation will be there. An optimum LH level will give you everything between 2 to 10. And if it is beyond 10, then again, you will have follicular atresia and LH receptor downregulation, all those problems are there. So a certain amount of LH is needed for a good follicular development, and that is called LH threshold. And a certain amount of LH is detrimental for follicular development, and that is called LH ceiling. And this is a typical example you will get in a clomiphene cycle. In a clomiphene cycle, when clomiphene goes to the hypothalamus and occupies the estrogen receptor there, it secretes GnRH. The GnRH will secrete FSH and LH both from the pituitary. So in a patient of hyper LH PCOS, not only the FSH goes up, even the LH goes up. So in a patient where the LH goes up, these patients will be resistant to the clomiphene developing a follicle, and we call it clomiphene resistance. And this is a typical LH ceiling, which is created by the drug clomiphene. And probably that's one of the reasons why we don't use it so much in our PCO population. LH there is a dose-dependent increase in follicular E2 and higher testosterone and androstenedione levels. Oocyte with multiple, suppose you really work on a very high LH atmosphere, you could have oocyte with multiple anomalies. But believe me, these situations these are studies, they're coming from cattle. And most of these studies are coming from the animal husbandry. Okay. If you reach a correct dose of FSH in a high LH situation, you will be able to overcome this story. Okay. So certain LH is optimal threshold, which assures oocyte maturation. And when we go back to the studies which are published on MERIT and MEGASET studies, which are large studies published between the RFSH and HMG-HP, which is better for in GnRH agonist and GnRH antagonist cycle, the conclusion where HMG-HP, which has an LH activity, is a far better drug when it comes to an ongoing pregnancy rate, live birth rate, and having less miscarriages. But what happens in an older age? In an older age women, the androgen amount decreases with age, and testosterone level decreases by almost 50%, and DHEAS is decreased by about 77%. So all older women have low amount of intra-ovarian androgens. So these are the women you need to increase the intra-ovarian androgens, and you will give your supplements, but LH is needed in your stimulation. And that LH will give good amount of androgens, and hence the ovarian stimulation will be better. So especially in older women, if you're debating your decision, you can just do a testosterone level. And if the testosterone is less than 0.45, then you definitely need a LH containing gonadotropin and not RFSH alone. And that will be a wrong choice to do. And no difference in both drugs if testosterone is normal. And this low FSH, LH-FSH androgen typically induced by OC pill pre-treatment. So now older women, if you're giving OC pill pre-treatment, then probably you're taking the LH down and they need more LH, and you have to see to, so OC pill pre-treatment, older women and RFSH alone stimulation may not work well. You will have to give LH in some particular format there. We'll talk about this anyway. This is a 2-cell 2-gonadotropin theory, which I'm talking to you about. Now, herein what I'm telling you is there is a rise in serum progesterone on the day of HCG if you're stimulating the follicles hard, and if you're stimulating especially with RFSH alone. This is because when the RFSH is there acting here, it will convert the cholesterol into pregnenolone into progesterone. And this progesterone can have an access to the circulation, or this progesterone actually goes to the theca cell, which is under the LH control. And in theca cell, with the cyclic AMP 450 pathway, the progesterone needs to get converted to androstenedione. Now, you are not using LH in a stimulation, you're just pumping in FSH there. So you have a large amount of progesterone created, and because of lack of LH, all that is not getting converted to androstenedione, or the sum of it will enter circulation. So high progesterone on the day of HCG trigger doesn't mean your LH has increased. It is an extra LH, extra pituitary related increase in progesterone because of this hyperfunctioning of the 2-cell 2-gonadotropin theory with lack of LH in there. So again, this is one of the reasons we don't want to use RFSH alone in our stimulation. Anybody saying time up or something? No. Generally, that sentence is not there in our lectures. Androgens. Androgen is substrate to form estradiol, and androgen also inhibits growth of follicles. So every hormone, when it comes to understanding in reproductive medicine, a certain amount of hormone is necessary. So certain amount of hormone is a threshold, and a certain amount of hormone is bad. So that is a ceiling. So every hormone has a threshold in ceiling in understanding of reproductive endocrinology. I salute Roy Homburg for this graph, actually. This is something me, Anil, Roy, we all had gone to the same conference, Anil in Lille, on AMH. And after coming back from the conference within the next 7-8 months, this guy had published this whole theory of androgen. He says there is an androgen excess. To give an example, I'm going to say there is a prenatal androgen excess. So there is a PCOS lady who is pregnant with a fetus, female fetus, and all her high androgens are going across placenta to that female fetus. So she will have a lot of androgens in her body, the female fetus, and it will make development of a lot of small multiple follicles will be there. Now, all those small multiple follicles will have high AMH. And as she's born and grows further, with this high AMH, the FSH action will not be allowed. Since the FSH action is not allowed, there is anovulation. With anovulation, there will be low progesterone. With low progesterone, there will be high LH, and that LH will cause, again, androgen excess. And the saga of PCOS will continue. Now, there could be many insults which could be taking place. This could be of a genetic origin, as I told you just now. This may not be of a genetic origin. It could be an insulin origin. It could be anemia, which acts on insulin growth factor binding protein 1 in the ovary. It then increases that, and that causes the LH drive. They've also been able to find AMH receptors in the hypothalamus. And they say that a few women of PCOS secrete more amount of LH to the given amount of GnRH pulse. And because of that, there is hyper LH, which causes problems. And why then these women have high LH? And why do high LH is secreted with that small amount of GnRH pulse and not with any other women? The concept is, in the prenatal androgen transition, which has taken place to the female fetus, that androgen, excess androgen, adjusts the hypothalamic pituitary axis in such a way that for a given small amount of GnRH, more LH is released in this particular population. So this could be the Barker's hypothesis. That's the way it goes further. I'm again jumping an idea. I told you the oocyte is the biggest cell. We grow the egg follicular apparatus from 2 millimeter to all the way to 20 millimeter, and a mechanical rupture takes place. So it requires a lot of energy for the growth. And this whole growth takes place in just 17 to 18 days. And it requires energy, and rupture also will require energy. So energy comes from mitochondria. Mitochondria comes, they get ATP from Krebs cycle. My humble sorry to you, I'm reminding biochemistry again. Okay? And it's the glucose metabolism. So the glucose needs to be internalized. That only becomes by insulin. So if the follicle is insulin sensitive, it will grow and rupture. If the follicle is insulin resistant, it will become anovulatory. So at the ovarian follicle level, if the follicle is insulin resistant, it will become anovulatory. So we keep asking questions about why we give metformin to PCOS. Where is the question about it? You should give metformin. But the problem is, metformin will correct the metabolic story of polycystic ovary. Metformin does not correct the endocrine story of the polycystic ovary. The metabolic story of the polycystic ovary is related to the live birth rate. That is, once you achieve pregnancy, going to the live birth rate. With high metabolic problems, will have abortions, PI, GDM, IUGRs, etc. But the metabolic story is not related to getting a pregnancy. So metformin, when it comes to an ART practice, with all those multiple meta-analyses being published, it has gone down, no doubt. We understand it's a different story. But still, it has a role in adolescent polycystic ovary. If you have any questions on that, we can take them up later. Let me jump on to the agonist and antagonist, what we use in our practice so commonly. How the GnRH acts. The GnRH receptor is there on a pituitary gonadotroph. The GnRH comes and sits there. Then the GnRH receptor complex gets internalized into the cytoplasm. And once it is internalized, the lysosomes will be there. They will break the concept, the situation, and the GnRH will be available for mRNA and Golgi to synthesize more FSH and LH. And the receptor will come back to the surface, accepting a new molecule of GnRH coming from the hypothalamus. The first effect it does, that as soon as it is internalized, it will release the stored pool of FSH-LH in the cell, and that is called flare. That will raise the FSH-LH immediately. But if the GnRH receptor is not made available again back to the surface receptors will go down. So this is what happens. So if there is a GnRH, which is you put, let's say, loop-right depot there, the GnRH is nothing but your loop-right depot, which is acting and occupying that receptor. Now this receptor complex gets internalized. The first flare will take place, but the receptor is not, the GnRH loop-right doesn't leave the receptor. They keep it bound together. And the receptor is not available again to receive next pulse of GnRH. And then there will be no synthesis of FSH-LH, and there will be continuous downregulation, what we understand. So this is an interesting study done in animals again. Degarelix, which is an antagonist, when you give, there is a sudden fall in LH, which is taking place. But when you give leuprolide, there is a flare, and then the downregulation will take place. Now, this is one thing which is the core of all our understanding of ovarian stimulation, that the follicle recruitment starts before the menses. Because the luteofollicular transition takes place, the FSH goes up, it starts recruiting follicles here. By the time you start stimulating here, well, there are a few follicles larger and a few follicles smaller. The few follicles are already reached the threshold, few follicles are yet to reach threshold. And now you again reach the threshold in further 3-4 stimulations, stimulation days. So you land up creating a lot of asynchrony that typically happens in your gonadotrophin cycles with IUI and also gonadotrophin cycles in antagonist phase. So if you can curtail here, if you can control this FSH, probably you can have a synchronous development of follicles. And we will, Dr. Sherry will be addressing this situation again in her lectures. This is a very interesting study. I would like all of you to visit this paper of Richard Fleming. And I think we're really thankful to this gentleman who was given the whole long protocol came from the Richard Fleming's research. And he's the one who introduced long protocol, and the whole world is still enjoying pregnancies on long protocol. But when it comes to antagonists, he says that in a long protocol, prior to the menses, the agonist keeps the FSH and LH low. So you get a herd of follicles there, which is synchronous. Well, in an antagonist cycle, that doesn't happen. You do nothing here, and you will allow a certain amount of FSH to go up. And then you take the FSH further up by your stimulation. So you stimulate 2 herds of follicles, and getting an asynchrony is very, very common. So when you have an agonist start protocol, your follicles will be something like this. An antagonist start, your follicles will be asymmetrical, and then you take them further. So at the end of an agonist protocol, you will have a synchronous development of follicles, and at the end of an antagonist protocol, you will have an asynchronous herd. And then you keep having that question in your mind. I was seeing 10 follicles, I got 3 eggs. I had 15 follicles, I got 4 eggs, and things like that. So this is basically because of an asynchrony. You're not doing much to the asynchrony. There's another problem which you carry forward. What happened is the agonist protocol came into practice first. And that said that the criteria for trigger is 3 follicles beyond 17 millimeters. And we carry forward the same concept in our antagonist protocol. And when you keep using the same protocol, you could be getting less oocyte yield. So the criteria for trigger in antagonist protocol is you see the maximum herd going beyond 17 millimeter. So you have 3 follicles of 18 millimeter, but there are 8 follicles of 16 millimeter. Wait a while. Don't give your trigger. Let the 16 millimeter walas also become 17, 18, and then you give trigger, and your oocyte yield will be better. So postponing the trigger by a day or 2 more in antagonist protocol, it will help you better getting an oocyte yield. These are all interesting studies that were done by Franchi et al. And George Grisinger earlier. I'm taking you through a different concept. To understand this concept, let's understand what could be happening endocrinologically in the first 5 days of an antagonist protocol and the next 5 days of an antagonist protocol. In the first 5 days, the follicles are between 2 to 4 millimeter getting stimulated, and they will go up to 10 millimeter by 5 days, and then they will grow further. In the first 5 days, the E2 is going up, the FSH is also going up, but that will not trigger premature LH surge. It will be triggered only when the follicles cross 8 to 10 millimeter. Because at this level, there is something called gonadotrophin surge attenuating factor, which comes from these follicles. And this gonadotrophin surge attenuating factor does not allow the LH to come in. So the risk of premature luteinization is only beyond 5 days when all the follicles have grown beyond 10 millimeter. Why is this important? There are few people like Messines et al. And he's published that we are using antagonists unnecessarily. The gonadotrophin surge attenuating factor is good enough, and you don't have to do any antagonist, just continue the stimulation and give a trigger. Well, I don't agree to this concept at all. I'll shortly come to that, why we don't agree. So when you give an antagonist injection, just within 1 to 2 hours, the LH level will drop. There will be a sudden drop in LH level. In about 13 hours is the half-life. And by the next day's antagonist is due, your LH has recovered. Believe me, there are interesting studies done by Shahar Kohl et al. From Israel. And he dissected the organoletron study group paper again. And he looked at those literature and he found out there is a subgroup of patients who do not recover the LH levels after 24 hours of antagonist injection. And this particular subgroup has a low oocyte yield. And he said, this is a case-to-case based study you should do to identify who requires LH-induced stimulation. Obviously, we are not doing that. I don't use any stimulation without LH, so it's a different story, but that way will evolve the concept. So this Shahar Kohl beautifully published all these things, and he says that it's better to monitor the LH levels further. Anyway, we'll come to that. In long agonist protocol, it allows a great flexibility. So it's doctor friendly. Like you want to go for an ASHRAE conference, put the patient on long agonist, give stimulation only so that the pickup comes all after you return back from ASHRAE conference. If you have a marriage and family, adjust everything. So it's doctor friendly, but antagonist is patient friendly. Being doctor friendly, we pump in a lot of stimulations, a lot of injections to the patient. So the treatments are long. With a lot of downregulation and over-suppression of pituitary ovarian axis, your stimulation is going to be a longer period. So the lady is receiving a lot of injections in long protocol. And that's one thing in our developing patient friendliness of the protocols. We lost on the long protocol and we have gone to the antagonist protocol. And most important of the antagonist protocol is a less of OHSS. We are equally concerned about safety of our couples, and agonist trigger in antagonist protocol is something a boon. And I think it qualifies for an award, but it just took away the complexities and management of OHSS from all of us. But when you're giving antagonists, can LH escape? And yes, why and who? Who the LH control will escape? So this is a beautiful paper by Roy Homburg and Lambach et al. Of the GnRH antagonist and mechanism escaping the LH escape. And what is said is when you're giving the LH antagonist, you are suppressing the LH suddenly. Now, because of that suppression, the sensitivity of the pituitary for the smallest rise in GnRH is very high. The pituitary has suddenly become very hypersensitive. And in such a situation, your suppressing effect and the hypersensitive pituitary, they have to balance each other to keep the LH down. But in some women, this balance will be lost and the GnRH will just kick off, a very small amount will just kick off the secretion of LH and the LH escape will take place. And that typically happens. I don't have it here. That typically happens in older women, obese women, and PCOS women. So let's go back to the GnRH, the gonadotropin surge attenuating factor. What will happen in a lady who has low follicles? In patients who have low follicles, your GNSAF will be low. Gonadotropin surge attenuating factor will be low. So these women have a chance of escaping early. And that's why many times in older women, you like to give trigger a little early at 16 millimeter rather than waiting for 18 millimeter. You like to start your antagonist early at 12 millimeter rather than starting at 14 millimeter, because collectively, because of less follicles, the GNSF is low. What happens in PCOS? They take a longer time to stimulate. The AMH is retarding the stimulation. So they will have plenty amount of GNSF and that will keep the things much suppressed. But the problem in PCOS is you have a huge estrogen. If you do a day 5 estrogen in a PCOS stimulation, it will be 1,200. And that too in a normal stimulation will be 500 to 600. With such a high estrogen level, that is going to give a positive LH surge. So it is a fight between GNSAF trying to keep the LH down and the estrogen trying to push the LH up. So that fight is different than the fight in the diminished ovarian reserve patient. And that's why LH escape can be seen commonly. Yeah, I think I'm going through the same concept, and rise in LH is in hyper responders, but the mechanisms of this rise of LH or LH escape is different in both. So diminished ovarian reserve is a predominant risk factor for antagonist failure, and this is breakthrough LH will be there. Age 40, poor ovarian reserve, high day 3 FSH levels, low AMH, and by day 11, breakthrough can be noted. So you need to be very careful in these particular women. Dose adjustments. Aren't you very favorite of doing dose adjustment in a cycle? We just start off with, let's say, 300 and you say halfway through, chal yaar, aur ek bada dete 150. Or you start with 150, you realize that yaar, double karte hai. You know? So we are in a habit of doing that. So I just went to this systematic review, and this is about last 10 years, and this has been published by, I think, this is by Human Fatemi. And they said 45% of the cycle are dose adjusted, either low or low. Halfway through, they will increase the dose or decrease the dose. And this is mostly on day 6, everything will be done. But these are just published trials. We are not publishers. No, none of us is publishing. But if you ask yourself in last 1 year, how many times you have increased or decreased dose, you will be able to tell me 10 patients at least. So it's such a common thing, but the publication would be very, very less. So that's not a real world scenario. So 10 to 20%, they'll be decreasing the dose. Otherwise, they would increase the dose. Most of us increase the dose. Even in the Optimist trial, in the second, they allowed an increase on dose. But stupidly, they allowed only by 50 MIU. A dose of 150 and 200 wouldn't make much difference. And to Indian ovary, so a more common dose adjustment will be done in agonist cycle, 59, than an antagonist cycle. That is what has been found. But the real world, okay, this is just a Caucasian data. This is not an Indian data again. Okay. So I just want to say on the dose adjustment one thing. You are adjusting the dose halfway through, day 6. You increase the dose by 150 IU. It is going to now recruit a few more follicles. And by the time, do you think they'll be dominant by the time you go for trigger? No. So practically speaking, you're not achieving anything by increasing the dose halfway through. So best is to decide the dose on day 2, have that dose decision making pakka, and you will have better results. And that Dr. Goody is going to enlighten you on dose decision makings in IVF. And even if you increase the dose, what happens? The FSH receptor is saturated after exposure to a particular amount of FSH. And beyond taking a serum FSH level beyond 20, nothing is going to grow. You make it serum FSH 30, nothing is going to be better about it. And FSH at the time of recruitment is important. Later increase may not do much, and it will be just 4 days prior to what FSH is 4 days prior to menses. That's going to determine how it's going to go further. The follicle consequences of any dose changes are not seen for 4 days. An IVF cycle length being 12 days, a dose change at the day 6 will be highly questionable. So it's better to have an optimum dose decision day 2 rather than halfway through making any changes. What about the luteal phase? We understand there are multiple follicles, a high estrogen level, give a HCG triggers, you take the LH levels very high, and obviously the LH rise will be very high in the early part of the luteal phase. It does not follow a normal curve. The LH and progesterone level will be a very high LH and progesterone in the first half. So obviously, because of this particular thing, what happens? It's a very awkward situation we are creating. We are creating in controlled ovarian hyperstimulation a very high LH and progesterone level. And day 6 onwards, because by day 6 of the trigger, your HCG action is lost. HCG action will be lost beyond 6.5 days. And the implantation window is between 6.5 to 9 days. So that's the time the blastocyst is going to come. And what are you creating there? You're creating a luteal hole. You're creating a luteal phase defect by using HCG trigger as well as having multiple follicles recruited there. And unless there is a pregnancy and the blastocyst now secretes an HCG, and believe me, the HCG molecule secreted by blastocyst is hyperglycosylated HCG molecule. It is not the same HCG which comes from the placenta. A hyperglycosylated HCG molecule stimulates the corpus luteum LH receptor, but not in the cyclic AMP pathway with a routine HCG does it. It does it by a ERK1 and ERK2 pathway, which are anti-apoptotic, and they mature the corpus luteum. So we always learned in JEFCOT the corpus luteum of pregnancy. So that is because of this hyperglycosylated HCG, which acts exactly like LH. But that comes from the placenta, is not hyperglycosylated HCG. It is routine HCG. It doesn't act like this. It doesn't act on ERK pathways at all. It does act on cyclic AMP, which is more steroidogenic. So it produces huge amount of progesterone than LH and any other hormones. This I'm not going to touch a bit about it because this is such an elaborate topic, and Dr. Shari will be covering after this lecture with all of you. What I'm going to tell you is the kind of FSH molecule secreted in our circulation is a bit different. A FSH molecule has certain glucose moiety to which sialic acid is attached. And how much sialic acid is attached to the FSH molecule is going to determine is the FSH molecule highly acidic or it is less acidic. Let's call less acidic basic, just for our understanding. There's nothing basic here, just less acidic. A highly acidic FSH molecule has shorter biological activity, but a longer life. And that's what is needed when in the early part of the follicular phase. You need a long-acting FSH molecule, so FSH accumulates and a certain high amount of FSH is reached, which in turn will give a push to the follicular development. But just pre-ovulatory, you get a more less acidic molecule, which is very good which is highly active, but it has a short acting. So it has to act only on one follicle, which has become dominant. And that basic or less acidic molecule continues pre-ovulated in the early part of the luteal phase. And again, when the luteofollicular transition takes place, a high acidic molecule of FSH is released. So you have different FSH isoforms, but our prescription has only one isoform of a fixed acidic. We are unable to match the God nature. We cannot match the isoforms of the nature. And that's why we keep pushing a large herd of follicles, because we accumulate a lot of FSH in the circulation of this lady. And this is a very interesting study, which I'm going to take you through, the characterization of FSH profiles in normal ovulating women. The underline is normal ovulating women. And they estimated FSH on all these particular days. And obviously, they did urine determinations of hormones and serum levels, and also the ultrasound scans. And then they put up the whole thing to know how the FSH pattern varies. And look at it. These are normal ovulating women. And look at the FSH patterns. There's something called low and irregular. There's delayed. There is, this is a typical classical one, I would say, the typical one. And there are so many variations in FSH secretion. And why does this happen? Who is ovary under control of? Pituitary, am I right? And who is pituitary under control of? Hypothalamus. And who is in hypothalamus under control of? How much you sleep, how much you eat, what you eat, do you regularly exercise, how you behave, do you take stress, and what is the importance of yoga? Is that. So if you convince your patient to do a good yoga is dharma, not exercise, yoga is dharma, then you are regulating her hypothalamus. That regulation of hypothalamus percolates down to pituitary and ovary, but it has some time. Our lack of patience amongst you and me and the patient in front of you has not made them pursue this, which is very sad. And that's where our Ayurvedic and homeopathic colleagues kill us. Because you have put waiting the patient in the hall for 2 hours, giving them 5 minutes, doing quick scans, okay, pushing them to expenditure of lakhs of rupees, not giving a pregnancy, taking through the rounds of roller coaster rounds, and she's sick of you. And she goes back to the yoga, to the Ayurvedic fellow, who just calms her and tells her to practice something different. And he regularizes her hypothalamo-pituitary axis. Let's not antagonize them. Let's practice what they practice in our practice. And that would give us a better result. So your whole aim is not to decide what ovarian stimulation protocol. Your aim is, have you controlled your hypothalamus? Ask yourself this question. Let's come to the LH. What happens to the LH levels? Are the LH levels same? And this is a very interesting study done by Park et al. The LH surge, he says, is varied. It's a different LH surge. It's not a typical high plateau and coming down. The LH surges are different. And he says these are the different ways the LH surge are there. There could be single peak seen in 48%. These are normal ovulatory women. Again, I'm not telling we are in stimulation piece. So LH peak is 48, double peak in 33, plateauing in 11%, multiple in 24. Why this is important? We all are going towards natural cycle frozen embryo transfers. A natural cycle frozen embryo transfer patient is under immense stress. So do you expect her LH to be very normal? There's a possibility, if you don't give her enough amount of morale boosting and control her hypothalamus in the best fashion you can, you would have this varied LH secretion, and which will just jack off the whole cycle of natural cycle for FET cycle. So we prefer doing modifiable by putting HCG there. But that is one good way. But at the same time, look at the hypothalamus and hypothalamic function in this particular lady. Low FSH variation, which seen generally with good sleep patterns, a high BMI, increased FSH variability is there, and with also increased physical activity will also increase FSH variability. FSH peak before day 2 is seen in 25% of the cycle. Day 2 to day 3 is 28%, day 4, 47% of the cycle, and 13% will have prior to menses. And that's what is going to trigger off the follicular generation. FSH decline in late follicular phase was seen in 42% of cycles only, and this has delayed ovulation and causes ovulatory dysfunction as well. So these are normal ovulatory patients, believe me. So much of variation is there in the body. And this concept I've already visited, that the progesterone comes from granular cell without luteinization, and premature progesterone lies in the late follicular phase, could be seen many. Just going to this. Well, thank you so much. If any questions are there, please.
Excellent, Sachin. It's a great learning from you, as always. You mentioned about stepping up the dose of gonadotropin halfway. Say, suppose it's day 5, and you feel that probably the follicles have not responded the way you want. And then we step it up. That's what you have also mentioned. That's what I think all of us do. And you feel that it doesn't really make a difference. See, I can understand in recruiting new follicles, but if you have a follicle which is not growing well, we just want to give an extra dose to make that follicle grow and not recruit new follicles. I very well understand, because there's not much time for the newly recruited follicles to mature. But what about the follicles which have already taken off, but not responded the way you really want? So probably then that small increase of dose might help. That's my thinking. Yeah.
That's a very practical, and I was expecting this question anyway. And there are two parts to the story. So, sir, let's take an example. So we have this lady whom you have stimulated, and you do a day 5 stimulation. On day 5, what you see is your E2 levels has reached, let's say, between 100 to 200 picogram, and you have about 4 or 5 follicles which are touching 10 millimeters, and you expected more. You expected more. Okay? And then you step up the dose, and thinking that these 8 to 10 millimeter are not up to the mark. Am I right? That's one thing. I think Anil needs to contribute to me here. I don't know whether we have any control study where increasing the dose will make a difference, or keeping the dose will have the same yield at the end of the day. Because what may happen is you're just making the patient hyporesponder, that is your duration of stimulation may go up, but you may have the same yield. So just increasing the dose, I really don't know whether it will make a difference. The common increases of such intention are done at a point which is on day 9 of the cycle. Your antagonist is already there, and you expect by day 11 a 16 millimeter follicle, and you see day 11 or day 12, your follicles are still 14 millimeter, and you are tempted to increase the dose there at that level. Sometimes even I do it, but I don't think it makes again a difference to the yield. Probably just prolonging the stimulation could give us the same result. That's one. So I really doubt whether we have any RCT on this particular aspect. The second scenario is you go all the way to day 5, and then you realize, well, no follicle has reached 10 millimeters. So your dose has fallen short, and you definitely have to increase the dose. Now is what I told you. Then you have to counsel the patient, well, please calculate 12 days now on. And my earlier doses have not made any difference, and your cost and everything is going to go up. I think, Anil, I wanted to contribute to this. Many times there could be an additional LHS. I'll quote some examples.
Increase the doses for 3 reasons. Primarily because it makes the doctor feel nice. I think we are convinced that by increasing doses, it helps. Increasing doses, generally tends to help in 2 occasions. One is on day 5, or day 4, you scan someone, and mainly in polycystic ovaries, you see that you've not recruited any follicles, which basically means you've started somebody on a wrong dose and you have not been able to break the FSH threshold. There you can rescue, and as Sachin said, you can then increase the dose, and I'll say then go for a step down. You can do all this provided you put somebody on the antagonist protocol, otherwise you're in deep trouble. Now, if follicles, once they cross 14 millimeter, and I say, think of it as a race, and follicles move at the same pace. There's no catch-up game here. When people say there's a catch-up game, follicles don't catch up. You have a follicle at 14, and it will go at the same rate of growth as a 12 millimeter follicle. So there's always be a discrepancy in follicles. So if you intervene at 14 millimeter in an ovarian stimulation cycle, then you're going to see a ladder type appearance, and that tends to give you. It all depends when you trigger. So if you go by the lead follicle, then you're going to create a lot of immature eggs. So then I say go by the bottom follicle, so you'll have follicles at 22, 23, 24 millimeter, and then you got 18 millimeter follicles at bulk. And then if you trigger, your trigger is more likely to create more mature eggs. Now, if you're going for ovulation induction, it's a bit difficult, because I think what happens is follicles tend to go out of steam around 14, 15 millimeter. And that happens again in PCO patients and in poor responders. In PCO, it happens for a different reason. It happens for a reason because the LH is high, and progesterone becomes the key marker of key hormone that starts triggering premature ovulation. And in those cases, how do you go beyond it? You have to push the FSH higher, which means that your starting dose has been lower. Intervening then is not useful. In clomiphene and letrozole, I think you're in, it's a place where you have to abandon treatment, because if your follicle stops growing, it is on the process of being luteinized. You're not going to get any eggs, and that's the evidence that comes from IVF.
Thank you, Anil. We're just moving ahead. Before we go with Dr. Sharyu's lecture, I would like to request Dr. Sanjeev Khurd madam and Dr. Uma Wankhede madam to have the honor of lamp lighting and inaugurating the meeting for all of us. They're the senior most practitioners here. Dr. Uma Wankhede has been Dr. Sharyu's teacher as well. And Dr. Sanjeev Khurd, we have learned ourselves a lot from his connect and his humbleness. So thank you, sir.
Good morning, one and all. Before initiating my lecture, I want to thank my mentor, Dr. Sachin Kulkarni, for giving this beautiful opportunity on this platform. In ovarian region markers, we all are highly dependent on ovarian region markers when it comes to ovarian stimulation in IUI or IVF cycle. There is always an interplay between these ovarian markers, and as we have AMH, FSH, AFC, and age as an ovarian marker, the interplay between these ovarian markers, how we can apply it clinically and how holistically we approach the patient. So this is my agenda, which I would like to go through to making it simplify for all of you. So do you have nomogram for a specific nomogram for FSH and AMH? It's need for the hour in India to have this nomogram related to AMH and FSH. Richard Fleming beautifully explained through this paper how the follicle depletion and AMH expression is having different role when it comes from the birth till menopause. So I will take you to this graph. So I'm making you understand better. Okay. So from the birth till the time of menopause, there is always a continuous depletion of follicles. And this depletion of follicles from the birth till the time of puberty, the depletion rate is quite high till the time of puberty. So till the puberty, almost 75% of the follicle pool would have been declined. At the same time, when AMH from the childhood till the time of menopause, how it will reflect in our in the whole career of the female. So in AMH, till the time of puberty, AMH will be having variation. From puberty till 25 years of age, AMH keep rising. At the age of 25 years, AMH is high. And that AMH, the lady is having maximum reproductive potential at the age of 25 years. So I am telling a theory where there is a follicular depletion, which is going on from birth till the time of menopause. But AMH rises from puberty till 25 years. And after 25 years, it stops dropping. We have very limited information about AMH between 14 to 25 years. And this we can apply in our clinical practice while counseling the patient. Many of us are seeing young girls coming to us and for their puberty problems. And we are advising them a AMH test. And to our surprise, the AMH will be low normal. It could be 1.2 to 2. And where we tend to sensitize that lady, like, having low AMH, and you have to move ahead with your fertility as fast as possible. And you get, the marriage and everything you have to plan early. I'm taking this opportunity to convey you, this is not the way we should counsel, because the AMH rises from puberty till 25 years of age, because the primordial pool is getting expressed and the antral follicle is going to express AMH better. So the physiology, don't sensitize the patient when it comes to adolescent, the AMH, to make her more sensitized about her fertility potential. Then coming to the folliculogram, as we understand that from primordial follicle till the follicle becomes pre-ovulatory, there are many phases where the follicle has undergone. The AMH is expressed by secondary small antral follicles. And AFC, when we are doing a baseline scan for the AFC count, we calculate a follicle size between 2 to 9 millimeter. But follicle between size of 2 to 6 millimeter, these are small antral follicle, and they are actually expressing AMH. The follicle between size of 7 to 9 millimeter, some of them could be expressing AMH, some of them could be expressing, these are the atretic follicles. So when we have a scan, the sizes between 2 to 6 millimeter, these are the true expressing AMH ovarian reserve. Now coming to the physiology, as Dr. Sachin has already mentioned, that we have two phases, gonadotropin, independent growth of the follicles from primordial till it becomes antral follicle, and from antral follicle till it becomes ovulatory, it is gonadotropin dependent follicular growth. But let me prove the concept that when we are saying that it's a gonadotropin independent growth, it's actually not, because some amount of gonadotropin has to be there to push the primordial follicle into the antral follicle, and how the puberty changes will occur and the lady will be having normal function. So now I have made two confusions here. When I'm saying the AFC is depleting from age onwards, like from the birth till the time of puberty and hence onward, the AMH is increasing till the age of 25 years and it is dipping down. Why? There is a difference, like discordance between this follicle depletion and AMH expression. So this is a total physiological slide. I'll try to explain it in a very simple way. As I mentioned that by puberty, there is 75% of decline in the follicle. That is a continuous apoptosis process, which is going throughout the life. And the first pubertal change is adrenarche. Adrenarche precedes menarche. So the androgen expression inside the ovary will improve. And that androgen will be converted into estradiol under the effect of FSH. At that particular time, the FSH, the very small amount of FSH, along with the low E2 level and certain growth factors, which are specific to at that puberty level, all of these combined will proliferate the granulosa cells. As we understand, the primordial follicle is lined by a single layer of granulosa cells. So the amount of E2 generated is very less. And that will push the follicle. And the follicle now enter into the small antral follicle and antral follicle. And it will start expressing the AMH. And the increase in AMH expression, 2 to 6 millimeter follicles express AMH better. And as we understand that AMH acts as a gatekeeper, it's not allowing the FSH to act on the follicle. So as to make it more simplified, we have FSH in small amount, which is acting on the androgen, converting into E2. E2 being mitogenic hormone proliferates the granular cells growth and pushing the follicle from primordial to the antral follicle. And now the AMH role start getting expressed, and that is acting as a gatekeeper for FSH action. When it comes to gonadotropin dependent part of it, so that is from small antral follicle where FSH is on rise, and the aromatase is under the effect of FSH are converted into the androgen is getting converted into estrogen. With the effect of estrogen being a mitogenic hormone, it will proliferate the granular cell growth. And this E2 will express the more FSH receptor on the growing follicle along with LH receptor. When the follicle has achieved a certain level, the E2 is carrying the granular cell proliferation, and that is where the AMH expression goes down. So the follicle which is having least AMH expression will get selected. And that follicle, now the E2 and rising FSH will continue the follicle growth, and the follicle becomes pre-ovulatory. So the follicle grows, when the follicle grows beyond 8 millimeter, the AMH expression declines. After 8 millimeter, the dominant follicle which is getting selected is no more secreting AMH. Now coming to the age-wise distribution of AMH, at younger age, the primordial pool is larger and these follicles are not secreting AMH. So the AMH value express the functional ovarian reserve in young age group. In older age group, the primordial pool is already exhausted, and that is why many of the follicles are expressing AMH. So at later age, we can correlate the AMH value and that express true ovarian reserve. So AMH is a modulator of follicular growth, and it regulates the threshold of FSH sensitivity for the small growing follicles. In our clinical practice, we come across the discordance between AMH and AFC quite often. And then it's a difficult challenge how to stimulate such patients. So let me give an example herein, where we'll be having we are seeing two patients with same AFC on our baseline scan. Let's say AFC is 8 in both of these patients. But the follicle between 2 to 5 millimeter, they are truly expressing their AMH, and where we can correlate the AFC and AMH will be, there will be accordance between this AMH and AFC. When the follicle is becoming 6 to 9 millimeter, they could be atretic, no more secreting AMH, and 2 to 3 millimeter follicle, they are secreting AMH. So we are herd of follicle. So in this patient, though their AMH is lower side, we'll be having normal AFC count in the patient. How we can apply it clinically? Many times we see a patient who had come to us for second opinion and already taken stimulation outside 2-3 times. And when we are doing a scan, the AFC is normal. And when we are repeating AMH, the AMH could be low. And we'll be having always a question, like, why? And we sometimes we tend to repeat AMH because we are conveying the patient that the AFC is good. So I think you will be having good, better ovarian reserve. So those atretic follicles, which the last stimulation has carried forward, that you are actually seeing. So always measure the follicle between 2 to 5 millimeter when it comes to AFC. Obviously 6 to 8 also will express the AMH, but not into that amount. Most of them could be atretic. When it comes to controlled ovarian stimulation, which is a better predictor, whether it's AMH or whether it's AFC. So when we plot the AMH on x-axis and on y-axis ovarian response, we get bell-shaped curve. At low AMH, obviously there are less follicles and the ovarian response is going to be low. At the extreme, when there is high AMH, AMH acts like a gatekeeper and retards the follicular growth. It's not allowing the FSH action to happen. So at both extreme, the ovarian response is low. And we have to break the threshold in case of high AMH, then only the response will be high. Now the question is in between, where the arguments are in the discordancy of this AMH and AFC giving the ovarian response. So as we all aware that MERIT and MEGASET trial was published for agonists and antagonists, they analyzed between RFSH and HPHMG, which is better. So then retrospective analysis of this paper was being made. And what they found they were curious about, what is the relation between AMH and AFC to the ovarian response. So if at all you see it carefully, the AMH is in dark blue circle and AFC in the triangle. So there is linear response of AMH to the ovarian stimulation. But when it comes to AFC, this is dispersed widely. So in agonist cycle or so, in antagonist cycle, AMH is a better predictor than AFC when it comes to a response in the ovarian stimulation. In our common practice, we are seeing a patient at advanced maternal age. And more than 35 years, many of these patients will be having short menstrual cycle. If you take a proper history, they will be having cycles of 21 days or 22 days. Why in such patients? Because the primordial pool has already exhausted. And the luteofollicular phase, as we know, it starts 1 or 2 days prior to the menses. In this patient, it starts early. Almost a week prior, the luteofollicular transition will start. So when the patient will be having menses and we are doing a day 2 baseline scan, for our surprise, there could be a follicle between 12 to 14 millimeter. And that 12 to 14 millimeter, the FSH has pushed from 7 days prior from the menses till this time. That is why we are not seeing a small follicle, we are seeing a larger follicle. This larger follicle is secreting more amount of estrogen and inhibin. So by the time we are doing day 2 scan, the inhibin would have been come in action, and that high inhibin retards the growth of, retards the level of FSH. So when we are doing day 2 FSH level, in such scenario, it is giving a false impression. So the patient is having low AMH, we expect FSH to be high. But when you are doing day 2, when the follicle size is more than 12 to 14 millimeter, the inhibin rise will take FSH normal and will give a false impression that there is a low AMH, but FSH is still normal. So in such patients, when it comes to clinical practice and you are doing a day 2 scan, you always tend to look the ovary. When the follicle of 12 to 14 millimeter is there, there is no point doing day 2 FSH. In such patients, it's better to advise FSH prior to the menses. So, as we understand that we all know that AMH doesn't significantly vary throughout the menstrual cycle. And that is why when it comes to the patient blood test, we always advise AMH at any point of cycle. But let me go through, take you through this paper where it's beautifully explained that in younger age group, the AMH variation is quite significant compared to the aging group. In young people, what exactly happens? As I mentioned, that the primordial follicle is going till antral and then it starts secreting more amount of AMH. The follicle more than 8 millimeter, when it's become dominant, it will stop secreting AMH. And other follicles will be atretic, so they are also not secreting AMH. So initially in follicular phase, you will find high AMH. But as it is going towards the ovulation, in luteal phase, the AMH expression goes down. And when we are measuring AMH, there will be a decline in AMH such patient. So why not do AMH on day 2 level as we are advising our FSH and LH level on the same day rather than doing it later? Many of us are outsourcing AMH sample. We are collecting in whole blood sample in gold top vacuumators with gel separator. And during the transport, if you are not processed that sample, it will increase the AMH. So if at all you are outsourcing, please centrifuge the sample and maintain the temperature of 4 degrees centigrade till the time it becomes, it will reach to the level of analysis. So there is increase in 20 hours is of 15%, but later 31% increase is noted with long storage. So centrifuge it, maintain the temperature, and then the transport will happen. Now, there will be always a question like whether the AMH predicts natural pregnancy. So young lady who is ovulatory, AMH is not a fertility marker. So there are various literature we went through, and as this study has given information that when they followed the lady for next 6 menstrual cycle, how many of them got pregnant. So they found there is no difference from 1.4 AMH to 5.6 AMH. when it comes to young ovulatory lady. So if it is she is a young girl with no ovulation, please don't advise AMH and endorse upon going for the fertility treatment. Herein, the patient who are having high AMH, PCOS patient, they are more candidate of taking treatment because the ovulation is not occurring in those patients. But when it comes to a normal young ovulatory lady, the AMH is not a fertility test. Same, the eager study, which was done in aspirin, with the aspirin in pregnancy patients, they have analyzed that AMH less than 1 nanogram and more than 3.5 nanogram. The fecundity odds ratio was 1.04, crossing the line of unity, and so there is no difference in the pregnancy rate, even if the AMH is low or it's in the normal range. So it does not predict the natural pregnancy. As long as women are ovulatory, ovarian reserve has little impact on the natural pregnancy. For women without infertility, AMH is not a fertility test. Now, AMH is a quantitative marker, and FSH and age, these are qualitative markers. Recently, Buratni in this role of FSH and AMH when it comes to age, beautifully explained that FSH performs better at age less than 35 years due to oocyte quality. And AMH is a better at more than 35 years of age, since it reflects the oocyte yield. Let me explain in a clinical scenario. You are having a patient of less than 35 years with normal AMH, or let's say low AMH, but the FSH is normal. What this FSH is telling us, that the inhibin is high and the granulosa cells are not sensitive for the proliferation. So FSH is a qualitative marker. So in patients who is young with low AMH and normal FSH, still the oocyte quality will be good. In patients where the low AMH is there and FSH is on the rising trend, the oocyte quality is definitely affected. That will affect our oocyte yield. This paper, like, the AMH and AFC, out of that, which is a better predictor of live birth rate when it comes to different scenarios. So they had grouped into 4, and good prognosis patient, they have taken normal AMH and low FSH. Poor prognosis, where AMH is low and even FSH is high. Reassuring AMH, where AMH is normal, but FSH is on the rising trend. And reassuring FSH, where FSH is normal, but AMH is low. Out of this, obviously poor prognosis, we can actually predict the response. AMH is lower and FSH is higher. So everything is damaged. And the live birth rate is only 13.1% in such group. In good prognosis patient is 29.3%. When it comes between AMH and FSH, when you're having low AMH and and the FSH is normal, that time it's a 15.6% of live birth rate. What exactly it tells us, that the AMH is a better predictor of live birth rate than FSH. So you have a patient with normal AMH but high FSH, still the oocyte yield will be high. And that is not the case where the low AMH is there and the FSH is normal. This is the same graph explaining in a graphical way. So in our clinical practice, how we can apply this knowledge of ovarian markers? So many times we get a patient where there is a normal AMH and could be between 2 to 4 nanogram, but to give an example. And there is FSH between 8 to 10. As we understand, 8 to 10 is a normal FSH value, but it is upper level of normal. So some of these patients could have FSH receptor polymorphism. And though the Poseidon 1 is a retrospective analysis, in these patients where the FSH is upper normal, we can actually subject them in Poseidon 1 group and predict the ovarian response. In patients with normal AMH and normal FSH, it's a routine story. Obviously, our ovarian response is going to be great in such patients. Low AMH and high FSH, these patients, as it depicts the oocyte quality, they may need oocyte donor gametes. And low AMH and normal FSH, low oocyte yield, and they may need multiple stimulation cycle, because these are the patients, they'll be of younger age and the oocyte quality is not affected. But to have that oocyte yield, the patient has to go multiple stimulations. Now, high AMH is nothing but PCOS. And let me go through the physiology of PCOS. So when we are doing a scan in PCOS patient, we often get two patterns on the scan. One is a rosary pattern where the follicles are arranged in necklace fashion, and one is a diffuse pattern where the follicles are dispersed inside the ovary. Both these pattern reflects hyperandrogenemia, but causes of a hyperandrogenemia in both cases are different. So in rosary pattern, there is high androgen level because of high AMH and high LH. This patient could be of low BMI, but the genetic basis is is more predisposed for rosary pattern compared to diffuse pattern. In diffuse pattern, these patients are insulin resistant. So FSH and LH could be normal. These patients tend to have high BMI, and they have the lifestyle modification. The lifestyle changes will put the make the BMI higher, and that is how the insulin resistance will build up. And these patients we are commonly seen in our common practice. And what exactly the clinical scenario we can match up with? In rosary pattern, these are like a high LH and high AMH. It's very difficult to stimulate that rosary pattern ovary, and they need high FSH dose when it comes to ovarian stimulation. When it comes to diffuse pattern, it's high insulin resistance patient. So in those patients, the lifestyle modification, giving metformin therapy will correct this disorder. And in this patient, if at all we are advising, that makes that patient ovulatory. So our counseling will be different in both of these patterns. So when it comes to a PCOS, we will be having stockpiling of the follicles. This stockpiling of follicles, as we understand, in PCOS lady, the high androgen and high LH retards the growth of follicle. So there is a slow growth of follicle from primordial to antral, and again it will act as a gatekeeper and not allowing the FSH action. And less GDF9 factor that also slows the growth of primary follicles. And AMH also prevents atresia of prenatal follicles, and that is why the stockpiling will occur. Let me simplify this. So we have a follicle of 2 to 4 millimeter size and which wants to grow. The AMH is having negative action on those follicles. Some of these follicles will escape under the effect of FSH and they will grow up to 6 to 8 millimeter, and some of them still grow further and becomes more than 8 millimeter. Now the fate of this 6 to 8 millimeter and more than 8 millimeter, because it has not reached the FSH threshold, they are not going further. But AMH having inhibitory action on this follicle, and it's act like an anti-apoptotic and not allowing atresia of those follicles. So we have primordial pull and we have like antral follicles, as well as we have the follicles which are not having potential to grow. So that accumulates many of the follicle. That is nothing but the stockpiling of the follicles in PCOS patient. So we all are aware about the PCOS phenotype, and from the Rotterdam criteria, hyperandrogenism, ovulation disorder, and PCO morphology. With these three factors, there are PCOS phenotype. When it comes to the PCOS phenotype, the adolescent PCOS and correlating with the phenotypes will matter much, because the lifestyle modification we can do at that level. But when it comes to ovarian stimulation, PCO phenotype is not going to matter. It's not like we have to treat that patient as a PCOS only. We can't modify in them. In PCOS, we find difficulty in stimulation, which is determined by high AMH, high LH. The patient will be obese, and obviously age is one of the factors. So I'm sure that many of you are come across where you are expecting that this lady is PCOS, she is having a high AMH, and I'm starting her stimulation. You are expecting that she will respond better. But in today's era, the poor response to this stimulation and low oocyte yield in PCOS is more common problem than OHSS. We were all the time thinking of preventing OHSS when it comes to PCOS, but now we are getting more of the client because we are not breaking that FSH threshold, and that is why the poor oocyte yield will be there. Dr. Goody will elaborate on this topic more. Then there are scenarios whether the AMH can vary throughout the life. Well said and done with all the physiology. Yes, it could be. So 20.8% variation in AMH level seen in younger girl, and factors could be simple stress, they are on some antibiotics, they are on some steroid therapy for some reason, and that will variate the AMH and AFC count. 14 to 55% decrease in AMH will be observed in patients who are taking contraceptive pills for more than 1 year. So when the patient is on OC pills, after the stopping of OC pills, you give a gap and then do AMH level rather than when the patient is on OC pills. Patients with high BMI, it's a different theory where the high leptin will decrease the AMH level. Vitamin D may increase the AMH level, and the physiology behind it, vitamin D will decrease the insulin resistance, and then the granular cell proliferation will be better, and that is how the AMH will getting expressed and the AMH will be higher. And as we all aware that in long agonist suppression, as like in contraceptive pills also, we are actually downregulating the hypothalamo-pituitary axis. So we're not allowing the follicle the exposure of gonadotropins, and that is why there is low AMH in this patient. Now coming to a different scenario, like as we know that endometriosis will be many times it's associated with low ovarian reserve. So patient with endometriosis and a normal ovulatory patient, the AMH decline is faster in endometriosis patient compared to a normal ovulatory patient. When it comes to a surgery for endometriosis, when the cystectomy is done, so what happens? We are actually removing the cortex and we are pruning that AMH to decline. So but what happens in the ovary? The ovary will have good number of primordial follicles, which will grow and restore the AMH to some degree. So immediately after the surgery, if you are repeating the AMH, it could be low. But when you are repeating the AMH later, it will be not very high, but it will be more than whatever we have immediately done after the surgery. So the primordial follicle takes almost 180 days to be pre-ovulatory, and persistent decrease in AMH at the 1 year after surgery is observed in patients where maximum blood flow destruction has been occurred during the surgery, and there are destructions of cohort of primordial follicles. This was a previous concept which I just mentioned, that post-surgery immediate decline of AMH will be there, but after some times the AMH will recover. But the recent meta-analysis is not giving the same conclusion. So this meta-analysis giving a conclusion that after post-surgery, there is always decline in AMH, whether it's less, whether you are doing it immediately, whether you are doing it, after 6 months. Obviously, we are harming the primordial pool, so the AMH will be always on the decline trend. Now, the interesting fact, which will help you about the counseling. Many times we come across a patient with endometrioma. She'll be having large endometrioma. Still, the AMH could be normal or higher side. So when, this paper conveys this beautifully, that excessive AMH is released in circulation due to inflammation and neoangiogenesis, which is because of the endometrioma. And these endometrioma are toxic to primordial follicle and draw them to exit their dormant stage and grow up. So that is why falsely the AMH is getting expressed. So large endometrioma, we may find the patient is having normal AMH and high AMH. How we can apply it clinically? That in clinical practice, the patients of endometrioma, obviously we are making them sensitized that after the surgery, the AMH will fall, but they will correlate with their previous AMH value. So it's better to make them understand, though you're having large endometrioma and normal or high AMH, after surgery, the decline will be faster, and this is the theory behind it. Now, in endometriosis, we get patients with endometriotic deposits and we get patients with endometrioma. Why this different in physiology is there? So AMH is expressed in the endometriotic cells, and high AMH is noted in endometriotic cells, which may be responsible for more fibrosis. And these will be the patients who will be having adhesions, endometriotic deposits will be there. In other scenario, when there is a reduced AMH in the endometriotic cell, they will allow the endometrioma to go faster because it is having inhibitory effect on the endometrium. So the endometria grows faster in these patients. So science proposed both theories. Hence, we need to replicate these observations in our clinical scenario. Now, coming to hypogonadotropic hypogonadism, we all aware in hypogonadotropic hypogonadic patient, the FSH, LH, E2, and they will be having low AMH. If it is of congenital origin, infantile uterus is a common presentation. It could be iatrogenic in later stages of life, where the uterus size is normal and we are getting low gonadotropin levels along with low E2 and FSH. So typically we come across with two scenarios in hypoc. One is low FSH, LH, AMH is on the lower side, and where FSH and LH on the lower side, but could be having normal or high AMH. So why I'm endorsing this point about hypoc is many of us, while counseling when it comes to hypoc patient, suggesting and advising them to go for donor therapy. These people have never undergone the exposure of gonadotropins being hypoc. So because of that, as I mentioned, that initial phase is gonadotropin regulated, and this patient had not gone through that phase. So the primordial pool is not getting expressed and the AMH is not getting secreted, and that is why they will present to hypoc. What can we do about these patients? So with 2 cycles of HMG, treatment of hypoc, the FSH and AMH levels goes up. We have to counsel the patient that it is a treatment where your patients will be tested. We have to make so many dose adjustment because we want that primordial pool to get expressed, and that is how we can stimulate you in a better way, and you can have child with your own genetic potential. So hypoc with low AMH needs continuous HMG stimulation to increase the follicles and AMH, and egg donation should not be option for such patients. Many of us are practicing oncofertility, and as we know that chemotherapy in oncofertility decrease the AMH level. And there are many confounders of ovarian reserve depletion in chemotherapy. First is age. Obviously, the younger age, if you are giving chemotherapy, the decline of AMH is not that faster. In pre-treatment, either with agonists or OC pills, the decline of AMH is not that faster. When it comes to a monotherapy or combination therapy, obviously monotherapy, less decline of AMH will be there rather than combination chemotherapy. And what matters the most is about the individual susceptibility. So that individual susceptibility to that chemotherapy will actually a predictor for AMH decline in such patients. So the balance of apoptotic and non-apoptotic pathway will determine the fall in the AMH when it comes to a chemotherapy or oncofertility patients. Well, thank you for the patient hearing.
Any questions? This is a slight change. Yeah, yes, sir. From the kits point of view, there has been an evolution in the kits that we started with DSL, and then we went to Beckman Coulter 1 assay, and then Ansh Laboratory, the Indian make, introduced the AMH1 and AMH2 analysis better, and they fractionated it all the way to 0.003. And so we had better, and that was taken over by Beckman Coulter 2, and that's what we are using as a standard practice. But now Roche assays are available, and I think, Anil, you people have shifted to the Roche AMH assays, because what data we have had on Beckman-Coulter 2, will it replicate on the Roche? Similarly, we really don't know about, and we'll be awaiting the data because they have stored the cryopreserved serums are still there, and so will come out. Those data will be published soon. But anyway, we are going ahead with Beckman-Coulter 2 in India. Most of us are going with Beckman-Coulter 2 only. Now, yeah, we just accept that's the standard of care as it exists today in India. Now, coming to this question that which patients of polycystic ovary will have low AMH or AMH less than 2. Firstly, we don't have a great cutoff. Like all the studies which have been done on polycystic ovaries or high responders. Rather, if you go through even the guidelines for ovarian stimulation published by ESHRE, there are only 2 studies on PCOS in the whole guideline. Because when you publish a guideline, you make big studies. In a big study, you come out of the real world scenarios. The extremes are excluded. So most of the studies have excluded the extremes. Even the megaset studies, it is high responders. We agree that most of them are high PCOS. So megaset HR trial, which is published, which had a cutoff of 5.5 in their high responder group. But otherwise, the earlier cutoffs have been 3.5. You could have this that because the PCOS diagnosis and AMH, that's one of the reasons why AMH is not a diagnostic criteria of polycystic ovary. It's a surrogate marker of polycystic ovary in an adolescent age group alone. The diagnostic criteria of Rotterdam or even the Barcelona conference, they don't utter AMH as a word there. AMH is more related to the response part of the story. So one can have a patient who has a high AFC, the whole thing's going into a PCO pattern, but the AMH keeping a little low. That could be there. Now, whether it is to do with the receptor polymorphism, I really don't know.
I'll say something controversial. I think it's probably a useless test. I'll give my reasons for that. I'll go on to an ancient time. See, in ancient Puranas, what happens is Mother Earth goes to God and asks and says, we are in trouble. So about 50 years ago, the gynecologist went to God and said, we are in trouble. We can no longer scare patients. And we can no longer tell patients that they're getting old. Help us. So God says, I'll give you a test. We'll call it the AMH test. So what does the AMH test do? The AMH test scares women. That's all it does. It allows doctors to push patients into treatment. So you look at an AMH test and say, your AMH is low. What does that mean? Nothing. It means absolutely nothing. Your AMH is high, and that means absolutely nothing. So what is an AMH? An AMH is also not an aging tool. An AMH is not a quality tool. An AMH only measures a certain number of follicles. And these are the preantral follicles. It doesn't measure the primordial follicles. It doesn't measure the large antral follicles. So what you look at instead, AMH tells you about the decline in numbers. And women age differently. So what you're looking at a test and you're giving the wrong information. Look at the test and see its value. So let's say the AMH is 2. Look at the age. And women age differently. How do we know that? There'll be some women who will age in their early 30s. Some women age in their early 20s. Some women age in their late 30s. We don't know that. So we are using, to a large extent, data which is Caucasian and putting it into the Indian zone. Now, Indian women are different. And I've always said that Hollywood is different from Bollywood. Bollywood is prettier, there's no doubt about it. Now, what we have to know is that the AMH in Indian women takes a faster decline. When I say, I don't say it declines at 33, I think it starts declining at 26, 27. And we see that in second generation Indians, we see that in first generation Indians in the United Kingdom. That's because there's a steady decline. But what is key in this is trying to see the antral follicles. So what I'll tell women is, I'll say your AMH is like your savings account and your antral follicle is like your current account. Now, what will tell you about your current fertility is nothing. Your age will tell you. And if you have a look at the recent data that has come out, what is the mean age of people in Maharashtra? Any guesses? 32 years. which means Maharashtra is an aging population. Same with the South. There are more advanced professions, people are more advanced. So you're going to see aging that's occurring. And we are looking at AMH and giving them the wrong answer. The question is, you have to be very provocative and said, either freeze eggs or get pregnant. That AMH tool is a resistance tool. And its AMH role is only in ovarian induction and ovarian stimulation. Outside it, it is very much a worthless test. So don't use it to give, I'll say, diktats and tell women that you've got a low reserve. It doesn't tell us anything. It tells us more about a specific part of your ovary, and that's all it tells you. And it helps us to plan treatments. So in the role of IVF, there's a role. In nature, I don't think so.
Yeah, that's why those studies did tell that even the spontaneous pregnancy rate, whether in a low AMH group and this doesn't differ. Rather, it is the high AMH group which has less spontaneous pregnancies compared to the low AMH group. So when it comes to assessment of ovarian reserve, the take home would be look holistically. Don't look at just AMH, AFC singularly. Have a holistic approach, and that would be better predictor. Thank you so much. Thank you.
Is this what is this? Pointer. Ah, fancy pointer. It's nice to be back face to face. It took us 3 years in which I think all of us have been fed up with lectures online and conference online. I think it's taken the toll of the same people. You've got to peek into people's houses, into their dresses, or the lack of dress sense. What do conferences do? Conferences bring the best of dress sense. And what do online meetings do? They get the worst of dress sense. And we've been through 3 years of a bad treat to the eyes. So I think it's good to be back. And I think eventually what Aishwarya also showed is that hybrid meetings may probably be the way of the future, where you could attend various meetings face to face and also online. Now, it's not letrozole in IVF. I said I'll do a brief talk on ovulation induction, because what do large number of people need? Not IVF, they need ovulation induction. So when people come to your clinic, it's good to push them towards IVF. What fetches me more money is IVF. And what gives me better results is IVF. But what patients often need to a large extent is ovulation induction. So let's look towards PCOS, and that's probably our main area of debate. 70% of irregular periods, 70% of anovulatory infertility is PCOS. So a large number of women who will come with anovulation will have infertility which is due to PCOS. So the question is, what are we treating? And I'll always say, if you're treating PCOS, think about what you're treating. So are you treating ovulatory dysfunction? Is it with insulin resistance or without insulin resistance? And that is key to it. So if there is ovulatory dysfunction with insulin resistance, then that is going to be more difficult. And that's where you need your thinking. But if it's ovulatory dysfunction with little insulin resistance, these ovaries tend to do better. So first and foremost is lose some weight, and that's for obese PCOS. You don't tell that to lean PCOS. It's a bit of a waste of time if you tell that to lean PCOS. And what happens if you tell a lean PCOS to lose weight and you push her into a hypoc condition? And it happens. You see more and more women. And that's because we trained when it was good for women to have a bit of fat. Now, a large number of young girls will try to go on to size 0 because that seems to be the definition of pretty. And what basically happens is, at a critical point, when young girls around 13, 14, 15, when they are going to attain menarche, drop their weight, they're more likely to switch off the pituitary gland also. And so you'll start seeing a combination of PCOS with hypo as time goes by. So, and this advice is generally for obese. So years ago, we came across clomiphene, and I call it the rebirth of clomiphene. And the reason is that we got rid of clomiphene, and then we said clomiphene is quite useless. And then clomiphene is slowly making a comeback, mainly in IVF. And it is older than me. Now, what is the plus point of clomiphene? And now I want you to remember this because I'll be using clomiphene for poor responders. And you have to use a very basic concept of clomiphene. Clomiphene is a phenomenal drug. And in simple terms, it fools the pituitary. There's no decline of estrogen. It blocks the negative FSH pathway. So the pituitary thinks, hang on, there is no estrogen because estrogen receptors are depleted. And the pituitary thinks, hang on, there is no estrogen there. I need to increase my FSH. So it increases the FSH. But the other plus point is that there's no control over it because the negative feedback mechanism is switched off. So what happens in nature? In nature, estrogen rises. The pituitary realizes estrogen is rising. The FSH starts dropping. And that's how we get a monofollicular growth. So what happens with clomiphene is that gets switched off. So the pituitary just does not realize that it has to stop secreting FSH. So it continuously gives FSH. And it gives FSH to a small extent. And in IVF, it becomes a brilliant drug because it's cheap, but it also is like a test. It's like a test to say, come on, run. And I'll see if you can complete the race. And that's how we'll use it for IVF. So it's a non-steroidal compound. It resembles estrogen in blocking hypothalamic receptors, signals a lack of estrogen, and it induces pulses of GnRH. And thus it gives a rise and a sustained rise of FSH. So let's go back to the basics. When you started, day 2, day 3, day 4, day 5, doesn't make a damn difference. Start it whenever you want, as long as there's no lead follicle. And then you started at 50 milligram, and then you keep increasing it in subsequent cycles. And why was the old concept that you should not give more than 150? Because beyond 150, its effects are quite less. It's not that effective. And I agree with that. And I think my dose is 100 if I ever give it. And that's it. So it doesn't matter when you started. You started day 2 to day 6. So you started from day 5 to day 9. And both of these are very much similar in the types of results. So that is how, if it's easier to explain that way. And then when do you do an ultrasound scan? I usually say I don't scan on day 7. I keep putting that, but the first scan is generally on day 10. And what it will give you an idea is a day 7 scan often does not give you a very good idea. It ends up making you more trigger happy and getting you to intervene. Because if you don't see a response, you'll say, see, there's no response. So day 10, by which time you will get an idea whether there is going to be a response with clomiphene or there's not going to be a response with clomiphene, or you need to intervene. And we'll talk of those interventions a bit later. So how long do you give clomiphene? We think beyond 6 cycles, it's very much useless. And I tend to say no more than 3 cycles because evidence suggests that the maximum number of pregnancies would occur in the first 3 rounds of treatment. So I'll say have less patience, try to start upgrading treatments if that doesn't work. And this was based on a very large study done by Professor Homburg, where they showed a reasonably good ovulation rate, pregnancy rates were very good, and miscarriage rates were very, very similar. So how do you split clomiphene? FE or PHENE, and both are correct. Do you give HCG? And again, there's a controversy of how good it is. Do you monitor cycles with ultrasound? You should, because this is private practice. And if you don't monitor, then you don't earn any money. So I think it's good to do it. And what is the starting dose? And we know when to stop it. And do you use any adjuvants? So should you give HCG? Do we give HCG? The answer is yes. Do I give HCG? The answer is yes. Why? Because it makes my life simple. Secondly, it allows people to indicate when they should try for sexual intercourse. And why is that important? It's because who has the least sexual intercourse? Women and men who are trying for a baby. Simple. Isn't that very odd? Is because it causes stress. And if you look at the recent publication in Fertility, and it's done on Chinese couples, and it's a phenomenal paper. And what they did is they looked at frequency of sexual intercourse in infertile population. And they saw that young couples were having a lower rate of having sexual intercourse. And that's because it causes stress. So what does the trigger do? The trigger pinpoints and says, hang on, stop fighting, stop quarreling over cricket and movies, and have sex on 3 days. And that probably helps patients. It helps us because, who wants to keep scanning again and again? But what does evidence suggest? And we don't know the answer. And from a success point of view, we don't know whether HCG is helpful or not. So why does clomiphene fail? And that is something which is very important in terms of its success rate. And it fails because one is, there are a third of patients, that's 30% of patients, who will have ovulation, but no conception. And that's because one is, it's an anti-estrogen effect. It reduces cervical mucus, and it has an impact on endometrium. And most importantly, clomiphene gives high levels of LH, because that's how the pituitary responds. Pituitary secretes two hormones, so it will give you a persistent high level of LH. And that again has its own problems. Do you use it for unexplained infertility? And we all do it. It's not that we don't do it. We do it because we say the logic is, let's give you more follicles, let's get more eggs, and that will give you a better chance of success. But if you look at all the evidence of clomiphene in unexplained fertility, the results are quite poor. And giving it in nature is very similar to asking them to do what they want. And it's not recommended in routine unexplained infertility. So why does, again, clomiphene have a negative impact on the endometrium? There seems to be an endometrial thinning that occurs in between 15 and 50% of cases. It causes downregulation. And we think that if the endometrium is less than 7 millimeter, pregnancies do not occur. It is not dose related. So if you see it, stop giving clomiphene. It is repetitive even at small doses, and don't use it. So what do you see? You see endometrium, something like that. It takes a different echogenic appearance. It starts looking slightly whitish, and these endometriums don't achieve a pregnancy. What you want is, you want a trilaminar and thin endometrium, which shows proliferation. And that is a sign that there's been no negative impact on the endometrium. So that's a general pictures of how it is. You also see in PCOS women, a small increase of estrogen leads to a massive increase in the endometrium. And what we don't know is, are these women who are going to go into hyperplasia in later life? And we don't know that. We just don't have that amount of information. So why is there no response to clomiphene? And we think there's no response because one is there are more androgens, the higher BMI, there's more LH, there's more insulin, and women gets older. So I'll come back to, I call it the fat goody triangle. You must have seen this. And I think, years ago, I was in my dreams, and then God came down and said that I'll give you a tool which will help me to understand how to look at events. So it came of the triangle. Now, what do I see in this triangle? And I'll say it's good to use it because it gives you an idea of what are you facing. At the end, when we do clinical work, what do we want to tell the patient? We want to tell the patient that is it going to be an easy stimulation? Are we going to help you easily? Or it's better to warn the patient and say, hang on, things are going to get difficult. We may require more intervention. And I think it is good to have in front of you the tools which will help you. So there's some PCOS that you can treat very easily. So what is the first sign that there's no insulin resistance? It is regular periods. PCOS who have a 28 to 34-day period, slightly varying, have very little insulin resistance. Those are the patients who will likely to get pregnant on oral agents, where the ovary will respond. You have very long irregular periods. That is insulin resistance again. So that's the place where you would think of intervention with insulin sensitizers, with clomiphene or letrozole, and that's where are going to be difficult. So how do you know that? You know that because you've got a PCOS that has an AMH, which is more, it's picomole. So you divide it by 7, isn't it? I think so. And so you got an average or AMH, nothing indicative of PCOS. You got larger follicles, follicles which are 5 to 6 millimeter. The larger the follicles basically means that AMH, they have come outside the inhibitory power of AMH. AMH holds down follicles. So if you see slightly larger follicles, they're more easy to stimulate. And these will respond much better. But then you've got large ovaries, kissing ovaries, a huge antral follicle count, packed of follicles. These cases are going to be very difficult to stimulate. And believe me, even IVF gets awfully difficult in these cases. So here you have an idea and you say, well, this is going to be a difficult stimulation. So again, what things should you worry about is irregular periods, because as I said, there is ovulatory dysfunction and AMH, antral follicle count, tell you about ovulatory dysfunction. They don't tell you much about insulin resistance. What tells you about insulin resistance? Your irregular periods, the first indicator of insulin resistance, hirsutism, obesity. These are indicators of insulin resistance. So if you see these, you're going to know that your stimulation is going to get difficult. So again, my job in, see, I'm not a very brilliant person. I realized that in my 30s. I realized that I could not do complex things. I could get people to do complex things. So my way of working was always employ people cleverer than you, so that it helps your life to be easy. And that's how I ran my NHS unit. Now, what you want to say is you want to see if your LH is normal, if your ovarian volume is less than 10 cc, if your AMH is less than 40 pmol, and if you've got follicles between 15 and 20, these are quite easy to stimulate. They give you your best results in IVF. If you have a huge number of follicles, that's a worry. But again, if you have multicystic ovaries and you have an AMH that is slightly lower, you may be missing hypothalamic amenorrhea. It's not hypo only. Hypothalamic amenorrhea there's some amount of LH that is still flowing in the system and FSH, so you see multicystic ovaries. So how do you improve results with clomiphene? You decrease weight loss, you monitor for anti-estrogenic effects, and if you see anti-estrogenic effects, stop the treatment. Possible adjuvants, you can give HCG. Again, giving estrogen makes you feel better. It's quite useless in a thin endometrium. So if you do it, you have to be very open with yourself and say that I feel better and I'm doing it because it will make me sleep better, but it is quite useless. Do you give dexamethasone? I'll say don't, because you have to give it long term. Does it reduce insulin resistance? The answer is yes, it does. But it's a very dangerous way of trying to complicate matters. And finally, we come to our favorite subject, that is metformin. Steroids, again, 0.5 milligrams suppresses adrenal androgen production. Don't use it. My advice is please don't use it. You will end up creating a lot of complications. You use it when there is combined with adrenal hyperplasia. And your endocrinologist will come and tell you that she may benefit from using a small amount of clomiphene. So we come to metformin. When do you use metformin? Simple question. What are you treating? Again, I'll say, what are you treating? And what does metformin treat? It treats high insulin levels. So if you've got regular cycles, giving metformin is useless. If you've got mildly irregular cycles, giving it is useless. So don't use it. But if you've got very irregular cycles, then something worth doing it. Now, I think one of the most brilliant researchers is somebody called Richard Legro. And the reason why he's brilliant is he answers many clinical queries. The researchers do a lot of hard work and they put in a lot of hard work. This guy has a special place. So he was the first person to do a trial on metformin. And he looked at metformin and placebo, clomiphene and metformin. And he said, metformin is useless. And that's it. And then started this entire debate that metformin is useless. But again, next time you decide to go for a movie, remember which movie you go for. Hollywood is different from Bollywood. Not that Bollywood is doing any better now. I think it's now we'll have to say, I don't know what they call South Indian movies. Is it Tollywood? So now Tollywood is doing better. So let's change it and say Tollywood is now prettier than Bollywood. Please don't start. I think as much as Richard Legro was good, it was where was his research? His research was based on in Northern America, where women are large, where their PCOS is different, where their phenotype is different. Now you have to believe that Indian women have a different phenotype. And Indian women tend to, I think, benefit from metformin. What do you think, Sachin? Do you think Indian women benefit from metformin? No, he doesn't agree, but I have a feeling it works. And so if you use metformin with clomiphene, again, it seems to give a better results. And again, these were in clomiphene resistant cases. When used as, if you look at the recent evidence, when it used as a combination with other agents as first line, does metformin increase pregnancy rates? And it seems that adding metformin does improve ovulation, but looking at all the evidence, it did not seem to increase pregnancy rates. And there was only one study which said give metformin for 3 months. Does a combination of metformin or clomiphene improve ovulation, clinical pregnancy rates, or live birth rates in a subset of clomiphene resistant patients? And the answer is it does. So again, what is it treating? I think in a significant proportion of women who have insulin resistance, that's the only place where who have irregular periods, you can add metformin along with your clomiphene and letrozole. And I think that helps you to save time. It helps you to give a final trial with ovulation agents. So what challenges do you see? And singularly, you see these challenges in clomiphene. And you see so many questions coming up on this. And follicle growth stops at 14 millimeter. And I call 14 millimeter the mark where LH and FSH start talking to each other and switching. So if you, and it's like the pass mark, the 10 millimeter is to get into the exams. But the 14 millimeter is a pass mark. If your follicles often shudder at 14 millimeters. And if you start seeing that, it basically means there's less FSH. It means that you have not been able to, you do two things in ovarian stimulation, ovulation induction. Number one, you break the threshold. And what's the threshold? The threshold is crossing the 10 millimeter mark. Is you push follicles where they can be responsive to FSH. And that is breaking the threshold, making them ready to be pushed ahead with FSH. Second part, what happens in nature is dominance. How do follicles grow? They grow because of dominance with FSH gives you. So as soon as that dominance stops, why does it stop? That means you've run out of steam. And what is steam? And that is FSH. So the FSH stops and the ovary does not go. So I'm a great lover of the folliculogram. And then how does the folliculogram work? It shows you an axis of days and it tells you the size of follicle. And you see a follicle at 14 millimeter. And then you scan again and it's at 15 millimeter. And then you say, what do we do? And I think at this stage, it's very much gone. But what it gives you a learning, and the learning it gives you is it says that at this stage, that's a slow recruitment of follicle. So if you wanted your intervention, it could have probably been here. Now, all of us want to roll back our past. Who doesn't want to roll back their past and go back 10 years or 15 years? In the same way, you would love to roll back and say, I know what happened. I should have added some gonadotrophins, or I should have done something different. But next cycle, what would you do? Next cycle is probably intervene earlier with gonadotrophins. So that will give you an idea around day 10 how to intervene. The other question is, can clomiphene be continued longer? And this is the controversial part. And I want you to go back, there are no fixed protocols in general in life. There are what do protocols do? Protocols give you an idea of how do you follow. But at the end, what you need to do is you need to pick up all this data, what you learn, and say, how can I improve my practice? And it's a trial and error. You need to push your clinical practice using drugs slightly differently. So what you can do is you can say, well, if you continue giving clomiphene or you re-add clomiphene, what happens? The FSH rises again. Why? Because it gives you a sustained rise of FSH. So it rises mildly and it gives you a slightly more FSH. You can do that. Or you can add gonadotropins, but you can only continue clomiphene and gonadotropins if the endometrium is good. If endometrium is poor, clomiphene is not the drug to use and you should stop using it. So we come across something known as a stair-step protocol. And where do I use it? I use it mainly if I've started clomiphene or I've started letrozole, and by day 10, I have not seen a response. Why can you use it? You use it because clomiphene has a long half-life. 85% of the drug is excreted after 7 days of stopping, and the saturations can last up till 6 weeks. And there seems to be a cumulative aspect of the drug. So in the stair-step protocol, what did they do? And they decided that you give 50 to 150 from day 2 to day 6. If there's no response, next dose go higher. Or you give clomiphene for 5 days, reassess on day 7. If there's no response, you add a higher dose of clomiphene and rescan after 7 days, which means you go one step up and you keep doing that. And what they noticed is in a stair-step protocol, you saw more follicles, you saw a better ovulation, and you saw the endometrium decreasing, and it seems to work. Where do you use it again? You use it again to salvage a treatment. You to try and intervene in a treatment because you've already started a patient. Patient comes to you, you've given a clomiphene, or let's say you've given a letrozole, and day 10, there's no growth. And rather than saying, let's start gonadotropins, because that discussion starts, she'll say, I can't afford gonadotropins, it's too expensive. We say, come on, let's try giving you another boost of clomiphene. And if that doesn't work, we know that there's no option but to go with gonadotropin. So it's a bit of negotiate. All of us do it. We negotiate with our patients, to go up to the next treatment. And it helps you to negotiate with your patients. Now, what happens is you give 100 clomiphene, nothing happens. Day 10, day 11, nothing happens. What has happened is you've been unable to break the threshold. What is breaking the threshold means giving the optimum dose of FSH to be able to get the follicle to enter the examination, which means to cross the 10 millimeter mark. If a follicle does not do it, it means that the amount of FSH that you're given through clomiphene is less. And that's again, which again tells you that you need to give more clomiphene. So you can either give an increased dose of clomiphene. I've given the same dose. You can give an increased dose of clomiphene, or you can start using gonadotropins too. But again, see what your patient wants. If she says, I can't afford it, then say, let's give it a trial with gonadotropins and see if it's going to work. Or you can decide, if the endometrium is good, let's start 75 of gonadotropins and hopefully get follicles recruited. So it allows you to intervene at the first treatment scan. So that's one of the reasons why I scan on day 10, because it lets you know whether if there's going to be a response, should we intervene with an additional dose of the same drug? Should we add gonadotropins and allow us to give her some chance of pregnancy? So this is something which you can do. You can either on day 10, day 12, increase the clomid or add gonadotropin. So a short boost. Again, the logic is increase the FSH. Can you give clomiphene continuous? How many of you all give continuous clomiphene? It's brilliant because what it does is it does two things. It allows you to give a continuous FSH action. And I use it during IVF. If somebody says, I want to do a natural IVF, and I've got a very strong view about natural IVF. I call it the only treatment where a patient pays a doctor a huge amount of money for what she can do at home. And but some patients want to do it and they want to give us money, and then you can do natural IVF. But I think it's a bad treatment. But when somebody says, let's do natural IVF, I say, let's do clomiphene with IVF. The reason is that clomiphene does two things. Again, let's go back to basics. It gives you a sustained small rise of FSH, and it also allows you to, it stops the negative feedback mechanism. So what happens? There's no LH sudden rise. There's no rise of LH because the pituitary is switched off. So in fact, in all those cases, you don't need an antagonist. And it works as a phenomenally brilliant tool. It gives you more follicles. Who uses it more? The Japanese use a lot of clomiphene in their modified natural IVF. Now, clomiphene can also be sold. It's good for medical reps who'll come in and tell you, I've got a new clomiphene. And it happened, we were doing a course in Dubai and somebody said, we use zoo clomiphene. And I said, gosh, this is quite new. Maybe in India, somebody's discovered clomiphene. Then I read about it, that all clomiphene is a combination of two isomers, ZU and N. And you can keep mixing the amount of ZU and N isomer and make a clomiphene. So I thought it's fantastic. If letrozole wasn't there, I could have gone into preparing a new type of clomiphene. And the plasma concentration of ZU and also is much higher. ZU creates the more antagonist feature. And what it does is it allows follicles, if you give it continuously, then it is that which creates the antagonist effect. The other thing that you see singularly with clomiphene is luteinized unruptured follicle, and nothing in online media gives you so much headache as luteinized unruptured follicle. Try saying, what do I do for luteinized unruptured follicle? And 100 people will give their opinion. And you'll have 100 different answers, which means that you're going on a blind race towards treatment. So what happens? Luteinized unruptured follicle is not a complete phenomena. It's partial or incomplete. And these are follicles that rupture or shrink early. How do you detect it? If you have a lot of time and you want to play around with your brain, then scan after 6 to 7 days after HCG trigger. But I tend to do a progesterone. If the progesterone is low, it tells you that there's an inadequate ovulation. I don't call it unruptured luteinized follicle. I call it inadequate ovulation, because the progesterone is indicative of follicular response to, it's indicative of granular cell conversion to luteinization, and it's indicative of your progesterone rise of the luteal phase. So if you see a day 21 progesterone that is low, I think it's time to think of something else. How do you prevent it? Stop trying to intervene in that cycle, move to gonadotropins, and singularly gonadotropins reduce luteinized unruptured follicles. Don't keep scanning, do a progesterone and scan. If the progesterone is suboptimal, again, as I said, there is a problem with ovulation. How do you treat it? Next cycle, use FSH or HMG. Trigger with HCG. If you want to trigger with Lupride, Decapeptyl, you can do it. I sometimes do it because it allows for a better understanding of granular cell function, and it acts as a more potent trigger. And also check your progesterone. If you have a very good progesterone, then you have cured the problem. Is there any role of measuring AMH with ovarian response with clomiphene? The answer is yes. What does AMH tell you? It tells you about resistance. The higher the AMH, the more difficult is your stimulation. And what we know is that if you have a high AMH, it is very likely you have a high AMH. Again, go back to the fat triangle. You've got a high AMH, high number of follicles, irregular periods. There is insulin resistance. Your stimulation is going to be difficult. Ovulation induction is likely to fail. So start thinking on those lines. How can you make it succeed? It's going to, you want your patient to ovulate at the first attempt. And this is what you have to put in front of you. How can you make your patient ovulate at the first attempt? Which means, am I treating insulin resistance? Am I treating ovulatory dysfunction? Am I treating a combination of this? And if you are, And if you combine everything, and so what do? And whatever evidence may say, all of us don't follow evidence, do we? All of us go a bit different from evidence. And so what do I do with PCOS? I say, come on, go on to Inofolic. It does work in some cases. If you've got bad PCOS, take some metformin. Come on, hang on, go for that. And let's give you a trial with letrozole or clomiphene. And then if it hasn't worked, then you know that, hang on, we need to think of something different. Can you give continuous clomiphene? And the answer is yes. And the spontaneous ovulation rate is only 2 to 5%. And that is the brilliant part, which means that your failure rate before a collection, if you do IVF, is just about 2 to 5%, in which cases you will lose your follicles. So you give it right up till trigger. So I think I won't bore you with clomiphene more, because again, you must have said, what a crazy drug to use. So if you don't want to use this, I'll say give HCG, lower weight, but you can move over to aromatase inhibitors. Brilliant drug, non-steroidal, blocks the conversion of androstenedione to estrogen, has been used for breast cancer and postmenopausal, and a dose of 2.5 to 5 milligram is almost free of side effects. So what is different here? While clomiphene fools the pituitary because there is no lack of estrogen, letrozole reduces estrogen. So what does the reduced estrogen do? The pituitary realizes that there's less estrogen and it gives you a peak of FSH. So I'll show you what is different in that peak of FSH. But also the benefit is the negative feedback loop is not switched off. So again, it gives you a unifollicular growth. So as the estrogen slightly starts rising, the pituitary says, let's start lowering the FSH. So it follows the nature's pathway, but in a slightly different manner. It also has no negative impact on the endometrium. So while clomiphene will block the pituitary, letrozole does not. So this is how clomiphene and letrozole work. If you see the natural cycle and you see clomiphene will give you a sustained rise of FSH. So there's a continuous rise of FSH. There's a small peak when you start, and there's a small rise of FSH. And that is what gives you multiple follicles. With letrozole, it's different. Letrozole gives you a higher peak of FSH. So in the initial 3 or 4 days, letrozole is more potent because it increases your FSH much better. That's why probably it's more successful. And then the FSH level goes down. So it works very much like nature. So the question we have to answer is, do they work? Are they better than clomiphene for first-line treatment, and are they safe? And these trials have been going on for a long time. And if you see, there seems to have a very good result. They seem to work. They seem to have a lower miscarriage rate. And this is again an Indian study, and there are a few studies which are coming up from India, which is good, because you have to remember that Indian women in PCOS react differently. So the question is, people ask us, should we combine clomiphene and letrozole? And the answer is yes. It seems to work when you combine letrozole or you combine clomiphene. There seems to be a benefit in stimulating the ovaries. Again, the letrozole group had a very good success rate in that studies, but this is a very old study when somebody started. And then in 2005, a paper came out, which was never published. This was a lecture at ASRM, and I said that letrozole causes congenital abnormalities, and then there was a ban everywhere. So Tulandi came across a good collection of data which said that letrozole was safer, was as safe as clomiphene, and can be used. And they looked at the cardiac abnormalities, and these were also very low. And again, Casper looked at the same findings, and he looked at abnormalities, which is again low. So studies started coming out which indicated that letrozole was safe. This is an Iranian study which also showed where they used huge doses of letrozole, 2.5 to 10 milligram a day. That is an accepted dose which can be used. And they showed that fetal anomaly rate was very low. So the question gets asked is, which is better? And that's very important because when you sit with your patients, you have to decide which is a better drug. Do you use the old clomiphene or do you use letrozole? So again, this was a study done by Richard Legro, who looked at letrozole versus clomiphene. And the reason why it's a very good study is it looked at PCOS with reasonable good sperm counts. They gave a withdrawal bleeding to women. And so they're also testing, if you give a withdrawal bleed to women, does that affect success rates? Clomiphene 50 milligram or letrozole 2.5 milligrams. So a lower dose of letrozole, day 3 for 5 days. Maximum dose clomiphene 150, letrozole 7.5 milligrams. And note, trigger sexual intercourse 2 to 3 times a day. So what are they testing? They're testing, one is, does withdrawal bleeding affect your results? Second, what's your ovulation rate without a trigger? Third, they were also looking at success rates. So if you look at the live birth rate with clomiphene, 19.1%, letrozole live birth rate, 27.5%. Pregnancy loss, very similar. And what is important is ovulation. So clomiphene had a lower spontaneous ovulation compared to letrozole. Again, a reason why you should give a trigger. Because if you give clomiphene and letrozole, both have a small rate where ovulation will not happen. And that's again the failure rate of these two drugs. So if you want to give a trigger, it will help to this. Again, both produce side effects, and we often ignore that. And the commonest side effects is hot flushes and mood swings. How do you reduce mood swings for your patients? See them for a very brief period of time. So when you see a patient for a brief period of time, she's not going to complain much. She doesn't have time to complain, so you don't see any side effects. But otherwise, who faces a side effect? The poor husband. And a lot of patients do that. Patients will come to me and said, the drug you gave was awful. It just made me feel like a different person. And then I tell the husband, he says, that's what she'll be at a later time. So, you can make a joke of it, but it gives quite significant side effects. And almost a third of patients will have side effects of clomiphene. And we don't know why it occurs, but it seems to. Again, when letrozole was not there, we use anastrozole, but letrozole is better. So it's simple, the higher the dose of letrozole, you decrease estrogen more. So you want to give a very high dose of letrozole to get a better FSH level, increase the dose of letrozole. So sometimes I'll start somebody on 7.5. How do I decide that? I decide that looking at the patient. I'll see large ovaries. I'll say, oh, come on, take 7.5 for 5 days and let's see you. And I can do that because I have refused to believe in fixed protocols. I've said, let's utilize what we learn. Let's utilize pathophysiology. Let's utilize pharmacophysiology. And let us try and see if we can improve how the ovary can function or perform. And you can just increase the dose of letrozole. Next time, if 5 milligram has not worked, make it 7.5 milligram. And you'll see a better FSH. At the end, what do you want? You want a higher dose of FSH, which will help you to recruit follicles. And again, finally, this study came up from Japan, which said that the risk of congenital anomalies was very low. The second thing that's coming up is that letrozole may increase integrin levels. And the reason why that's coming up is there have been some studies that have said that letrozole may reduce the miscarriage rates. Yeah, and again, there were mainly Japanese studies, and we are not entirely certain about it yet, but we think that there is some positive aspect to the endometrium that may happen with letrozole. Do you do the stair-step protocol? You can, but the only disadvantage is that letrozole has a shorter half-life than clomiphene. So the cumulative aspect of letrozole is less. And so I'm not entirely certain if doing a stair-step protocol is as effective. There have been about 4 studies which came up in fertility sterility, and all of them said that the stair-step protocol of intervening on day 10, adding a higher dose of letrozole may be helpful, and that's a stair-step. So what happens? See, this is the difference which I've tried to write. So what happens with letrozole? In letrozole, you see a rise of FSH, which goes down. With clomiphene, you see a smaller rise of FSH, where it's more sustained. So in this period, when you're going to see a unifollicular growth, clomiphene recruits more follicles. Next question we have to answer is that what size of follicle is it ideal to trigger for clomiphene and letrozole? We trigger at 18 millimeter, don't we? But all that data is based on IVF. In nature, follicles don't rupture at 18 millimeter. In nature, they rupture between 18 and 30 millimeter. Do you know what gives you an indication of impending ovulation? The endometrium. So, and I'll show you a study here. And the endometrium always rises 2 days before ovulation. So you see a massive jump of endometrium. So again, in thin endometrium, why? What do? I use a lot of letrozole in my thin endometrium in frozen transfers. But also what I tend to do is I say, let us wait till your follicle gets to 23, 24, 25 millimeter, because you don't know in nature at what ovulation occurs. So ovulation induction should also help you to understand what happens in nature. So in nature, you will find out that some women will ovulate at 24 millimeter. And how do you know that? The endometrium changes. The endometrium gets more positive. And again, why do you keep that in mind? It's good to intervene at 20, 22 millimeter, but in some cases where you see a poor quality of eggs, you see endometrium being thin, give that a try. So, and this was again a study done with IUI during a natural cycle or with clomiphene, HCG, IUI performed, and the primary objective was to identify the optimal lead follicle size, a retrospective study. So in nature, we thought that the highest pregnancy rate, which is 14%, was when the follicle size was 19 millimeter. With clomiphene, the best pregnancy rates were when the follicle size were 22 millimeter. It seems that 15 or the 18 millimeter mark probably is not the best mark in nature or for IVF. So we looked at another study where they looked at clomiphene and letrozole, very similar. This is just a retrospective analysis. And they found that the mean diameter was between 22 to 23 millimeter. And there's no single follicle size at which you get your best result. So we will say so what do I tell patients? I tell patients, why didn't you start trying at size 18 and see me in 2 days? And if it's size 20, 22, I'll trigger. If she's already ovulated, you've not missed the boat. She's continued to try. And follicle size is, endometrium is different for each follicle size. So it's key. What we know is that 89 millimeter, when it gets to, with clomiphene, gets to 24 millimeter, and with letrozole to 4 millimeter again. So pregnancy rates are higher when lead follicle is between 18 and 22. It decreases for smaller follicles. And for each millimeter of endometrial thickness, the follicle size increases by 0.5. But what I think happens is, as follicles cross 18 millimeter, there's a more rapid rise of estrogen, and there's a more rapid increase of endometrium. It is the rise of estrogen which starts the positive feedback of LH. So the higher the estrogen, the pituitary responds much better. But also what happens is, I think I'll come back to it, is estrogen the trigger of ovulation? And I think there's a controversy around it, and we'll talk about it tomorrow. So pregnancy rates are higher when leading follicles are accompanied by a thick endometrium. Larger follicles produce more estrogen, leading to higher endometrial thickness. Clomiphene and letrozole could not be compared in these studies, and letrozole was given to younger women. And the weakness of his studies was that serial scans were not done, and it was retrospective. You can also use tamoxifen, and I think with letrozole coming in, the use of tamoxifen has decreased. You give it from a dose of 20 to 40 millimeter. It does not have any negative impact on the endometrium. So keep that in the back of your mind, and sometimes when clomiphene and letrozole don't work. If you look at the and this was a study I presented a study online, and it's a very complex study. So what they looked at indicators of endometrial receptivity, and they looked at what clomiphene and letrozole do. And they took biopsies. And what they noticed is that 4 of the with endometrial receptors genes declined when you use clomiphene, and they remain the same when they use letrozole. So that could also be, in addition to causing changes in the endometrium, it also seems to affect the endometrium immunologically. And finally, years ago, I came to Kolhapur to do a meeting, and there's a guy who got up from the audience and said, "What happens if you combine clomiphene and letrozole?" And he said, "Oh, I do it. I gave good results." So in fact, all of us had a good laugh. And, he went off, and I think he was right. And so they did the study. And I think we can never find that man. I can still remember a shortish man who was wearing a red shirt and who stood up at the back. So they combined clomiphene and letrozole. I'll tell you what my logic is here. And so they randomized to 3 days letrozole 2.5 milligram daily, or they used clomiphene and a combination of letrozole. And they noticed that ovulation was better when you combined it. Clinical pregnancy rates were very much this. It was better, but to very small numbers. Letrozole works locally, while clomiphene works at the hypothalamus level. Another study showed a better ovulation rate. So in simple terms, I'll say go back to basics. What does letrozole do? Letrozole increases intrafollicular androgens. So, and what do androgens do? And I tell, in simple terms, who irritates the woman the most? The man. Don't you agree? So the same thing happens, is androgens irritate the follicle. So, and what makes the follicles more sensitive? The androgen excess. So why do PCOS respond aggressively? Because of the androgen excess. Why do you use DHEA? Why do you use testosterone patches? The logic is the same. The logic is that you want to sensitize the follicle. Letrozole also sensitizes the follicle, and clomiphene probably works better there. Again, the success may be better if they had used 5 milligram of letrozole. In fact, I've seen a lot of over-response whenever I have combined. So that's in short. I think the reason I said we'll use it in ovulation induction is it helps us to plan a bit differently. You can mix and match. And I want you to go back taking this talk and believing that you can try and use these drugs differently. Try and use it outside the protocols. There's no harm in doing it. And try and see if you can make them more successful. And maybe you'll come up next time and tell us how we know something different, or my patients respond much better. And the reason why it's important is because gonadotrophins are expensive. IVF treatments are expensive. A large part of the population can't afford it. And so utilizing these drugs more effectively is helpful. Okay, thank you.
Thank you, sir. I have quite a few questions. I mean, it was a wonderful presentation.
Yes.
Too many questions, actually. I don't know from where to go. In your clinical practice, when you see a PCO patient, which is the drug you prefer using, like either the CC or the letrozole? And based on what factors you choose the drug is the first question. No, so I have lots, sir, actually, to ask you.
So I think that...
You said based on the ovarian volume, you decide.
No, so number one is I look at their cycle.
Yeah.
So first you have to decide, is letrozole worth giving? So my first drug of choice is letrozole. Is letrozole worth giving? And if she has regular cycles, I tell them no, don't do it. If she's got mildly irregular cycles, then I say, let's go for letrozole 5 milligram because it's more likely to work. If she's got immensely irregular cycles, then by giving letrozole, I'm only treating ovulatory dysfunction. I'm not treating insulin resistance. And there I say, whatever it is worth, I say, go on to Inofolic and go on to metformin, and then we'll start letrozole. So I first go on to periods. Now, irrespective of the AMH, you remember that the ovary tells you a story, and you should be able to listen to that story. And what the ovary tells you is, you're not a biochemist. Are you? No, yeah, you're a gynecologist. So since when did we become doctors who looked at a test and reacted to a test? The test only gives you an indication. So let's say the AMH is very high, but the lady is ovulating. She's got a cycle that is 33, 34 days. The ovary is doing its job. It's not doing it at that fixed level. It has a longer follicular phase. So in those cases, I'll say, go on to letrozole. Now, if you've got a 50-day cycle, 60-day cycle, that's where I'll say, go on to lowering your insulin resistance and then go on to letrozole.
Then if you're using letrozole, how do you decide that this patient is resistant to letrozole? Like in CC, as you said, and one more thing, the important question is, you said somewhere your slide said that you're going to call the patient on day 7 for a scan after you start the CC. But we do not follow it here. I mean, we do not call the patient so early on day 7. I don't know which regimen you meant day 7, whether it was a conjunctional regimen or the extended regimen, where you're trying to look whether the clomiphene is effective or not, whether you need to step up the dose or continue the dose. So these are the things for which you said you would call the patient early in for a scan. But here we call them maybe around day 8 or day 10, depending on
I think
how
it's good. As I said in that talk, I don't see them I don't see when I was younger, I had a lot of time. I had a small private practice. I saw them on day 7 because that was one way of making more money. But now I don't. I see them on day 10. Day 10 to day 11 is good. And I think it's.
So how do you decide the resistance part of the patient?
So by day 10.
Because I have had patients who are cycles were almost extending to 180 days, once in 180 days, and AMH was almost 19. And I used all these regimens where patient did not respond. And how many days of your stimulation maximum you have gone? And I mean, according to the protocol, we know like this is the time we stop and then we move ahead. See, but in your clinical practice, when do you put a full stop, sir? Like, this is not responding.
When do you do a full stop? You do a full stop when a patient has run out of money. See, I give letrozole for 7 days. Why? Because the packet which we get in the UK is for 7 days.
We get it in a package of 10 tablets. I mean, like.
Yeah, so we get 14 tablets.
So,
and my mother taught me not to waste food, so I don't waste drugs. So I give it routinely for everyone for 7 days. That's my personal, and I see them on day 10. By day 10, I know if that drug has worked or not. If it has not worked, I continue letrozole for another 7 days. That's my personal belief. And I do it on very big PCOS because what happens is that it allows me to just give almost continuous letrozole with only a 3-day gap. That's my personal practice. How good it is, I don't know. I think it works in some cases.
Do you use 5 milligram OD dosage or you're using 2.5 milligram?
No, I use 5 milligram. I think
when you're using 7.5 milligram, again, you're using the OD dosage, once a day dosage.
Yeah, you can use it as a single dose.
As a single dose, yes. Right. So suppose in this cycle, you've used it for like 17 days, as you said, and the patient has not responded. So in the next cycle, how do you go about?
I give gonadotropins.
Yeah, suppose this next cycle you try with gonadotropins. Again, the patient has not responded. What do you do next?
Fantastic.
I mean, my question is, I had a patient like this.
Fantastic.
Would you do an ovarian drilling for the patient?
No, I don't.
And then do you give them another chance, or you directly advise them an IVF?
No, okay. The only thing is, would you ever drill somebody's testis? No. Then why do you drill somebody's ovaries? It's such a drastic, crazy thing. We do all these things because they are women. So if your drugs are not working, you're not able to break the threshold. What breaks the threshold is high doses of FSH, which means you have to do IVF because ovarian induction has failed and ovarian stimulation is failing. But I'll give it to Sachin.
I have a small different take. Going back to your first question, in which patient I will counsel that I'm going to start you letrozole, but it may not act. I will go by the antral follicle count and how the ovary looks and what Sharyu just showed. If you see a typical rosary pattern of ovary with all the follicles less than 5 millimeter and no follicle beyond 5 millimeter, that means they don't have androgens enough, which the aromatase to get the letrozole cycle going on. So I may start it off, but I will counsel them that your ovary is different. You have all the follicles are less than 5 millimeter. My letrozole may not work in you, but let me give it a try. That kind of, so I'll be very wary about these clients where all the follicles are less than 5, a PCO, where I may not give letrozole. Again, we also give for 7 days. Giving extended letrozole therapy, which is quite a YouTube thing today. The problem with an extended letrozole therapy is you expect too much out of letrozole. You expect as if gonadotropin is going to keep on increasing the FSH levels. You expect even letrozole to keep on increasing the FSH level at the same pace. That doesn't happen. Number two, always remember that we are giving letrozole, keeping the E2's level low. Now, how many days that endometrium will sustain a low E2? I've had queries, a lot of patient doctors asking me queries. I have given her extended letrozole therapy, and now my endometrium is not picking up because you have to give a drug-free interval after letrozole. At the time of letrozole, all the endometrial E2 is down, and all the receptors are hungrily waiting there for the E2 to come. If the E2 doesn't arrive after stoppage of letrozole, in 2 days' time, the E2 will pick up and all the receptors will be satisfied and the endometrium will grow. That's a different story. But on letrozole itself, but that many a times the extended letrozole is used for FET in India, which is a big question mark for me because there's no great evidence there. The second part of giving an extended letrozole pumping in, that endometrium will break through. Then the lady will, she will say, what doctor, I came to you for a pregnancy. You give me a drug to develop an egg and I got started bleeding. I was expecting a bleeding later. So with all these counseling done prior, then I will jump into all these things.
And also I've seen in 1 or 2 of my patients that whenever sir was telling that when the dominant follicle is around 18 millimeter to 20 millimeter, wait for another 1 day or so and just see whether that endometrium picks up a little bit. So what I've seen is in my clinical practice, the beautiful trilaminar looking endometrium, which was maybe about 8 millimeter, after 2 days, if I wait, the dominant follicle would have grown in size to 22 millimeter, but whereas the endometrium would have shrunk sometimes. We see that there is a shrinking happening in the endometrium. Have you any time seen such cases and how do you go about in such cases?
See, let's go back to, as I said, there's no fixed protocols. And
because this does happen even in our, FET, stimulated FET cycles that I've seen that a day waiting shrinks the endometrium.
So, you come, see, there's a new concept coming up, which is on physiology, is what starts the trigger of ovulation. We think that a high estrogen starts triggering ovulation, but we probably think that it's also progesterone that plays a key part. The progesterone there's a very thin window of progesterone where level is very low. Before ovulation, progesterone starts rising. And the reason why you see the endometrium go away is because pre-ovulatory follicle has seen a higher progesterone rise. So those cases, you know that your trigger is going to be late and your FETs don't tend to work there. And you should not be doing an FET then. But that's because of the rise of progesterone, which is marginally high. But we think that progesterone may also be a main indicator of initiating ovulation. And that happens in IVF, where your antagonist is being kept steady. The progesterone marginally rises and you think I'll go for a freeze-all protocol, but the follicles have ruptured.
This was Casper's study of endometrial compaction when it was basically done in HRT cycles. And he reported that whenever there is a fall in endometrial compaction takes place by 1 millimeter or more, the pregnancy rates improve. And he presented in a beautiful title saying that why euploid embryos don't implant. The title was that, but the study was about compaction. This study was replicated in about 508 patients, and they exactly reported the ulta rate, where the endometrium was compacted, the pregnancy rate was only 11%. So, it doesn't hold true. And again, you are discussing this in context more of a simple ovulation induction. I think we'll just say, madam, forget this cycle, go with another cycle, rather than wasting a lot of time in that 50, 100 rupees wala cycle. Best is to plan gonadotropin therapies and move ahead in life, rather than, trying to dissect all these small issues. That's what I feel.
Thank you, sir.
Just look at the lady. Just look at the lady. A typical pear-shaped obesity and acanthosis. That's more than enough. There is no need of a testing. I don't do a test at all.
When you go back home, pick up your degree and find out what it is. If it was a PhD biochemistry or MD gynecology, we are not biochemists. And the more the more tests you do, you confuse the doctor. The more you confuse the doctor, you confuse the patient. And that's it. I tend to do very minimal tests. Even in IVF, I do very, very minimal tests because I think it just creates a huge problem.
It is a consensus in India to a lot of tests. But then if you don't do that, they feel that, well, you are not done enough and you made a mistake. You did not analyze this. That's a different story. Anyway, any more questions? Yes. You're asking something. Yeah.
Sir, actually, I induced one patient who was suffering from secondary infertility. She has been treated for PCOS for first pregnancy and she got pregnant elsewhere. After 4 years, she came with irregular cycle. So on third day, I induced her with Letrose 7.5 mg. I used to induce for 7 days. So when I did a scan for her, after 7 days, the follicle were 1.4, 1.4. There were 2 to 3 follicles, but endometrium was thin. So I started her on Proguanova and I induced her with HMG. 3 injections I given. And on the day 12, I seen that endometrium was also good. It was trialaminar, 7 millimeter, and the follicles were ready. So I did ovulation test, urine ovulation test, and then it was negative. That's why I gave her trigger with Hucogo 5000, 2 injections. But next day, surprisingly, she came that I started bleeding, madam. Then, exactly what, so yeah, was it because of, because 3 cases, only last week only I get 3 cases same. After I given the trigger, next day they came that, madam, period has come. But on scan, there was no, follicle was ruptured.
See, if you, as Sachin said, if your endometrium is thin, the low estrogen will have a negative impact.
Yes.
And if the endometrium does not recover, or if the breakdown endometrium has started, there's not much you can do. So
I've given Sir Proguanova for her.
See, Proguanova is a drug that you're giving estrogen orally when the receptors have already been downregulated.
Okay.
So in that case, what it is telling you is that letrozole is not the drug. You should start with gonadotrophins. And if you start your induction with gonadotrophins, you'll get a better result.
Okay, next cycle only pure gonadotropin, yes. Not combined.
So, whenever all of us face these problems, don't look in retrospect, look in prospect. Because retrospect, don't have that guilt, what must have gone wrong. Think how will you correct it. The correction is gonadotrophins.
Okay. Good afternoon, sir. Thank you for such a wonderful talk. I have 1 or 2 questions, yes. So first of all, what do you do when you see 4 or 5 follicles on day 10 with clomiphene more than 10 mm? Do you stop that cycle or you still follow that? In
4 or 5 or 3 or 4?
4 to 5 more than 10 mm with clomiphene.
I'll tell you what I do. It is not entirely correct, but couples have been trying for a long time. So I tell a patient that if you continue, then you'll have a multifollicular growth. It is very likely that you'll have multiple eggs growing. It is very likely that your pregnancy rates will be higher. And it is possible that you will have twins or triplets. It is very dangerous to continue this. My advice is don't do it, but it is finally your choice. I've not come across any patient who has not tried for a pregnancy after saying that.
Right. And sir, do you use, then do you trigger in such cases?
No. So the question is, Do you know the Hippocratic Oath has changed? It has now changed to, in modern times, it is first of all, protect thy ass. So, don't put yourself into trouble, which you are seeing coming. So there you document the right things. You also help the patient. Remember, these are infertile patients. I've been trying for a very long time. Every time you cancel a cycle, she goes into depression. So you say the right things and she'll do the right thing. Finished.
And sir, do you add gonadotropins if the follicle is already more than 10 mm on with letrozole or clomiphene?
Generally, no, because I think I give that for a second discussion because they are more expensive. The results don't change dramatically. So I think if letrozole is not working and it's having a slow growth and my extended regimes have not worked, I'll say, come back and let's think whether you should go for gonadotropin stimulation or you should think of IVF.
Okay. And the third and last question, sir, is there any quantification of the FSH rise with oral agents? Like if we have failed with clomiphene or letrozole, then does it mean we should use a higher dose of gonadotropin for ovulation induction in such a patient?
I'll do that in my next talk. I'll tell you how I probably plan the dose of stimulation.
Right. Okay. Thank you, sir.
No, I don't know. I thought you wanted to know. See, if you do 7 days post ovulation progesterone, and if it's good, there's no role for ovulation with luteal support with letrozole. If your progesterone is low, my question is, what are you treating? Are you so? If you go online, I've done a talk on what forms the luteal phase. So what creates the foundation for luteal phase, a good follicular phase? So if you've got ovulation happening earlier, which happens in older women, which happens in PCOS, then your luteal phase also is going to be poor. So if a progesterone is low, I say letrozole is not your drug of choice. I think we should move to gonadotropins.
In last 3 cycles, even then.
I think she should have a hysteroscopy because we tend to miss some polyps, but equally, we tend to miss some either endometrial hyperplasia, which is typical or atypical. So if you've done a hysteroscopy, there's nothing much you can do. I'll say start the stimulation, but they should have had a hysteroscopy done.
Okay.
What does it tell you? It tells you what stops a woman's periods. Simple. So if she's got bad PCOS, see, if you're giving somebody a withdrawal bleed, her follicular phase does not start. So a woman's period gets longer.
Yes.
So why do PCO women have longer periods? Because the follicular phase does not start. So what it means is that as soon as the follicle starts growing, endometrium builds and the period stops. So either you wait or you probably needs to get the follicular phase growing faster.
It's actually, we have already started the letrozole from day 2. So in that case, we have to extend it further.
Yeah, what I'll say is wait till day 12, day 14, and you'll see if it has worked.
Okay, let's go ahead with the gonadotropins or
just wait and see.
just wait and see. Okay.
Excuse me, sir. Sir, you said like you look for insulin resistance by looking at the cycles. If the cycles are irregular, then you would like to add metformin. So it applies to lean PCOs as well, which are very thin and.
We don't know. What we know from old studies is that metformin does not seem to help lean PCOs as much as it tends to help obese PCO. But I don't think, have you read Sachin's paper? I think he should be getting a Bharat Ratna for it. And I firmly believe No,
So Sachin sir's theory, yes, I do agree.
So what happened in Indian women, and I think there is evidence that even Indian women who are slim, a significant proportion of them will have insulin resistance. And metformin does not seem to help those women.
So should we have PP insulin done and then give metformin or not? Should we have PP insulin done for insulin resistance?
Yeah, ma'am, everybody has a different way of diagnosing hyperinsulinemia. I am putting a very simple way. If the patient is having central obesity and acanthosis is there, I assume that she is having insulin resistance, which is more than a criteria. Obviously, you can go into the details. So what essentially we are diagnosing insulin resistance with metabolic syndrome, go by the American Diabetes Association criteria of putting all the criteria and putting that into your patient group. And then every patient will have insulin resistance out of a different criteria. Somebody could be high triglycerides, somebody could be low HDL, somebody could be a high LDL. The criteria would differ. So we don't want to debate onto that. We all the studies are on HOMA and insulin resistance and PP insulins and things like that. Go by simple criteria. What are you going to grade your insulin resistance and then decide the therapy? Nothing of that sort.
Yeah, I don't think it's
so. I think don't worry very much go into that metabolic story a lot. Concern and what ultimately, suppose you have a high insulin resistance woman and a husband has 2 million count. What is your answer? IVF. Is your IVF going to overtake the insulin resistance? Yes, it is going to overtake. You're going to pump in more gonadotropins. So you're going to override that thing. So let's not waste time on homa karenge, ye karenge, wo karenge. Farak nahi padega.
I for all my PCO patients, before I start any treatment, I get an HbA. See, I've got a basic, I think all of us do is I take a blood pressure, which is very important because you don't know how many women are getting older, and I do an HbA1c. If your HbA1c is high, then you know that these guys are going to get pre-diabetic. Then it helps us to plan much better. But I've stopped doing insulin. We used to do insulin on our NHS for everyone as a research tool, but I don't think it really helped. And in fact, we did it.
Also, it never helped. Our study told us that our women have low HDL levels in spite of the low weight, and that's also a marker of their metabolism. Funny thing in Indian population. So Indian population does have a little more insulin resistance. So it's a thin fat index, which is a very Yarnik's concept of food. A thin fat index, something which is very commonly seen now.
Sir, is it possible that only one ovary is hyperstimulated after giving CC and the other ovary doesn't respond at all?
Yes.
Why does it happen?
Because that's how the woman is.
Sorry.
See, ovulation induction, recruitment follows a very weird process, and the ovary decides which follicle has to be recruited. Now, which ovary is larger? We think that the right ovary is generally larger than the left ovary. That's because the left ovary runs on a compromised blood flow, and so the right ovary has more direct blood flow. The larger ovary always responds better and more, and ovary that has larger follicles. But the ovary also decides which ovary is going to respond. So I don't think we can change that.
Thank you, sir.
Sir, in previous lecture, you said the antagonist wanes off in 48 hours, effect of antagonist. And when,
I didn't say that.
when there is multi-follicular development, means we are in doubt of OHSS and we are giving agonist trigger, then body's LH will not work that much because of antagonist remaining effect.
You're logical, but the affinity of the GnRH receptor, the agonist has much higher affinity to the GnRH receptor compared to antagonist. So even if you give antagonist just now, and after 2 hours you give agonist, the agonist replaces the antagonist and you get a flare. So it is more to do with the affinity of the receptor to the drug rather than the action, duration of action.
You were asking about some giving LH, sir?
LH?
LH.
What? Why?
From outside, giving LH.
For what?
For trigger.
Trigger, yeah. You can give. So the triggers which are, he's going to cover it up, HCG, LH, kisspeptin, and GnRH agonist. But the amount of LH which will be required for trigger will be very big matter. Like something like, 1 IU of HCG is 7 IUs of LH. So you give 6,500 IU HCG as a trigger, a standard trigger, that is 250 microgram of recombinant HCG. So 6,500 into 7, just do the calculation. That's one amount of LH. The LH is available at 75 IU. So it's very impractical to give such a high level. IV lena padega shayad 2 ghante ke liye to get an LH. So that's why we don't use LH as a trigger in our practice. And kisspeptin will be a higher dose. So thank you, Anil. Thank you very much. About this question, you asked about the LH and the progesterone, the luteal support. There's a very interesting study which has been done wherein they have seen the LH rise and the progesterone levels in the gonadotropin cycle, fertile cycle, clomiphene cycle, and the letrozole cycle. And you have a better LH surge as good as a normal ovulating women when you give letrozole. And so generally the progesterone levels in the luteal phase in an LH cycle is better compared to the other ones. So letrozole alone cycle, a progesterone support may not be needed in the luteal phase. So you're talking of an FET cycle? Huh? No, I'm not come across this. It is just my lack of knowledge. I don't have that particular reading done. Okay. I'm just going to take you to, yeah, again, one more clarity I want to say. The metformin works better in a normal BMI woman. Metformin doesn't work very well in obese women. I'm not creating a confusion. You know, in obese women, metformin just decreases their thermogenicity. So after eating one chapati, she will still gain 20 calories. You and me, after eating one chapati of 100 calories, get 100 calories. So we are more thermogenic. In an obese woman, that thermogenicity will come down, but she has to decrease her weight only. But in a young woman, giving metformin will change the insulin resistance, because I told about the thin fat Indian. So all the studies which have been done earlier, or you will go by Columbus studies or any studies which have been done, or Norman studies from Australia, they talk of a normal BMI woman on metformin does best from the endocrinological point of view. Obese women on metformin doesn't do that well from the endocrinological point of view. Anyway, I hope I might have confused you, but that's a fact. Okay, I'm just going to take you through gonadotropin. The IUI discussion we have distributed over two lectures. I'm going to talk to you about a few things on IUI, and then Dr. Mohan Kamath in the evening will be principally covering a lot about the clinical aspects of IUI to you. So I'm just going to take you through a few introduction of the drugs which we commonly use in practice and how they're different, and then we'll answer a few queries in IUI, which are our day-to-day queries as well. As Dr. Shariu told us that the earlier stages of follicular development from primordial follicles to preantral follicle is something which is just FSH regulated, and if it is not FSH responsive. Oh, the slide has not come. I put it here. Yeah. But it is not FSH responsive, and we really don't know how to manage those up. But once it comes to preantral follicles, then it becomes FSH responsive, and it grows all the way to pre-ovulated and ovulated. So it is only happens, this whole story takes place in just 17 to 18 days. And what we are here assembled together and dissecting the subject is about what we can do for these 17 days of development. And we are really not worried about what happens earlier to that part. So our science is all about revolving on the 17 to 20 days of this follicular development. These are the drugs which we have. This is Gonal-F, which is recombinant FSH alone. Then we have Luveris, which is recombinant LH. All of you are IVF practitioners, you know about this, but few could be very youngsters for them. Menopur, the FSH molecule is very highly purified, but it doesn't match that of the Gonal-F, but it is better than the routine HMGs, while they don't have LH activity, because as you start purifying the FSH molecule, urinary gonadotropin, the LH is lost. So instead of LH, they add about 9.9 IU of HCG. Is added as an LH activity. So, 1 IU of HCG equal to 7 IU of LH. So they add almost about 70-75 IU of LH activity to that Menopur. Then we have our routine HMGs, which is outsourced from the your raw material, which is coming from Argentina, Spain, Germany, China, Korea, and then it is lyophilized in India. and we get those lyophilized powders out here in India. And then you have pargovirus, which has recently entered in our market, which is 2:1 combination of recombinant FSH and recombinant LH, which is now available for us in practice. And this I've already told you about the different isoforms, and I told you that different isoforms are not available to us in our practice. We have to use one isoform, and then we go ahead in our stimulation. The FSH acidic isoforms are secreted at the older age, and in the younger age, it's more basic. So in the older age, being acidic, it is biologically less active. So imagine when you collect menopausal urine, you're collecting basically acidic FSH, so biologically less active. While your rFSH, which is gonal-F, it is synthesized by a DNA technology, which is basically less acidic. So it's a little more basic, and it has high biological activity, though it has a shorter lifespan there. The half-life is less, but biological activity is very high. Why I'm telling you this is a lot of us have this typical habit of mixing apples and oranges, or just for cost saving, first 5 days go on rFSH, and the next 5 days go on HMG. Believe me, you have to trust that you're giving a high stimulation with a high biological activity, then dropping down the activity when you use HMG. So that may not work great in all the cases. You will have outliers who may not respond well, or the follicle may not grow well, and few of the follicles will disappear. If you desire that, then that's okay. If you don't desire that, then that would be disastrous. In my practice, I never decrease the dose. I go full throttle in all my stimulations, because GnRH agonist trigger is there, which will say it's a savior from the OHSS. So what I want to tell you here again is, when you have used urinary gonadotrophins, you're going to have an acidic FSH molecule. When you use recombinant, you're going to have a basic or highly active recombinant. Menopure is, again, it's very unique. I don't have any shares in Ferring company, but Menopure is very unique and very good because it has a very high good FSH value, and it has HCG as an LH surrogate. And these changes of losing the LH takes place as the purification goes on, and in the purification process, the LH is lost. But since it is a long-acting acidic molecule there, it pushes a larger herd of follicles as you stimulate them. The LH, you have recombinant LH and you have HCG, which you can be using. Recombinant LH has a terminal half-life of about 10 to 14 hours. Urinary LH is again 10 to 12 hours, and endogenous LH is just about 60 minutes. While your HCG has a long half-life beyond 30 hours. And so when you are using HCG as a surrogate for LH, the LH activity would be persistent for a little longer time compared to recombinant LH. What about batch-to-batch variability? Pretty common in the yesteryears. Now the batch-to-batch variability has definitely come down. Because till the time we were relying on the Steelman-Pohman assays or bioassays, which were drugs were injected into rat and the total rat weight was checked. There were many confounders which could decide the validity of these bioassays, and that's why we had a lot of batch-to-batch variability. Again, the sourcing is so different. It is a very random source. They used to hire nunneries to collect the urine and then process it further. Now, so at the sourcing problem itself, there were many confounders. There could be different ages, different obesities, or different diseases they could be suffering from, which may have some effect onto the FSH molecule there. And though the batch-to-batch variability could be also attributed to that. Ferring, for the first time in Europe, came out with this idea that they had 1 lakh individually screened donors, and then they donated urine and then started purification. The company claims that, and they published this study also, the company claims that, well, we have individually screened donors. But now I sometimes wonder, just going to this nunneries, how it will be written. Well, you go to this urinal and you go to this urinal because you have diabetes, you don't go to this urinal. And I really don't know how they ever executed that protocol of individually screening the donors and making them urinate into one urinal and then collecting the urine over. But no studies are published on that part of the story. HMG HP, what you use are Menopure. It is the HCG of the pituitary origin. And again, I'm repeating that LH's half-life is only that much, or HCG is more. Mariofort is another drug which is not yet available to us, but Anil uses it in London. The Mariofort uses placental HCG. Obviously, it is more potent than the pituitary HCG. And Mariofort has shorter stimulation, more oocytes, and equal potency, and higher estradiol levels are there. But we really don't know how it will act when it comes to OHSS. Now, we all understand that whenever we do ovulation induction in anovulatory ladies as well, thumbs up, we go ahead and do it. But what about ovulatory women? Women who are already ovulating, is it worth stimulating their ovaries further? So what is the philosophy being stimulating them further? So the treatment philosophy of ours to implement an ovulation induction or ovarian stimulation in already ovulating women could be just improve the mild ovulation problems like delayed development, inconsistent ovulation, which I showed you in my earlier scans, where studies where the FSH is variable. So you could be streamlining those effects to have a proper ovulation done there. Ovulating normally, but simply does not conceive, and probably regularizing their ovulation by different proper hormonal fluctuations could aid them better. FSH addition, when you add to stimulation, it will increase the estradiol. It will also optimize the cervical mucus for a better passage of sperms. Endometrium will be better, and that will also support the follicular growth. And this is one secondary analysis has been published on the study done by P. Diamond et al. And Richard Legro, and which is famously known as AMIGOS study. Which was a study of unexplained infertility undergoing IUI and 3 groups of letrozole, clomiphene, and gonadotrophins. And in their particular study, they said that letrozole women had less pregnancy rate compared to gonadotrophins because they had more follicles probably. But when the secondary analysis was published, they said that the richer women got faster pregnancies. The poorer women had less pregnancies, economically poorer women, and they also had more miscarriages. And Robert Casper published this secondary analysis of an AMIGOS study. And he went further. He said probably a poorer woman, because of a chronic economic stress, they will have a gonadotrophin, your hypothalamic pituitary axis not working well, and they will require a higher change in the estrogen to take place to have the axis functioning very well, which is possible with gonadotrophins, which is these higher changes may not be possible with your letrozole and clomiphene alone. And he attributed that gonadotrophins giving more pregnancies also, and the poorer women not responding to this chronic level of stress, and which is changing the requirement. So in India, obviously, economic stress is there. We are unnecessarily competing with each other for no reasons at all. And so this stress over a long period of time is definitely giving rise to some kind of ovulatory dysfunctions, and that we will correct by using gonadotrophins. And that's why I definitely feel that we should, even if the lady is normally ovulating, there's nothing wrong in pushing them a bit by using gonadotrophins or the different drugs. When you give HCG, as I told you in the Park et al. Study earlier, the normal LH surges are different. There is peak, there is a single spike, the double spikes, all those things are different. You just ameliorate that by giving an HCG trigger and just override and have a very uniform LH trigger, and that would have better luteinization also. And FSH addition merely stabilizes an already functional process to a more satisfactory manner. So there is all the logic in giving ovulation induction, ovarian stimulation, milder ovarian stimulation for women who are already ovulating. And what protocols will you use? You will choose recombinant FSH because your aim is the lady is already ovulating. She has a bit about LH, and that LH will be more than sufficient. Anyway, you are not interested in 10 follicles. You're just interested in 2 or 3 follicles. Starting dose is obviously low, 50 to 75 IU. In older women with a high BMI may require, or very high AMH patient may require even high dose. But even if high AMH and high AFC is there, you're not going to put your foot directly to a high dose. You always go in stepwise manner, because we really don't know who will explode by going out to multiple follicles, and you will go stepwise manner. It's better to start at a low dose rather than to start at a high dose. Start stimulation from day 6. Sometimes you will give letrozole, clomiphene to start with, and then add a stimulation of gonadotrophins from day 6 onwards. Though this is a very common practice in India and China, it's not a very common practice. Anil wears a different hat in Harley Street. Either he gives letrozole or clomiphene, or he gives gonadotrophins. Very few times he will be making combinations, but we are used to making combinations of these 2 drugs. So whenever you're giving low dose, I think you try to choose your recombinant FSH or menopure. But what happens with our ovarian stimulation in IUI or non-IVF cycles is we want to be economically very constrained, and that doesn't permit us to use these kinds of medicine. We'll end up using HMG 75 very commonly. High dose. Now, if you go by the guidelines of ovarian stimulation published by Eshrey, it says, well, you use any drug. You can use RFSH, you can use HMG, HP, any drug, the live birth rate, ongoing pregnancy rate, everything remains the same. But again, coming back, these guidelines are published on larger studies. And when you do a larger study, you do not take into consideration the real world scenarios. The extremes of population is very less. It is a population typically between, 18 to 35 years of age, a normal AMH range, a normal BMI range, everything will be normal. That's not a real world scenario. The patient in front of you is very old. Patient in front of you has a very low AMH. She has a combination of AMH, FSH discordancy. She is polycystic ovary. So the same rules of guidelines of ovarian stimulation may not apply to the client in front of you, and you will need to change, and we will discuss this as we go further. Now, in my practice, HMG is the drug of choice, and even Anil will agree to that. We prefer using LH in our stimulation protocols and not use RFSH alone in our stimulation protocol. If you ask us a question where RFSH is needed, we feel it is the diminished ovarian reserve patients or the patients who are older age, they need RFSH. But then you cannot use RFSH alone there, because RFSH is basically used in those patients because you need a stronger push and you have a great biological activity there. But you need LH also. So many of the times, my protocols in diminished ovarian reserve patients is a combination of an RFSH and LH activity. So it could be an RFSH and RLH like parvovirus, or it could be an RFSH with HMG, or a menopure and RFSH going hand in hand, or menopure alone. But it is never RFSH alone in our older population. When this comes to IVF. In ovulation induction, well, you can still use a low dose of RFSH. Anyway, you're targeting 1 or 2 follicles, and that will still work very well. These are the different protocols which we use for our non-IVF protocols. You all very aware about it. I'm not going to go through any detail. You people understand this better. I'm just taking you very quickly over a few protocols. I understand most of you are IVF consultants, and it will be just taking over a few things. This is a protocol which has been recommended by B.N. Chakravarti, and they published this study, I think at Rome, Ashray, they presented this particular paper quite some time back, where they use letrozole 2.5 milligram from day 2 to day 6, and on 2 days they just gave HMG 150. They said that the first HMG will increase the FSH levels, so few more will meet the FSH threshold, and the last HMG will not allow the FSH window to close. The FSH activity will continue for another 2-3 days. So instead of 1, many of the times you may have 2 follicles. Obviously the OHSS risk is not there, but this protocol is not going to work. It will work only in good responder. What I mean by good responder, the one who has already responded to letrozole alone. Simple definition. Let's not complicate it. So then this will work. And I prefer using this patient for this protocol for donor IUIs, because they are all young women. You diagnose a bad azoospermia as fast as possible. The couple is very young and they are generally good responders. So unexplained infertility, you can do that. Instead of 1, you may have 2 follicles, not in all cycles, a few of the cycles, and then this may work better. But beyond Dr. B.N. Chakravarti's paper, I have not come across any more publications on this particular protocol practice. But this I recommend to a lot of people who are worried about OHSS. This one thing I showed is OHSS is not there. Otherwise, in a patient who has not responded to letrozole alone, you've given letrozole, clomiphene, the patient never responded to that, never recruited. Obviously, you will be going to gonadotrophins, and the typical protocol you will use is you'll start gonadotrophin 75 IU to 150 IU. If you're using a routine HMG, if you're using an RFSH, obviously you have the choice of giving 37.5 or 50 IU, going continuously for 5 days. At the end of 5 days, a certain level of FSH is reached. Then you want to do a scan to know whether you have cracked the FSH threshold and a few follicles have got recruited. So on day 6, you will go for a scan. And at that scan, if you have a follicle beyond 10 millimeter, that means you have reached the FSH threshold, just continue the same days, take the follicle all the way to the day of trigger and give trigger and go ahead. But what if no follicle is recruited? Obviously, you're going to step up the protocols. You're going to add the dose for another 5 days, maybe increase it for another 5 days, have a look at the follicles, do a scan and have a look again. But then there could be some PCOS who will just go into OHSS. Like you're given 75 IU, well, there's no recruitment. The moment you put 150, suddenly 7 follicles have started growing. And neither you don't want that as well. So in polycystic ovary, the typical Roy-Hamburg, Colin Howell's recommended protocol in PCOS, go low, go slow. Slowly build up the FSH level so that at a point, just 1 or 2 follicles will trigger they will reach the threshold and the follicles will keep growing. So you can go with a low dose at 50 or 75 IU or even 100 IU continuously for 12 to 14 days. And then you'll have development of a follicle or 2. And then you can give a trigger and plan ovulation induction or IUI or ovulation induction and simple timed intercourse. The problem is it's a longish protocol, counseling to the client is very difficult. And, if it fail, obviously it will fail. The success is going to be just 15%, not beyond that. And this will fail very commonly. And then you should have a morale yourself to advising the same protocol again to the client, and then boost the patient's morale to go through the whole protocol. So when it comes to counseling, Colin Howells published a very beautiful paper long back in 1995. Then AMH was not there in the picture as the criteria. And he put up a few criteria in which this protocol may not work. And he said, patients with high BMI, patient with a large number of antral follicle count, patient with a low FSH. So probably they could be hyperestrogenic because of obesity again, patient with high LH, they said that this protocol may not work. So if you have these combinations and you're giving it the chronic low dose, be very, very wary about it. Counsel them in detail. Okay, what dose you're starting, how you are going to analyze this. You build up a patience in your patient also that she has to take injection for 12, 14 days. When I shared this, a lot of Indian doctors or my students only, they have shared this. One of my students had shared that she does this protocol typically after ovarian drilling, and it has worked well for her. She does it with RFSH alone and uses a dose between 75 to 112.5, and it has done wonders to her practice using IUI. So chronic low dose protocol is this, which we typically go in continuously doing that. A severe PCOS, high BMI, high LH, low FSH, high FCs, difficult results. When I shared, we were talking with Jatin, even Jatin Shah said that he prefers using a dose of 112.5 for low dose chronic protocols. I think that's very agreeable in Indian population. You can have an increment of 25 IU after a week, stop. If it is taking more than 14 days, an increment, then you can do an increment in the next cycle. That is, you can just forgo that cycle and go to the next cycle. And this is a protocol after drilling we can use. So there are different protocols which are available to all of you, and look at the pregnancy rates of CC, letrozole alone, HMG, CC with HMG, and letrozole with HMG. And whenever HMG has been used in protocols, the pregnancy rates have been better. So practically speaking, giving CC alone or letrozole alone and doing an IUI has completely come out of my practice. We prefer using gonadotropins. The whole target is to achieve 2 follicles so that our success is better. But then you will have a patient who is little advanced stage and have a very diminished ovarian reserve. She will very well respond to that clomiphene alone. And in her, because clomiphene, as Anil mentioned, is a wonderful drug. And even for 1 follicle, I wouldn't hesitate in that particular group doing, because every egg is important and every ovulatory cycle is important going over with IUI in that particular patient. What about antagonist? Are we going to use antagonist in our IUI cycle? And this is a typical protocol I'm just depicting here, that what happens in IUI is you put up a protocol and then you realize on day 8, when the patient comes for a scan where you're having multiple follicles. And that's the point you think of adding an antagonist. Okay. Otherwise, but for this particular decision making, as a few questions were getting discussed, that you started letrozole and halfway through added HMGs, I would say don't do that. Discuss the counseling, discuss the protocol beforehand, start with that protocol, announce at the end of it, this protocol did not work for you and I'm going to change. Okay. Now there is something called stair step with gonadotropins, like as we discussed in the previous question answer session. You give letrozole, halfway through decide where the follicle is not growing and add a stair step with gonadotropin. Well, that is agreeable, but it's better in a counseling session, it's better to devise one, because then you are telling the cost of one treatment, cost is going to be 5,000 rupees. You go through that. If it doesn't, we go with additional. Then the patient has understood better that they have to go for a better protocol. They will invest better into that rather than halfway through giving them a shock, another 5,000 madam, and that will be difficult to adjust. So in my counseling practice, it is, we decide on the protocol beforehand, execute that protocol, then announce failure or success of that, and where we succeeded, where we failed, and then we adjust onto the next protocol. That is better policy to do. Let's discuss a bit about the antagonist. So this whole concept of IUI is increasing the gamete proportion in the uterus. So the oocyte which is released has a chance of has a fertilization capacity for 24 hours, and that of the sperm lifetime is only about 1.4 days, and you just have to match both these things together, and that is what exactly happens in an IUI. But commonly when we stimulate, we land up in these kinds of follicles. We have a lead follicle which could be about 19 millimeter, and you could have 2 more follicles or 3 more follicles which are 16 and 14. The lead follicle takes a decision for trigger. So you give a trigger, but the other follicles are lost. The other follicles become useless for us. And it's always a tendency for all of us, dil mange more. Why not have those other follicles also grow? And you feel that adding an antagonist and allowing the follicle to grow and preventing a luteinization can make those other follicles also grow. And instead of one trigger of one follicle, you're giving trigger with 2 or 3 follicles, and your pregnancy rates could be better. And that's very commonly comes to us. And again, when you have these multiple follicles, the premature luteinization itself is little high, natural. And even if you decide to give trigger, probably it may not work well, and premature luteinization is going to be high, and your pregnancy rates are going to be low. So why not electively go for antagonist? So when we add antagonists, there are 2 kinds of protocol which you have learned, is a fixed protocol and a flexible protocol. Fixed is on day 6 of stimulation, you add antagonist. Flexible is when the follicle is beyond 12 or 14 millimeter, you add antagonist. In IUI, it's going to be a flexible protocol. It's not going to be a fixed protocol unless you pre-decide that it is going to be a fixed protocol. So it's a flexi protocol, addition of antagonists will be there. So this is a nice paper which is on antagonist cycles in intrauterine insemination, and premature LH occurs at follicle beyond 16 millimeter. So, you know, somebody who would debate with me, I think good Mohan is not here, because Mohan has published a beautiful paper on use of antagonists in IUI. He says it doesn't work. And probably this is one of the reasons he's putting forth. Anyway, a lot of 16 millimeter follicles will harbor a good egg. Just go ahead and give a trigger. Why give an antagonist and waste your time? And probably you will be still successful in few patients. And that could be the Mohan's concept. And a few people may argue with us that why give antagonist? Why not just give trigger? So this is this analysis published about 6 randomized control trials. And they said that ongoing pregnancy rate increases by 5.3% when you use antagonists, when you have multiple follicles developing there. And it will take about 20 anticycles to have 1 pregnancy additional. So now you weigh your situation yourself, but we generally don't weigh the situation generalistically. We weigh it to the individualized patient in front of us. So I would say if you have 2 or 3 follicles and the patient is agreeable to it, you can go ahead with antagonists. But obviously, you have to continue stimulation and you have to continue with antagonists. So the cost of treatment will go up. Who will benefit? Older patient with short follicular phase, reduced ovarian reserve, they will have defective GNSF. So they will trigger their LH faster, earlier. You know, typically you will see a patient who is 14 millimeter. You confidently tell her, well, madam, come after 2 days. And you expect that follicle to be 17 millimeter. After 2 days, when she comes, the follicle is ruptured. Because she's an older woman, she triggered her LH faster. And these are the women who could be helped with antagonist if they have multiple follicles. So antagonists will give you results only if your IUI stimulation protocol has multiple follicles. With a single follicle, I sincerely doubt your antagonist is not going to give anything. So antagonists will convert an explosive ovulation induction into a controlled rescue IVF. So can you go for a rescue IVF by using antagonists when you have an explosive stimulation noted at IUI? So we will try and go to that. There is an increased pregnancy rate with anti-use because more follicles are allowed to grow to mature stages without premature luteinization. And lead follicle less than 16 millimeter, LH less than 10, and progesterone less than 2 is an ideal time to start an antagonist. That's the right time you're starting, and probably it will be more result oriented. It would be a little expensive as well. Now I'm going to answer a few questions which are on IUI and which commonly come to our mind. So first question is, should you confirm your rupture before IUI? And Anil would be laughing. I said, I don't even do IUI. My nurses do it, and forget about confirm. You just tell them a particular appointment, they finish the IUI and go home. But in India, a lot of us are worried that if follicle rupture nahi hua, IUI karu ya nahi karu. So there's a nice evidence for all of you that this is a beautiful evidence that whether it is rupture confirmed or not confirmed didn't make any difference. You know, the clinical pregnancy rate is 14% on either sides. Live birth rate is 11% in either side. So whether it is rupture or no rupture doesn't make a difference. So don't bother about confirming the rupture. Just confidently tell the patient, come at 36 to 40 hours, I'm going to complete your IUI and going ahead with the whole thing. Your pregnancy rates are good. The take home here is for the people who claim that my IUI pregnancy rate is 40%. The take home is mentioned there. Okay. So are you realistic when you counsel your patients this? And that will make a lot of difference. The moment you start counseling the patient, your IUI results are 40%, your IUIs will increase and IVF will be low. The moment you start counseling the patient, your IUI results are 14%. They will say, doctor, you have tried enough for 14%, jump up, and your IVF will go up. So don't counsel, don't be very bombastic about counseling high pregnancy rate with IUI. You're making a fool of yourself. What about sperm counts and IUI success? And these are studies which are done by after the Hamilton paper of 2005. And I think Sharif is going to dissect that paper more further. So it talked about total motile sperm concentrations. And I'm not quoting Hamilton, I'm quoting another paper here, which is about live birth after intrauterine insemination. Is there an upper cutoff for number of motile spermatozoa? Look at the results. That when the motile spermatozoa was between 20 to 30 million, the 28% pregnancy rate. And when it jumped beyond 30 million, the pregnancy rate has come down. So when there is a large number of sperm there, and when you do spinning and swim up and density gradient techniques, a lot of apoptosis will be cells, they will release reactive oxygen species, and that will decrease the fertilization capacity of these inseminated sperms there. There are another 2 questions now. So suppose a client in front of you gives you a total motile sperm concentration of 50, and your insemination count has 50 million sperms. Should you dilute the sample and make it to 20 million and then inseminate? No, that wouldn't work, because you're talking of insemination. So your already ROS is there. You should think of dilution before you ever spin the sample up. But studies, there is only one sporadic study on that, so I wouldn't recommend you. But suppose your total motile sperm concentration is less. Go on the other side of the story. It's 1 to 10 million. Then these are the couples you can suggest them a double IUI, like IUI 24 hours after HCG and 1 more IUI later, after 36, 40 years. Or having the Bahadur paper of having 2 samples collected, 40 minutes interval, 2 samples, and then you do take the insemination count more, try to go reach 20 million, and you can achieve a better pregnancy rate. So that is our take on the total motile TMSC, which is going into the uterine cavity. Next, the question of luteinized unruptured follicle is very common, isn't it? So this is a beautiful paper on follicle growth and endocrine dynamics in women with spontaneous luteinized unruptured follicle versus ovulation. And the commonest misunderstanding amongst all of us, it is premature luteinization causing luteinized unruptured follicle. Yeah, a part of the story is correct. But when you look at the endocrine dynamics, they did the follicle endocrine study on day 2, day 6, day 12, and post-trigger in the early luteal phase. And what happens to all the estrogen, progesterone, LH, FSH, everything they studied. And they said that the follicles which grow faster with lower LH concentrations, they more land up into luteinized unruptured follicle. And the theory behind that is when there is low LH, it upregulates the LH receptor. And as the LH surge starts, the LH doesn't go, in 5 minutes, it doesn't touch 60 MIU. It will go over 4 hours to 60 MIU. On that path, as the natural LH surge is climbing up, in the initial part itself, because there are a large number of LH receptors there, because this follicle is deprived of LH, the whole follicles get luteinized, and that lands it into an unruptured luteinized follicle. That's the whole endocrine story. So suppose you give HCG and the follicle doesn't rupture, don't repeat HCG. There's no point giving a double trigger like that, because your follicle is already luteinized. It's a gone case. In your IUI cycles, what kind of stimulations will you use? CC letrozole is your favorite, or HMG75 is your favorite? So look at the CC cycles, and they compared CC to HMG75. The live birth rate in CC cycle is 6.8%, while 12.8 in HMG. So that's a bigger take-home message for all of you. We did a study, me and Anil, we did a study about use of CC and letrozole in Indian population in anovulatory and ovulatory women. We did not go for a publication of that, but the study was quite a startling thing. What it revealed is, in our study, in ovulatory women, beyond 31 years of age, giving CC 100 milligram gave us 3.1% pregnancy rate. Okay, so don't use these drugs alone. Move ahead to gonadotrophins as fast as possible. Take every opportunity to go ahead to gonadotrophins so as to achieve a better success. And in this, I'm particularly quoting this particular study because somebody asked a question about proguanova, addition of proguanova. See, if CC is going to cause an endometrial side effect, it's an idiosyncratic reaction. Your addition of proguanova is not going to make any difference. In this particular study, they added proguanova whenever they saw thin endometrium. In spite of addition of estradiol, CC cycles had thinner endometrium than gonadotropin endometrium. So come out of this concept that we can ever simulate nature by giving progyno. Typical, the whole order is given in one book. Like it is given clomiphene for these days, progyno on these days, dufaston on these days, these 3 days intercourse, and the prescription is handed over to the patient. Don't do that. You'll have to monitor every patient and take a decision for yourself. In my practice, we have completely stopped giving estradiol valerate in CC cycles in this phase, totally follicular phase. Most important messages. This is a nice study which published about what is important in an IUI success. It is the protocol, or is it the total motile sperm concentration? And if your given protocol is giving you 2 follicles, if taking your estrogen beyond 500 picograms, but 2 mature follicles of 16 millimeter and above, the estrogen will be around that. That is enough to give an ideal pregnancy rate from the stimulation point of view. So don't keep shifting your stimulation protocols from one protocol to the other. HMG RFS is there. You are just increasing the costs of the patients. What is important is, are you achieving a 20 to 30 total motile sperm concentration there? And that is more related, giving you a better pregnancy rate. So just shifting the protocol is waste of time once you have reached that 2 follicle issue. Otherwise, if not, then probably, yes, you may have to shift the protocol as well. What about thin endometrium in IUI? Again, I think we are hypersensitive about thin endometrium. All the studies on thin endometrium have come from IVF studies. And because Robert Casper put up that philosophy that when you have a thin endometrium, your embryo is exposed to a higher oxygen concentration. Embryos grow in a pyruvate and lactate atmosphere, which are products of anaerobic metabolism and not aerobic metabolism. And that's why the embryos may not implant and you will have less pregnancy rate. But when it comes to IUI, on the day of HCG, if you have a thin endometrium, don't worry about it. Because now your HCG is going on, 36 hours later, follicle will rupture, then you do an IUI, then another 12 hours for fertilization, another 5 days for the blastocyst to come to the endometrial cavity. And all this point, your HCG is acting on a corpus luteum, pumping in progesterone and estrogen, and that will improve the endometrium. So if you have a thin endometrium on day of HCG, just call the patient for 6-7 days later, endometrium would have picked up in most of the cases. Unless you have a very refractory endometrium less than 5 millimeter all through the menstrual cycle, well, then that definitely demands some kind of investigation. And this is a beautiful paper on meta-analysis by Weiss et al. Published way back in 2017. I think Anil has a beautiful video onto this. And the whole analysis said that cancelling an IUI in the pretext of thin endometrium does not have enough proof. So don't bother about what endometrial thickness you have. Okay, unless you have an ecogenic, continuously thick endometrium, and as Anil just discussed, that we need to look at the histopathology of that endometrium. Are we facing some other problem? That's a different story. But thin endometrium, don't bother about it. Don't cancel your IUI. And blastocyst implantation rate after implantation comes from implantation after 6 to 7 days, and corpus luteum is still functioning. So we won't bother much about it. What about rescue IVF? We don't do many rescue IVF because we are private practitioners, and rescue IVF invites certain costs. So I think whenever you have more than 4 follicles at the end of an IUI stimulation, we have, what choices do we have? And these are our choices. Number 1, abandon the cycle and tell them not to have intercourse. But see, OHSS, because of HCG is avoided. But if they have intercourse and they get pregnant and she has twins, OHSS because of pregnancy, she can still have. Or you just give agonist trigger. So you're causing rupture of the follicles, but then they'll be followed by an active luteolysis and tell them not to have intercourse. Well, that's ideal, because then you're avoiding OHSS because of HCG. You're also avoiding OHSS because of pregnancy. Or even if you don't add progesterone in the luteal phase, that also is good enough, because luteolysis will be so severe the chance of pregnancy is pretty low. Or then, as Anil said, that we don't want to lose a chance of pregnancy, getting a pregnancy. So you can add an agonist trigger, and intensive high-dose progesterone therapy can be given. Now, this typically patient would be a non-PCOS patient in my practice who develops 4 or 5 follicles. So she's non-PCOS. So I'm not worried about she going into a bad OHSS. Okay. That severe grade OHSS will not be there. I will still give agonist trigger and an intensive luteal support, because that is also her opportunity of getting pregnancy. Will I give HCG? Yeah, I may wait for a day and may give HCG later on the day of IUI, maybe 1,000 IU or 1,500 IU. Now, these are some jugards we would love to do. I'm not training you to do jugards, but then you'll have to weigh the situation. It's a shared decision making between the client and you, how you will act in that particular situation. But suppose you want to, patient says, well, doctor, I want to go for a rescue IVF. Then how do you do it? You go with, it's a HMG stimulation already done. Patients will be seen on day 8. For just 4 follicles, you won't do a rescue IVF. The follicles will be beyond 6 or 8. And then you will continue the HMG stimulation. You would add an antagonist to it. You will give agonist trigger because it's a high stimulation. You can't risk giving HCG trigger. And you will go for a pickup, vitrification all, and frozen embryo transfer later. So you're increasing a huge amount of cost to her treatment. AFMC in Pune, their favorite is to do rescue IVF because they do not increase the cost. It is free treatment. So obviously they have that luxury of doing a lot of rescue IVF, but we in private, we won't have that luxury because we are going to increase a lakh of rupees cost to them when you convert that IUI cycle into an IVF cycle. What about luteal support in IUI cycles? When it comes to clomiphene, there is, and with a single follicle development at the end of clomiphene, there is no role of luteal support at all. Because clomiphene is long acting, it is sitting on that estrogen receptor. It is not perceiving the higher estrogen reaching this, so the positive LH is not occurring. After the Rome-Eschrey, there was a paper which won the prize in Rome-Eschrey, was about a reverse protocol, where they gave HMG for the first 5 days, and the last 5 days they gave clomiphene citrate. So they said they are using clomiphene citrate as an antagonist, not allow premature luteinization to take place. And so if clomiphene citrate acts that way, the chance that there would be a low progesterone will be pretty less. So if progesterone you have to add, you will add in gonadotropin IUI cycles, and obviously there is an increase in the pregnancy rate, and 11 patients are needed to treat to achieve 1 additional pregnancy. So if you go with the meta-analysis, it says that whenever you use gonadotropin, adding progesterone makes a difference in luteal support. If it is gonadotropin and clomiphene or gonadotropin and letrozole, again adding letrozole, we don't have a great data. Clomiphene, again, it makes a difference, though clinically significant, not statistically significant. But if it is a clomiphene alone cycle, giving a luteal support doesn't make much of a difference. Okay. I've not covered the whole topic of IUI. I'm very sure about it. Thank you so much. A lot of clinical aspects will be attended by Dr. Mohan Kamath. And when it comes to sperm selection, Dr. Sharyu will cover it up herself. Any questions on this? Yeah, you use with the sperm processing media itself. Absolutely, sperm processing, but that you dilute beforehand, not later. So you'll have to aliquot into 2 different things and then do it. And after this, Dr. Anil will take you through gonadotropin dosing in IVF. Yeah. Yeah. I purposefully avoided that. When it comes to intensive lutein, this is a terminology which has come after Peter Humaydan talked about giving an agonist trigger and doing a fresh embryo transfer. So there were 2 stories to this, 2 philosophies, I would say. One is an European philosophy, which is highly guided by Peter Humaydan, who says that give 1,500 of HCG on the day of OPU trigger and again on the day of OPU. With that, he can maintain a good progesterone level. And that he called intensive luteal support to save and do fresh embryo transfer cycles. But the problem is the moment you say HCG, you will have OHSS. And in his group, they noticed 5% OHSS. And they noticed 5% in spite of choosing a very milder criteria. Like they chose a criteria of more than 15 millimeter, only 11 follicles beyond 15 millimeter. But the severe criteria, which were defined by their own group, by Papanicolaou et al., was beyond 18 follicles beyond 15 millimeter. That they did not choose for this. So in spite of choosing a milder criteria, they had OHSS. The Americans never followed that. The American had an intensive luteal support where they gave estrogen, progesterone, vaginal progesterone, and intramuscular progesterone every day. They called it intensive. Why I wanted to avoid this question is, in an IUI cycle, how do I embark saying that give intramuscular progesterone every day? So I would say, in my practice, I would say intensive ones, I would do duphaston maybe 40 milligram a day. Or a vaginal progesterone with duphaston 30 milligrams, some combination of that sort. No particular study on that aspect.
So I think I'll try and talk about how to plan the dose of IVF. And this is an ongoing lecture. So every few days I keep changing it because I seem to confuse myself on the way too. And one of the things you have to remember is that fixed protocols don't work. They seem to work on men. They don't seem to work on women. So you remember that the ovary responds very differently. And so you'll have to, in some cases, say, if you follow a fixed protocol in about 60 to 70% of cases, you use any protocol, it works. It's not very difficult. IVF is not generally a difficult subject. It's a simple subject. You need a good laboratory and you need to be just use a bit of common sense and IVF works. Is it difficult? No. Why do you do IVF? You do IVF only for two reasons. One is that you lets us sleep at night. That's the main reasons why we doctors do IVF. The second is it's money when results are low. Think about it. You want to do a knee surgery and you say there's a 40% chance of success. People will throw you out. People will beat you in India. In IVF, you say 40% chance of success. People say, fantastic, he's the best in the country. So see, there are positives to it. But equally, there is 20 or 30% in a highly competitive market and in a highly competitive place. There are 20 to 30% of cases which are difficult, where you'll need to understand what can I do to change my protocol. So what I'm going to go through, I'm not going to give you fixed way of doing protocols. And this has always been how I train my trainees. It is important for you to develop a thought process. And by being able to examine your patient, see which protocol would fit the best and modify what you have learned along the way. And at the end, you will find a right protocol for your patients. And my job is to give you those ideas. So, if you had seen Bailey and Love, there was a saying that said, the eye does not see what the mind doesn't know. And so if you don't, I strongly believe that if you don't read and if you don't push your own education as time goes by, ignorance prevails. And as doctors, all of us are busy. I'm not saying that we've got a lot of time, but make it a point to read something every day. The second thing is, and this is very much an old Indian concept, that all knowledge lies within us. It has to be revealed to us. And the way you reveal it is by pushing yourself to learn and understand. So Sachin's talk, I enjoy his talk on IUI on stimulation, because it's a pretty good talk. It gives you an idea of the various combinations. So what is that talk about? That talk is about getting 1 or 2 follicles. So it's a very mild way. And what do you want to do is you want to get more follicles. So what is that concept? Is you want to call it controlled ovarian hyperstimulation. And that's where, as Sachin said, that's where that big question mark comes, is how can you control what you already overstimulated? Now, the main crucial concept here is the FSH threshold theory. So in simple terms, I'll say that how many follicles can you get beyond the 10 millimeter mark is the FSH threshold. And which means that you need to recruit follicles. The more follicles you recruit, the more eggs you're more likely to get. And in nature, you have 1 follicle growing. So what does, ovarian stimulation do? Ovarian stimulation breaks nature's policy of 1 follicle and 1 egg. So again, a few concepts is antral follicles are presented and they go through monofollicular growth. The destiny of large majority of follicles is death. Ovarian stimulation aims to change the destiny of follicle. The other important thing you have to remember is that when you look at the antral follicles, why is it that some antral follicles are competent and some are not? And again, it's an aging process. As when women are young, they use their best eggs. As women age, the quality of their antral follicle count, the quality of their reserve, which means the antral follicle count, also declines. And that you see in your IVF cycles. Ovarian stimulation aims to change the destiny of follicles. So follicles which are supposed to die and go into atresia, what ovarian stimulation does is it brings them out and tests and gives them a chance to live. You cannot stimulate more follicles than you see on a scan. If you saw 8 follicles and then you stimulated and you saw 16 follicles growing, there are only 2 things. Either your scan was wrong or you're a magician. So you decide what you are. But otherwise, you can only see, let's say at the start of stimulation, those are the follicles you can stimulate. And nature offers those follicles. So again, remember, all this is based on an antagonist protocol. If you're going for an agonist protocol, I'll say, believe in God. And when you start the stimulation, in normal responders, you'll hopefully stimulate very well. Antral follicles are generally recruited in the later part of the cycle and also continuously. But we're not going to talk of continuous recruitment, because in good responders, you don't need to go for random stimulation and you don't need to go for luteal phase stimulation. And that's the talk which we'll start doing tomorrow. Now, which is the best recruitment window? It's a late luteal phase. So next time, when you go back to your patients, scan somebody on day 24 of a day 28-day cycle. Your follicle count will be the best. Why? Because the FSH is low, the LH is low, luteal phase physiology. So what is that? Nature's long protocol. Nature lowers your FSH and LH, and as soon as the FSH LH is lowered, the recruiter window widens. So again, where do a majority of my stimulations start? Even in PCOS patients, majority of my stimulations start on day 23, 24, if I'm going for a freeze-all protocol. Because by the time it comes to day 1 to 2, follicles are already selected. So you have very less controls. You can only stimulate what are there. Now, there's a window. And remember, there are 2 windows of recruitment in nature. One day of recruitment, which is the late follicular phase window, which is a wider window because of its pharmacology. And the second recruitment window is the follicular recruitment window, which is for the first 5 days. What closes the recruitment window? 2 things: rising estrogen and a high dose of FSH. So if you suddenly decide that I'm going to whack this woman with 450 or 600 of FSH, the higher the FSH you give, serum FSH rises faster and you shorten the window. And then what do you see? You see 2 follicles growing, 1 follicle growing. Why? Because you've had a very short recruitment window. So you have to decide what do you want. So that is the key aspect. There's a very basic concept of, and I'll keep harping on it because I'm not a believer of very fixed protocols. I believe if fixed protocols can convert us, then come on, we should have become somebody else. We should have decided to go and sell oranges on the streets, because that's a very fixed way of selling. But think about it. Every ovary is different, and learn to listen to the ovary. So for ovarian stimulation, what does the FSH do? You have a force versus resistance. So you have to decide what forms your high resistance. And that is the entire way how stimulation works. For your successful stimulation, except in poor responders, the concept is different. We'll talk about it tomorrow. We'll talk about what in poor responders, resistance is the aging process. In younger women, resistance is multifactorial if you want to have a successful stimulation. So know what you're going to face. Know what response you want. Do you want 5 follicles? You want 10 follicles? You want 20 follicles? You want 70 follicles? You decide what you want and what is good for the patient. What is the risk? So when you start, you have to think, if I use this protocol, will I risk a poor response or will I risk an over response? You don't want a poor response. If you're doing a fresh transfer, you don't want an over response. So you have to decide on what are you going to face. So measure your antral follicles. Follicles which are less than 4 millimeter generally don't stimulate well. They have more AMH in them and they stimulate poorly. You have to recruit, and that's, I think your scan is incredibly important. So have a look at these follicles and measure them. And that will give you an idea how it's going to work. Now, no research will tell you this, but I believe that the theta is a sign of how young the ovary is. And that's the normal responders. So when women age, what do they lose first? The non-growing follicles. So as women age, what gets thinner? The theca gets thinner first, and the follicles get less later. First to drop is AMH, then to drop is the antral follicle count. So what does the AMH indicate? The AMH indicates the long-term aging process. It doesn't indicate fertility. All it is telling you is that the ovary has decided, let's start aging. And this is my concept, and I think my concepts can change. It's like religion. We keep changing the way we think. And so when you scan women, you look at her AMH, and if the AMH is on the decline, and this is what I tell my patients, if the AMH is low but the antral follicle count is good, in IVF, she's giving you a window in which you can get a good response. Eventually, what happens is, as the AMH declines, the pituitary does not realize the aging process. Eventually, it starts realizing the aging process when the theca cells. So what is sending the trigger? The trigger is coming up from LH based. So as women age, their LH goes down. And that, I think, forms the basis where the ovary detects and says, hang on, I'm getting old. Let me slow down. Because what is the first job of the ovary? Is to get a baby. What's the second job of the ovary? It is to keep the woman's femininity, which means to get her into a later menopause, to give her a longer life, to give her stronger bones. And the ovary switches. When we don't know, every woman has it different. I think Indian women have it around 33, but that switch occurs. I think in Caucasian women, that switch occurs between 35 and 37. And that gives you a window of opportunity. So, you see somebody at 33, 34 who's got an AMH of which is low, but has good antral follicle count. Be proactive. I've got gray hair, I'm much older. I can tell women, if you don't try for a pregnancy now, it's going to be pretty bad. Or do something, freeze eggs, freeze embryos. And as you get older, you can do that. People don't think you're mad. You can take up this fatherly or motherly approach, but that's something which you have to think about. So understand your FSH threshold. What are the components of a threshold? One, you have big ovaries. Bigger the ovaries, higher the threshold. Why? More LH, more theca. More follicles, higher the threshold. Number of follicles. If you have more than 10 follicles in each ovary, the threshold is higher. Theca element, it tells us about the LH. It's a surrogate marker for the LH. Theca tells you about the androgen excess. Theca tells you that how much of the man is there in a woman. Who irritates a woman? A man. So theca tells you that. The higher the theca, you are going to have a difficult stimulation. All of us know that. PCOS. If there are very few follicles, again, a number is a must, and have a rethink. Are you stimulating at the wrong time? Again, it happens in women who have a good antral follicle count. They go through phases where follicle counts just drop. How small are the follicles? Are they less than 4 millimeters? If there's a very high LH, that's a warning mark. That's a warning that your stimulation is going to be incredibly difficult. And finally, measure your ovarian volume. Because if you have got 8 follicles and you've got a big size ovary, then it's telling you a different story. It's telling you a story that this ovary is a bad PCO. It's recruiting follicles very badly. And you see some women who are PCO, who have irregular cycles, but you scan them and you see only 8 follicles, 9 follicles, 10 follicles, but they're large ovaries. These ovaries do the worst. And maybe these ovaries, require some damage, as they said, drill the ovaries, maybe. Because what lowers your LH? The only one thing that drastically lowers LH and AMH is ovarian drilling. And some women require it. They require that knockout blow to the ovary. The second thing is LH sealing. And Sachin spoke about it. As high estrogen levels occur, a feedback occurs and there's premature luteinization and the cycle gets abandoned. This is almost corrected by agonists and antagonists. And now the question is, surprisingly, luteinization is not a complete phenomena. And how we know that is, you get to egg collection, you measure 15 follicles, you get to egg collection, and then you see only 10 follicles, 4 of our follicles have disappeared. So I don't know, I did a talk recently, and I put it on YouTube, on vanishing follicles. And they vanish because there is part luteinization. And it's not LH that is triggering it. It is progesterone that is triggering the part luteinization. And we are forgetting that how progesterone role, because in our massive stimulation, we are trying to change not just the estrogen levels. Estrogens are supraphysiological levels, but you're also putting progesterone before ovulation at supraphysiological levels. And that high progesterone levels before your trigger are probably also playing a role in the luteinization. So what do you want? You want between 8 to 10 mature oocytes. You want a good response. You want to replicate the LH surge. You want to collect eggs. And then you pray that the embryologist does a good job, because once you get eggs, the entire responsibility is the embryologist. And the doctor is the supreme being. The embryologist can be blamed for all the failures. And that's the rest. So I've got, again, general, you have to remember that this is not fixed. This adopts my thinking. So if you look at, you've got an adequate number of follicles, your LH is low, your ovarian volume is fine. I put it green, which means it's going to work well. They're going to give you a good result. If you've got a very high AMH, your LH is high, and you've got androgens, high volume ovaries, it's going to give you a poorer response. It's going to give you a variable response. You're going to get a lot of immature eggs. You're going to have a high risk of overstimulation. Why? Because these are women who've got PCOS. They have got a huge amount of androgen excess. They're more difficult to stimulate. And what happens to women with PCOS? They produce more poor quality eggs, because that's how the metabolism is going. Remember, maturity is not the only sign. In the same way, euploidy is not the only sign of quality of an embryo. So maturity of an oocyte is not the only sign. A human being is formed from two components, correct? So man gives half the chromosomes and woman gives half the chromosomes. But where does the cell structure come from? The cell structure only comes from the woman. So when people say, is a child 50-50? Answer is no. Men like to believe that, but it's not the right answer. A large part of the mitochondria, the energy, is entirely oocyte driven. So, and as women age, they lose the mitochondria. So just looking at mature eggs is not the way of looking at it. It's also looking at the mitochondria. And in women with PCOS, there is mitochondrial impairment. It also happens in older women. That's why you get eggs which are mature where you don't get good quality embryos. Same thing happens in PCOS. So what is the basic approach? Now, if you want to say, hang on, I want to train in infertility for 3 weeks, and I want to open my center, this is the best protocol. A lot of people do that, and it works well. 60% of cases you can do well, 40% refer to somebody else. It's simple logic. Why learn more? You've got a busy obstetric practice. You want to do a bit of fertility, then follow this protocol. It works well. But then you want to change a bit. You want to modify this. So let's use this as a basis, because this has been an age-old protocol, works in 60% of cases. So why try and change the wheel and say, I want to change everything and make it more complicated? If you're a researcher, you'll do that. But if you are clinicians, and as clinicians, we want to make things simple. Increase the dose based on your number of follicles and size of your follicles. So I've got this, think of the ocean, bubbles which are higher up have lower resistance. So follicles which are higher up have lower resistance. Follicles which are deep down have high resistance. They're more difficult to stimulate. FSH, you require a higher dose of FSH. So what does it tell us? If you've got bigger follicles, you require a lower dose. If you've got very small follicles, you require a higher dose. Forget the AMH, forget everything. That is what the follicles are telling you. Then you come to the AMH, and so you look at this. Small follicles require more FSH to push them. In normal responders in PCOS, there is more AMH. In poor responders, there is more resistance because there is less FSH receptors on those oocytes, on those granular follicles. So The overall concept is different. What's happening is different, but the treatment is still the same. It's pushing the ovaries harder. Higher follicles, go for a milder dose. So then I've changed this slide about 10 times in the past 2 years, which tells me that I'm as confused as anybody else on coming up. So what I'm saying is start on 150 for young women. But if you see a very high AMH, a very high LH, think of increasing the dose of HMG and play with that. But you can only do that in an antagonist protocol. See, your trial and error will work if you can be saved, if you can prevent ovarian hyperstimulation. So in this entire concept, what I'm saying is, if you have large number of follicles, a big thika, go for a higher dose, step down. If you've got a lower number of follicles, look at the size of follicles. Follicles of 5 and 6 millimeters will stimulate very easily. Even if you give them clomiphene for 5 days, you'll see a follicular growth. You can push the patients differently. So try and think about it. And after the age of 40, I think you can do whatever you want. You can think as much as you want. There's not much you can do. What I try to do is I try to get more eggs, because what you want to basically see is how many blastocysts you can get. Even at the age of 40, if you get 10 blastocysts, the rate of euploidy is between 10 and 20%. So how many blastocysts are needed at the age of 40 to get a euploid blastocyst? Around 10 or 15. So you're already on the losing level, and it is difficult. And women, I think, find it very difficult to accept that IVF in the 40s is not going to work. And they'll have to look at different options. Again, remember, you can do all these permutations and combinations on an antagonist protocol. First, if you want to use the antagonist protocol, you must believe that your knowledge is limited, that you're not supreme, that you're not God. Though you use a long protocol, are supreme human beings. They have no fear, and they're very close to God because they know the exact protocol to work. With antagonist, you're saying, I don't know. I don't know how this ovary will respond. I'm going to take a chance. Because let's say you start somebody on 300 and 40 follicles get recruited. You're in deep shit. So what do? I can use the analog trigger. I can opt out. I can do a step down. Think about it. See, so I always thought, when I was in my 30s, I thought I'm a very clever doctor. By the time I got to my 40s, I realized it doesn't make a damn difference. I lowered my IQ and I understood reproductive medicine better. And this is what I'm telling you. It's just, don't look at your results. See, we didn't do biochemistry. Why did you do gynecology? Because you wanted to sleep well, earn a lot of money, and be happy. Why do you want to look at complex biochemistry? Why do you want to look at insulin levels? That's not our job. We've got our endocrinologist friends who will do that. They have studied a lot, give it to them. Just use simple belief and you'll be able to get good results. So what is the ideal days of stimulation? So, and I'll say, this was a good study and they looked at a large number of cases. So what they did is they said, these are not PCO patients. They're all normal responders. And less than 8 days stimulation, 9 to 11 days, and 12 days. And what they saw that 9 to 11 days, they seem to get the best chance of pregnancy. Why is it? Again, look at a menstrual cycle, and that will give you an idea. In a normal responder, I'm not talking about PCOS. In a normal responder, look at, and even a poor responder, look at what is her follicular phase. If she's got a 24-day cycle, she's going to have a short follicular phase. So collecting eggs makes sense then. But if she's got a 28, 30-day cycle, her follicular phase is going to be lengthened. What does ovarian stimulation do? It fast tracks, so it makes follicles grow faster. So you suddenly decide, oh, follicles are there at 25 millimeter on day 8, let me trigger. And you see a poorer blastocyst culture. So, at the end, what you say is speak to the ovary. The ovary will tell you when is the right time to trigger. And I think it is closer to a woman's follicular length of follicular phase. So if your follicular phase is 30 days, the period is 30 days, the follicular phase ends on day 16, continue the stimulation to day 12 to 13. But if she's got a 28-day cycle, then 11 to 12-day stimulation is adequate. And that's my theory. So again, ask the follicular phase. So what I tend to do is I write 28 days, and on my folliculogram, I usually write is trigger around day 12 to 13. That indicates that she's got a normal follicular phase. So what causes accelerated recruitment, poorer outcomes compared to delayed response? Is it a low AMH? And again, a low, which is the best way of assessing it? I always say, IVF is a race. It allows you to look at how the ovary is performing and how the ovary responds. And the ovary responds very differently. Everyone responds differently. It's only young women in the early 20s who will have a very fixed way of response. And as women cross nearer that 30, you will start seeing a very variable response. Again, believe, why does that happen? Women recruits her best follicles first. Why is it that the army wants 25-year-old? Because your reserves are best then, because you do the best. So including, I believe that the Indian Army is changing. My father and grandfather were both in the army. So I always take fascination. And the reason is because the army's general age is 29. Hang on, even the ovaries start going variable at 29. So what do you want? The best dealing ovaries at 25 to 26 years. So in the same way, the younger the ovaries, you have a more predicted response. So the question is, how much FSH do you give? Now, once you give a high dose of FSH, within 24 hours of injection, a high FSH is attained. How many of you all measure FSH during stimulation? Very few. And it's very important. The reason is, once you start touching 20 to 25 milliequivalents a liter of FSH, that is during stimulation, that's the maximum you're reaching. After that, giving any additional dose is a phenomenal waste of time and money. So usually around day 8, I measure the FSH, LH, E2, and progesterone. And I've got the lab to give me a very good rate to do it. And what it is telling you is, it's telling you, have you reached your maximum FSH, serum FSH levels? Yes. Then look at the response. So it creates a window in the first 36 to 48 hours where you can stimulate the ovary hard. And that's the reason why if you see follicular growth, again, remember, if they have entered your classroom, which means they have crossed 10 millimeter, after that, fiddling with the dose does nothing because you've reached high FSH levels. But if there is no recruitment, you may still have reached high FSH levels, but the follicles have not budged. There, increasing the dose will help. So let's look at the different protocols. Again, you can do a pre-treatment if you want. If you want, we can do, I've not gone through the pre-treatment. You can use the pill, you can use estrogen, you can use progesterone. But what is the flare short protocol? The antagonist is not the short protocol. The antagonist is an antagonist protocol. The short protocol is an agonist protocol. And a short protocol makes use of the agonist for from day 1 of your period right to the end. So what does it act? It acts as a flare in the beginning and then it downregulates. The surprising thing is that we don't have any antagonist in Europe now. Short acting, it's all out of stock. So I'm using long acting antagonist to trigger. But that's very interesting. I've learned something new there. So the microflare is again the same. You want to mix, you use a small dose of analog for the first 5 days. So it creates a flare of FSH, LH, and then you decide to use the antagonist. Agonist protocol, antagonist protocol, day 5, day 6, you start the antagonist, and that's the fixed antagonist protocol, and then you trigger accordingly. So they're just, I like to put diagrams. This is how I describe to patients. It makes it easy. Long protocol, again, you can use a long-acting analog for 3 weeks, and then you can continue the analog, and then you continue. I very rarely use the long protocol. I'm not saying it's out of fashion. I do think it's required in some cases. In some cases, it gives you a better control over premature luteinization. It gives you better synchronization, and there's a role to use it in some patients. But I don't think it's poor responders. I think in some cases of normal responders who have a poor recruitment, even with pre-treatment with Proganu or the pill, those patients benefit on the long protocol. So when you look at monitoring in IVF, why you monitor? Because it gives you an idea of how the ovary is progressing. It gives you an idea whether your stimulation dose should change, and you avoid ovarian hyperstimulation. When do you scan? I normally, on the antagonist, I usually scan around day 4 or so, by which time I get an idea whether to increase the dose or it's working. So I tend to scan a bit early. I don't do much blood tests because the blood tests don't give you an indication around day 4, day 5. It's normally an E2 may tell you whether there's been no recruitment at all. So if you want to do a blood test, the only blood test you can do is do an E2. I'm not a great believer of doing LH in the beginning. I think if you are very worried about a high LH, then freeze embryos. Then you don't have to worry about all those things. It gives you an idea about follicular response, but E2, what does E2 tell you? It tells you about granulosa cells. What does E2 not tell you? It doesn't tell you about the aging process. So as women age, their granular cells become less. So what happens? They produce less estrogen. So a 40-year-old stimulation will produce 25 follicles and have a lower estrogen than a 24-year-old. Because each follicle has a lower amount of granular cells, and that's what happens with the aging process. Once the E2 starts rising, then it doesn't tell you anything about egg numbers, egg quality, but it tells you about the risk of ovarian hyperstimulation. And again, the progesterone is a big story whether it should be 5, and there's still a controversy. I believe if you are generally worried and you're not certain at what progesterone success rates drop, just freeze at any progesterone. Very simple. I do that. It stops my headache. Again, FSH medications, remember, there's a small window where your FSH rises. Can you lengthen the window of recruitment? Yes. Start in the luteal phase or start with clomiphene. Clomiphene allows you to extend the window. And when do I use it? Sometimes I just don't know what dose to start somebody on. It does happen. It does happen where I just don't know. I don't know whether to start on 150, 300. So I say, why don't you take some clomiphene? And take some clomiphene and see me in 3 days' time. And in those cases, I give a 200 milligram clomiphene. Why 200? In cricket, what is better, 100 or 200? 200, isn't it? So it makes me feel nice. But equally, when you give more clomiphene, you increase your FSH faster. But it gives you a slightly higher level of FSH. And I do that. And by day 3, I decide what protocol works depending on how many follicles have been recruited. Role of progesterone is very tricky. I think it's about 5 years ago, we believed that if your progesterone on the day of trigger reached more than 5 nanomole, you should freeze. But we're not entirely convinced about it. I freeze majority of my embryos, so I don't tend to worry. But a high progesterone worries me about a different matter. And I think on the day of trigger, a high progesterone tells you the risk of premature luteinization. And if you see a progesterone very high, remember, it's not a question of overall ovulation. You will start seeing follicles disappear. And that's something which the newer concept, there's a very good paper. I'm trying to present it on YouTube, but it's so complex that after 2 readings, I still don't know how to present it. It's one, understanding it. Teaching is a very different concept because until you completely understand it, you can't teach. And I'm still finding it difficult to understand it, to simplify it. So the day I simplified, I'm carrying it every day. It's in my bag from the last month or so. So the day Mother Saraswati has been here. So The day she opens my mind, I'll teach. High stimulation, again, many large follicles with FSH HMG are very similar. HMG is much better. You need only 1% of LH receptors need to be occupied to elicit a granular cell steroid response, which means to push the patient into luteinization. The cutoff, again, 4 to 6 p-mole, we don't know. You know, everyone is debating about what is the ideal progesterone where you freeze. If you use a folliculogram, it is quite good. The reason why you should use a folliculogram is, see, we are different from engineers, we're doctors. We are, our memory is pictorial. You know, you see a blue nevus, and that remains imprinted in your mind, and we possess phenomenal pictorial memory. Engineers are different. Engineers possess phenomenal numerical memory, and that's the difference. And so when you write numbers, and sometimes people from India sent me this folliculogram with numbers, 11, 12, 11, 12, 13, 14. And I believe, gosh, why did you become a doctor? You should become an engineer. You would have made millions more. Because this allows us to find out how the rise is happening. The usual trajectory is 45 degrees. If you have a faster response, why does it occur? It occurs in women who are older. Why? Because follicles get recruited very fast. Equally, it happens when your dose is higher. If you give somebody a high dose, you accelerate recruitment, and sometimes you decide to trigger ovulation very, very early. See, if you see a response like this, you see, what would I do here? I do that because this is a PCO woman, and I see only 3 follicles. Only 3 follicles have entered the phase where they can be dominated. I would cancel this cycle and tell her very clearly, this is not working. Next time around, we'll be able to get a better response. And it tells us that 150 is not breaking the threshold of multiple follicles. It's time to go back. So let's lower the cost. Let's lower the burden of large costs. Let's lower the burden of multiple cycles. This patient may benefit from 300. So you look at steady growth of follicles, you look at synchrony of follicles. So if you see 2 follicles at 22, 23 millimeter, and then you see a load of follicles at 18 millimeter, wait till those follicles catch up. If you see where your bulk of follicles are and catch up. In poor responders, if you see a bulk of follicles coming up, you may get more eggs, but it's difficult to see what's happening. Again, measure your follicles, measure each of your follicles. It takes time. How small are they? That's also important. It will tell you that these small follicles are not going to get recruited. These are your recruited follicles. So it gives you, giving you an early scan will give you an idea of how many follicles will get recruited. That's what I say, 5 millimeter, 4.3 millimeter. And these small follicles are just not going to get recruited. And this is again, poor responders. In PCOS women too, it helps you to see how many follicles have started the growth by measuring them. Do you do Dopplers? I don't do it, but I believe a lot of Dopplers do it. It looks good. And I think the only reason I do it is because it is color. Unlike men, women enjoy colors. They enjoy red. And, I don't know how many of you all have read A Psychology of Color. The red color is the first color that came to us. So humans initially were born colorblind. And the first color to come was red. But who gets it first? It's women who get it first. So men continue to be colorblind in evolution, and women get the first color. We get the red color. Why? Because women collect fruits, and you want to know which is the ripe fruit. And how do you know that? The red color. So again, if you look at all magazines, everything is in red and blue. Why? Because women, it attracts women, the red color. And so women are in color, men are in objects. If you want to stimulate men, then get cameras and cars and so and so. So red color is good. So if you want to impress women, then put some Dopplers. Does it influence the results? The answer is no. But it makes you feel good, makes her feel good. There's a lot of color, a lot of sound. So you can do that. But otherwise, what is the concept? The concept is that around the time of ovulation, just before ovulation, perifollicular growth is the best. It has been tried and tested, but in randomized controlled trials, we haven't been able to literally predict how many eggs are there. The younger you are, you get more eggs. The older you are, you get less eggs. So that's the only thing that we know. So you see, it looks beautiful, doesn't it? And everyone likes it. You know, your patient like it, you feel very confident. But I think this is in a young patient. You see follicles generally having a good growth. That's the corpus luteum. And that's important. Why? Because, and this is a luteal phase start which I did. And this is a post-ovulation. But see the follicles too. They're bigger. You're more likely to stimulate them. But also what happens is as ovulation occurs, the blood supply moves inward. So it's peripheral and it moves inwards. And the velocity, the API and RI both change. And that's why you see a huge amount of growth in the corpus luteum. The endometriosis protocol is a complex. I think, does endometriosis affect oocyte quality? The answer is yes, it does. Can you do anything about it? The answer is no. So that's a very simple answer. What do you do? In the past, we used to give 3 months of GnRH analog, but what it knocks off the AMH, it knocks off the follicles. And can you decrease AMH? And using long courses of analogs can reduce AMH. So what I tend to do is I say, let's try and get the best follicle count. Let's collect the eggs. Let's get to blastocyst and then decide whether we want to downregulate you for the endometrium. So see, this ovary is brilliant. You know, this is, would you do surgery? The answer is no. What you'll do is you'll end up destroying that ovary. But there are a lot of follicles, and that's what we did. And these ovaries are quite good ovaries. What they need is, they just need stimulation, embryos, and then freeze the embryos. And if you have something like this with a good follicle count, go ahead and don't do surgery. But you have something like this, large follicles. This was again a case. I could not do a transvaginal scan on her because she had very large endometriomas. But here, I think just to get access, trying to drain the ovary is beneficial. So that's in brief about how to think about planning doses. And I think when we talk about PCOS, I think we'll see how to stimulate PCOS, and we'll take that on a different level.
I think we'll break for lunch because there's one lecture on batching and synchronization which will follow after lunch. I'm so sorry to tell you that lunch break will be just for about half an hour. You can carry the plates inside. Exactly after half an hour, we'll start lecture with batching.
If you want to feel full faster, take a lot of rice, take a lot of carbohydrate.
We'll have a background music and put off to sleep. Thank you so much. Good afternoon, everybody, and we are starting off with the lecture. So good afternoon, everybody, and we will start with the session because I'm just lagging behind by about half an hour. Want to cover up because Dr. Mohan would be arriving any time and we will have to give time to his lectures as well. I'll be taking a lecture for all of you on synchronizing and batching first, and this will be followed by Dr. Anil Gudi's lecture on polycystic ovary and IVF in polycystic ovary. Next would be Dr. Sharyu Mohite will be talking about oligospermia. And then is an IUI lecture and we go ahead on the protocols. Starting. Yeah. Your belt it outside. Okay, we start off this lecture on synchronization batching, which is again very commonly practiced in Indian scenario. The various reasons which we do is one of the reasons could be an economical reason because the centers were very young and they would love to batch the protocols and batch their IVF patients so that the usage of media, the usage of every other resource goes very economical for them. And most important is to organize the shifts of embryologists and doctors. A lot of centers call upon other doctors to do their cases or They could be hiring embryologists who are so short in India, and the embryologist could be a batch embryologist who would come just to conduct the batch and go away. So batching is going to be very, very important for them. Management of limited expertise available. And a lot of people in the initial years of their IVF practice, when they do not have a full-time embryologist, highly rely on batching and this whole concept. So I'm going to touch three concepts here. One is batching, second is scheduling, and the third is synchronization. So what we mean by batching is what I just told you, that we just want to batch so that for economic or various embryology available reasons that we want to batch it up. Scheduling means we could be having some issues and we want to avoid doing IVF cycles on those particular days. For example, there is a marriage in your family and you are away for a week's time, or you could be touring somewhere for a week, or you're going for an ASHRAE conference for a week's time, and then you don't want any cases to come at that level, but you don't want to lose on your patients at the same time, and how you will schedule. In the West, most of the people work only from Monday to Friday. So they try their best not to have any pickup schedule on Friday, Saturday, so that they can move on. So that's a scheduling part of it. And synchronization is another story altogether. Synchronization is a story about, suppose you start a particular protocol on second day and go ahead with execution of the whole IVF stimulation. At the end of the day, at the end of the stimulation, what is your oocyte yield? And can you do something before you embark onto your IVF so that your oocyte yield increases? So synchronization is all about getting a better oocyte yield. It has nothing to do with your batching or scheduling. So these three are extremely different concepts. What are the benefits and losses of this? Obviously, the big benefit is a planned distribution of workload would be there, and this has less openings of the incubators, better organization of shifts, and everything can be planned that way. But the problem with batching especially is this, that any small issue, any small issue of an electricity failure in India, or one of the batch of gonadotropins is not doing well with you, or any temperature, any contamination in the incubator or the laboratory, and any failure of instrument can affect the whole batch. Let's say you have a batch of 8 patients and OM pickup pump doesn't do very well on that particular day. All your 8 pickups will suffer. And nobody has a spare OM pickup pump in their laboratory. So, we don't think very widely when we establish our IVF units. We just have singular instruments. So any failure of a singular instrument can suffer very badly. So that's one more advice or suggestion I would like to give to all of you, that as you go on in your IVF practice, see to it that you have spare instruments. Like having a spare ICSI is very difficult, I agree, but having multiple incubators, at least one more spare OM pickup pump, all these small things will make a lot of difference. And the question wouldn't come with OM pickup pump. There's so many IVF centers at nooks and corners, you can always borrow one. So let's try and answer why there is an asynchronous growth when it comes to follicular genesis, and what protocol should we use so as to avoid asynchronous growth, and can we synchronize it? And does it really matter that you're synchronizing? Does it really increase the live birth rate or clinical pregnancy rate? So at the end of it, are you going to be happy, or you're still sad that you're not able to synchronize those follicles? I've already shown you this diagram, and this is the diagram which is telling you that there will be an asynchrony of follicles because the luteofollicular transition will take place early. In a younger age women, the luteofollicular transition will take about 3 to 4 days before the onset of menses, while the older women or women with diminished ovarian reserve with short cycles, that luteofollicular transition will take place at least 7 to 10 days prior to the onset of menses. So there will be a rise in FSH level, and that FSH will click the threshold of few follicles and they will start growing. So by the time you come to day 2, you will have some follicles already recruited. And then you start your gonadotropins typically on day 2, wherein there is an asynchrony and we are just going to increase the asynchrony. So to synchronize, either you have to do something at this level, wherein you don't allow the FSH to rise before the onset of menses so that you can synchronize, or you synchronize at this level, you don't allow the premature luteinization to take place. So these are the 2 ways you can synchronize the follicular growth, and you can have maximum oocyte yield in your given IVF cycle. I think the hot favorite from the pre-treatment point of view has been OC pills, and it's been used for years together. And the reason why OC pill pre-treatment became very famous was all this IVF started with Belgium really progressing very well, and they almost offered 9 IVF cycles free of cost in about 2 decades ago. And all the big bosses today, then they were very young and they would move from country to country like Macau, Cyprus, Spain, and they would conduct batches of IVF. Now, all those women were kept on OC pills, and then they went ahead with batch IVF stimulations. At a point, they realized that the kind of results they're getting in Brussels Free University, the same results are not there whenever they are doing batching. And that's how the whole investigation about whether OC pill treatment is really harmful to our patient started off, and that evolved a different story. So if you read the initial papers of OC pill pre-treatment, they all have come from the Belgium group, the Human Fatemi or George Grissinger. All these people have published literature on these things. But what OC pill pre-treatment does is there is a 20% fall in ongoing pregnancy rate. And that's a sad part, especially when you do fresh embryo transfer cycles, you have a less pregnancy rate. Then there is higher dose of gonadotropin required because you are suppressing and then stimulating. So the amount of gonadotropin required is high, and there's an increased duration of stimulation. So all that does increase to your cost. But when the meta-analysis got published, and George Grissinger put a very beautiful paper, and he says the answer lies in the data itself. The paper is titled that way. And what he says is, well, all those trials which have been done they're using different OC pills with different amount of progesterones and different amount of estrogen. The duration of OC pill treatment has also differed. Some people have given as less as 12 days of OC pill. Somewhere it has been given almost for 40 days. And the saddest part is, after doing OC pill suppression, they all have received only recombinant FSH stimulation. So is this recombinant FSH stimulation more responsible for less ongoing pregnancy rate after a pre-treatment? Because as we understand, and we will understand a little further as well, that OC pill treatment will suppress the LH further. So this is a typical sample batch calculator. You can say how it goes, that you have a fixed embryologist visit. Generally, the embryologist visit would be 2 days before, like 36 hours before you'll be giving you triggers. Generally, stimulation goes for about 11 days or 10 days. So you will, you'll adjust your day of stimulation will be decided. And about 5 days before the first day of stimulation, you will stop your OC pill. And generally, everybody would give about 5 days of washout period for the OC pill effect to go away. A few of the women will get menses, a few may not get menses, but on a particular day, you declare that as a stimulation day, start day, S1 day, and you start the stimulation further. So what happens? After OC pills is stopped, within 2 days' time, in 48 hours, the FSH starts rising. But your stimulation may not start then. You will wait for the menses to get stimulation, and will start stimulation by day 2. So the whole idea of not allowing the luteofollicular transition to take place and the FSH going up doesn't happen. The FSH still does go up, so asynchrony still continues. So OC pill treatment, if you start your stimulation on day 2 after the stoppage of OC pill, it is of no benefit from the synchronization point of view. What on top of that, the OC pill will suppress FSH as well as LH. The FSH will recover fast. In 5 days, the FSH will recover. But in a subgroup of patients, the LH does not recover. So you're starting your stimulation with a low LH pool, and that will again suffer the kind of stimulation you go ahead with. So with OC pill, if at all you want to synchronize, you start your stimulation after 48 hours. So you stop the OC pill today, day after tomorrow, you start your stimulation. Don't wait for the menses to come. And this 5-day washout period, you don't get. Then you are at least synchronizing the follicular growth. You're not allowing the luteofollicle transition to take place. And that your FSH injection, your stimulation itself is the thing which is raising the FSH and go ahead and stimulate further. So before 48 hours, if you start, that is better. So 2-day washout period. Let's go through some literature papers on OC pill pre-treatment. There are earlier papers in 2009, 2010 came from Sidrin Deodrin, and they also said the same story. So I'm quoting 2 papers of effect of pre-treatment of oral contraceptive pills and progestins on IVF outcomes in women with polycystic ovary syndrome. It is very natural for all of us that we like to induce menses to go ahead with ovulation induction or IVF stimulation in PCOS. But believe me, if you don't induce menses, go for a new cycle, let them get spontaneous menses and go ahead, you are doing much better from the follicle health, oocyte yield, and even implantation. So even in IUI cycle, suppose you want to give us induction of menses by OC pill or progesterone, and then you put up an IUI cycle, your pregnancy rates are going to be lower. If you do it new, without any induction, a spontaneous cycle, obviously you'll be better off. But again, it's a test of patience, and some of the women will have menses every 2 or 3 months, and they don't want to postpone their treatment. The time to pregnancy is very, very important. So if you look at the polycystic ovary and look at the control group where there was no pre-treatment, the progesterone group and the OC group. In the OC group, which is gray in color, the pregnancy rate, the conception rate, the clinical pregnancy rate, live birth rate, everything is kept low. On top of that, the miscarriages have increased. And when you come to the frozen transfer cycles, the frozen triple cycle, in spite of doing a frozen transfer cycle, later on, your miscarriage rate has still kept high. So that has not been improved when OC pill pre-treatment is given. So given a chance to do an antagonist cycle, best is not to use any pre-treatment, more not to use OC pill as your pre-treatment for IVF cycles. I'm so sorry for this. 1 minute, let me just escape this. Okay. So this is a similar study, the effect of pre-treatment of oral contraceptive pills in cumulative live birth rate, in vitro outcomes in ovulatory women. We looked at the anovulatory women, the PCOS. What about ovulatory women if you do pre-treatment? Again, the same story. Whenever they have given OC pills, the clinical pregnancy rate, the fresh embryo transfer live birth rate, and cumulative live birth rate, all of them have suffered. And as the OC, you look at this graph, the cumulative live birth rate also suffers. So OC effect could be there on the oocyte quality itself or on the embryo quality, hence low cumulative live birth rate is reported. And OC group, obviously in this study was younger with low FSH, but in spite of a younger group, they reported a low fresh live birth rate and cumulative live birth rate with OC pill pre-treatment. And if we understand, even if women who are taking OC pills after about 6-7 months of OC pills in the time for pregnancy, the chance of spontaneous pregnancy in the first 3 months after stoppage of OC pill, spontaneous pregnancy is also low. So LH, estradiol, and endometrial thickness is all lower after OC use, and you get more thinner endometrium on the day of HCG trigger if OC pill pre-treatment is given compared to no pre-treatment. So OC induced lower hormones and stimulation induced rise on the hormones. It commonly causes an asynchrony of endometrium, and hence the fresh live birth rate is pretty low when OC pill treatment is given. So it affects at various levels. Basic effect is on the LH drive. The LH keeps very low, and that is what is affecting the most. So some of the women, you can have progesterone withdrawal can be done, especially in PCOS. If not, OC will be using commonly progesterone to induce menses, and you can have an early start off of IVF cycles and not wait for spontaneous menses. Since we all do freeze-all cycle, the progesterone pre-treatment does not affect the fresh transfer live birth rate or even cumulative live birth rate. And number of oocytes retrieved remains the same, but is better than OC pills. So if at all you want to give something for scheduling or batching, progesterone is far better than giving OC pills. At least it does not affect the freeze-all cycle. The cumulative live birth rate may be affected. The freeze-all cycle is not affected with these treatments. Let me just talk a bit about the OC pills more, and the important part is the LH. If the LH comes down, if it doesn't recover, then you're starting a stimulation with a low LH pool. And when you're starting a stimulation, imagine you're given OC pills, 5-day washout, the LH is still less than 1.2. You start your stimulation, GNSAF comes up, that does not allow the LH to go. And then you are antagonist on day 6, keeping the LH low. So this oocyte, which is now forming or picking up, it is bathing in a low LH pool for nice about 15 to 20 days. And obviously this oocyte will be having less competence. Not only that, when you start stimulation on a low LH pool and you land up giving a GnRH agonist trigger, your chances of empty follicle syndrome is very, very high. So if you want to avoid it, you must have a good LH level at the start of the stimulation and then give GnRH agonist trigger, and then your chance of empty follicle syndrome or low oocyte yield in PCOS, this is one way of avoiding as well. What about estradiol pre-treatment? And that's my favorite, I would say. So when you give estradiol during the washout period, the endocrine profile shifted from a suppressed FSH-LH to those in spontaneous cycle. And this shift takes place very fast, just in 3 days. So with estradiol pre-treatment, you don't have to give a period of 5-day washout. Just 2 or 3 days is more than sufficient. But the follicle size, in spite of the washout period, the follicle size in the cohort remains the same. So it does achieve a reasonable synchrony. When E2 pre-treatment is there, then after that, there's a rebound rise in FSH is higher. The follicle sizes in the cohort could be different later. And 1 to 3 days washout time is optimal. You don't go for a large washout time. You don't go for 5 days and 7 days. Just 1 to 2 days is more than enough. Don't start stimulation like you stop your OC pill in the estradiol in the morning, and on the same day you start stimulation. Don't do that. So you have to allow at least 1 day or 2 days of washout time. Otherwise, the FSH level is very, very low. Compared to OC pill, the estradiol alone suppresses the FSH level very, very low, and that will take a little higher dose or longer stimulation to go ahead with. So this is a nice paper on a pre-treatment with estrogen does not affect IVF outcome in compared to no pre-treatment in antagonist protocol. It's a randomized trial. And they gave about, Progainova was started 7 days prior to the expected menses. They gave about 4 milligrams of Progainova to all of them. And they scheduled the whole thing. The pickup was planned between Monday to Friday. The trigger was given on Saturday to Wednesday. Stimulation 12 days of the start stimulation on Tuesday to Sunday. So you can just plan it up beautifully. So let's try and plan it up. So suppose you are visiting Pune on, let's say, Monday and Tuesday, and you want to do pickups in Pune on Monday and Tuesday. So generally, all your patients are going to require, let's say, 12 days of stimulation. Let's be a little open about it. So Monday means all your trigger will go on Saturday evening. So you're going to give your triggers only on Saturday evening and on Sunday evening. If the trigger is going to go on Saturday, 12 days before that is your start of stimulation. So generally, if your pickup is on Monday, your stimulation will start on Monday. So it's 14 days time exactly. So you start all your stimulations in Pune on Monday and Tuesday. So that your pickup after 12 days of stimulation, your pickup will come on Monday and Tuesday. Simple calculations. Now the lady comes to you, not on a Monday, but a Wednesday before that. She says, well, I'm second day, I already paid you advance and start off the stimulation. You say, okay, I can start up, but I'm going to start on Monday for these reasons. And you just take Progainova. Take Progainova, 6 milligram a day from today till Monday, till Sunday. Sunday, you stop Progainova. Monday, you come to me and we will start stimulation from Monday. So what is the endocrinological parameters on day 2 and on Monday? Or let's say stimulation start day 1. What will happen to FSH? FSH may come down a bit, but in 4 or 5 days, not hugely. What happens to LH? LH doesn't come down. Does it improves? I'll come to that story. So practically, and what happens to the cohort of follicles? They remain the same. Since the FSH is not rising, the follicle is not growing. So whatever AFC you want to see on this particular day, the same AFC will be seen on the other day as well. So endocrinologically and from the AFC point of view, you're not making a bad difference, an ill effect there. And you're still able to do a fresh embryo transfer as well, because there's nothing wrong. You're just giving estrogen there. So it's very easy to schedule and plan batches on giving estrogen pre-treatment. So let's see whether the results make a difference. And this paper is definitely telling, well, it doesn't make much of a difference. So FSH level could be very low at the start of the stimulation in the pre-treatment group. The washout of 1 day should be given. Since both arms, E2 pre-treatment and no pre-treatment, has the same number of follicles, they said the synchronization is not there, because in non-pre-treatment group and if the synchronization is achieved with estrogen, the pre-treatment group should have more number of oocyte yield compared to the non-pre-treatment. They achieve the same. That's why this synchronization is not there, but results were the same. So look at the results. Look at the hormonal measurements. What surprises me in this particular paper is the LH level. The LH level in the estrogen pre-treatment group is 4.8 compared to no pre-treatment for 5.7. That really surprises me. Obviously, the estrogen level on the start of the stimulation would be different, but that wouldn't matter much. And endometrial thickness, everything is. And look at the AFC. AFC is all the fine. The higher dose in pre-treatment group was required, longer stimulation by 1 day, but the clinical pregnancy rate, ongoing pregnancy rate, and miscarriage rate remained the same. So, and this is all fresh embryo transfers. So be less assured, you can give some pre-treatment with estrogen and do fresh embryo transfers. This is a beautiful paper. This is by Diditively from Lille. And they have decided long back that they have very fixed stimulation days, and that's called S1. So all the stimulation will be started on that particular day only, so as to avoid work on Saturday, Sunday. So even if the lady gets periods on a particular day, the stimulation start date is pre-decided, the lady will receive some amount of Progainova. So in their study group, this is the protocol they followed. See, it's very easy to decide that you want to give Progainova for somebody who is ovulatory or somebody who's going to get regular cycles. What about anovulatory and the PCOS women? What they did wisely, they put the patient on to dufaston for a period of 20 days, 10 days. And after the dufaston over, then they put Proguanova, 4 milligram a day, till the stimulation start day 1. The lady could have got menses, lady may not get menses. That wouldn't make a difference. Obviously, only if the lady gets menses, they would do an embryo transfer, fresh embryo transfer. Otherwise, they probably won't do. Or the lady, even if she gets in 1 or 2 days of stimulation, they may probably, yes. And then the standard anticycle was given. And the ovulatory is very simple. Just give estrogen pre-treatment till the standard S1 dose, S1 start day, and then you start the stimulation further. Any confusion at this level? Understood this well? Yeah. And look at the studies. What they classified the whole group into different days of Proguanova received. So the A group received just 1 day of Proguanova, while the F group received 6 days of Proguanova, and then the stimulation was started. What is impressive here is look at the LH levels. As the number of days of Proguanova went up, the LH levels peaked. And this is very important to know. Okay, so the LH level on after receiving 6 days in Proguanova, the LH level was better. It is 7.9 compared to 4.2 in just who received just 1 day of Proguanova. And higher E2 on day of HCG, better ET, low progesterone because of deeper suppression. Obviously, the success, they do a fresh embryo transfers there as well, and they're very happy about it. I'm telling you another story now. So if you at all you come across a situation where your LH is very, very low, just put the patient on 6 milligrams of Proguanova. What does Proguanova do? It will build up estrogen, and this estrogen will tell the pituitary to secrete positive effort and more LH. The LH won't surge, but the LH will increase. But that increased LH is supposed to act on the follicle and then produce progesterone. But that follicle is not there because FSH is not there because of Proguanova. So the LH, high LH cannot act on the follicle. So there is no rise of progesterone. FSH is low, but the LH peaks up. So in a patient, if you're given pre-treatment, and if you see that your LH is less than 1.2, don't embark onto stimulation. Just give Proguanova for 6 days or 7 days. Look at the LH levels again. Once you're satisfied the LH has come beyond 2 or 3, then you can start your stimulation. So estrogen, this is a beautiful paper again published, which says that estrogen treatment beyond variable number of days after menses does not have any influence on outcome. And there are few patients in this particular paper, they received 28 days of Proguanova, and then the stimulation was started. And I really don't know why they received 28 days, but this group was there. So there was no effect on the ongoing pregnancy rate or clinical pregnancy rate. So can you use GnRH antagonist as a pre-treatment? And this GnRH antagonist study was first, this was the Peter Humadan thing, but Franchin in 2005, they said he published this study of hormonal manipulations of luteal phase to coordinate subsequent antral follicle growth. I would like you people to go through this study because he has really compared using OC pills, estrogen, and antagonist all together in one paper. And what they give is the cetrorelix 3 milligrams. There's a long-acting cetrorelix was given on the day 25 of the cycle, and day 2 cycle parameters in the study group and control the study. And with ANTA, obviously there was high LH suppression than FSH due to low, because of low half-life of LH, the LH got suppressed more and the FSH was still there. And look at the results. If you go to the results, look at the serum FSH level in the control day, it is 6.7. The FSH, when they gave a pre-treatment, it was 4.5. The estradiol level is quite dropped low, and the follicular sizes, the mean follicular size is 5.5 and 4.1. So it was pretty significant that giving cetrorelix injection that could get AFC herd together well. Luteal crash was described by Peter Humadan. This was one of the early studies which is published, and he did this in his poor responder group. And he defined his poor responder as women with 4 oocytes or just 5 follicles, FSH, if the FSH dose required was beyond 2000 IU, and this was done in GnRH agonist protocol. And the luteal crash versus the GnRH agonist protocol, that was comparative study. In the crash, there was no flare. It avoids FSH. So he gave mid-luteal. Once they confirmed the corpus luteum, they gave a 3 milligram cetrorelix. And obviously, the active luteolysis took place. And then they started the stimulation. And when it comes to results, it comes to the crash protocol and the long agonist protocol. Well, crash protocol did perform better over the long agonist protocol in this particular study, where the good available embryos are there. And the oocytes and follicles, everything was a bit better than the long agonist protocol. So you can use GnRH antagonist as well, but you can't use it for scheduling. You can only use it to synchronize a few follicles there, and that is possible. And this has been recommended in Posidone 3 group, that you can use antagonist protocol, crash protocol in that particular group. A lot of us, a common question which is asked to us when we talk about an antagonist pretreatment, common question asked to us is, we commonly get a high LH polycystic ovary patients. The LH is 12 and 13 and 40, and some patients could be having a 30 and 36 LH. Now, will we start, will you start antagonist first, take the LH down, then start stimulation, add antagonist again, give agonist trigger, and then freeze all? That is what logically comes to your mind. But it is just a cosmetic treatment for the whole thing. And Anil is going to talk about just a cosmetic treatment, just makes you happy. It wouldn't make any difference. You just realize a high LH means you require to use a higher dose. At the end of this antagonist, so-called, you wanted to give that cosmetic treatment. You got the LH down after 3 doses of antagonist. You put the patient on RFSH. You are still hampering or harming the patient up, because you got the LH down and now you're giving RFSH to it. So the lady is going to have LH deprivation through the stimulation protocol. So I wouldn't agree to this at all. I would rather give maybe 450 IU of stimulation. There are patients who are very outliers, where the LH is very high, 20, 25 LH is there. I would just go high on my stimulation, or I explain to the client before that I will start a standard 300 IU. If you're not responding, I may have to go up higher. And very commonly, we'll land up using a combination of gonal-F menopur in this particular group. So just because it's a PCOS is a high LH, we don't use gonal-F alone again. Even if you go by the Megasite HR trial, it also says that you're using a good LH activity is very much needed. And that's why in the first talk I tell, the cumulus doesn't have LH. So don't worry about getting oocyte getting affected very badly there. There's something called GnRH agonist stop protocol. Now we have a whole lecture on GnRH agonist stop protocol, and Dr. Sherry is going to do this lecture tomorrow evening. I would request all of you to attend that lecture up, because that's going to really tell you a very novel way of achieving synchrony and achieving the best success rate. And this particular protocol which can be used for your normal responders, or even for your mild polycystic ovaries, or patients with Posidone 3 also. You can use these protocols to have a good amount of synchrony. And what we realize is in GnRH agonist stop protocol, you get a better synchronized growth of follicles. And Dr. Sherry will tell you to the physiological aspects of it. And definitely, I'm not going to discuss it at this point of time. So whenever you give pretreatment, again, I'm telling you, please do day 2 LH while using agonist, antagonist, or OC pill pretreatment. But E2 pretreatment, you don't worry much about the LH. LH will always be high, and you will get a better results. So pretreatment for synchronizing follicular cohort in normal responder does make a difference. You have a large number of follicles you can get. Whether you give or you don't give, you still get good follicles. Polycystic ovary, it is generally we'd like to decrease the LH, and that's why we give. You can give OC pills and antagonists. Then always use HMG stimulation if at all you are doing that cosmetic treatment, but there is no improvement in live birth rate with pre-treatment in this particular group. So may not do that practice. Diminished ovarian reserve, every egg is important. So try your best to synchronize it, either with GnRH agonist stop protocol, and Dr. Sherry will tell you tomorrow about it. In Posidone 4 group, where the AMH is very, very low and a high FSH is there, if you use suppressive treatments like antagonists, COCs, or GnRH agonist stop, you're going to suppress the pituitary ovarian axis much further, and you may not get the same yield. So, and in these particular group, every egg is important. You can go for follow the AFC, random start, double stimulation, all that Dr. Goody will be telling us tomorrow about in ovarian stimulation for poor ovarian reserve patients. If the AMH is beyond 1.2 and Posidone 2, that is an unexpected poor response, this may benefit with a pre-treatment there, because you're going to achieve some amount of synchrony. But again, the subgroup of this Posidone 2, which is FSH receptor polymorphism, and if that is a reason for hyper response in the first cycle, because these are all retrospective diagnoses where you have gone through the stimulation and landed up in a less oocyte yield. So that FSH receptor polymorphism may not get a great benefit. Otherwise, this could be a good protocol therein. So if at all we are talking of synchronization, that is best with GnRH agonist stop protocol, which we learn tomorrow. Rest all pre-treatments are more for scheduling, and hardly you can achieve any synchronization. Well, thank you so much, and I'm ready to take any questions. LH is good. Don't reduce. See, what will happen? Suppose you have a high LH PCO patient. You will just explain her, your LH is high, so you are difficult to stimulate. Right? And I'm going ahead with a particular protocol. And if I'm able to surpass your LH and stimulate well and good, otherwise I may have to increase the doses. And how to decrease the LH then? See,
with down regulation, do we, I mean,
yeah, but that's again a cosmetic treatment. That patient, the high LH patient, will still require a good amount of stimulation. You can't down-regulate and put 50 IU of RFSH. That's not going to work.
and whether the miscarriage, I mean, there are few studies to say that if we start with a high LH, the miscarriage rates are more. Are there any studies that
See,
come up?
a few of these studies have come from the maybe 2 decades back. Those studies have come. See, I'm not talking of an extreme outlier case where your LH is beyond 30. Now, even I feel we need to come down on that. I can't give beyond 600 IU of FSH anyway. So I'm not talking of such a case. I'm talking of a simple hyper LH PCO where your LH is between 12 to, let's say, 12 and 16, something like that. The former studies about few decades back talked a lot about LH having low oocyte quality, low embryo quality, and high miscarriage rate. And those days, even as a part and parcel of investigation of RPL, we were doing the day 2 LH level. But that is a dead story now. We don't do those that way. So in PCOS, again, we will be talking about this. Getting a poor response in a PCOS is very common. It is because of hyperandrogenism, high PMI, high AMH, and high LH. And to negate that is high dose.
So no down regulation, high dose.
HMG you
Yeah,
said?
you must use LH in the stimulation because that LH, the high LH, is not making any difference to the oocyte there. The oocyte is still new.
Okay.
Okay. And what is the use of using LH in stimulation of PCOS? I think Anil will be telling about this. It is basically making your stimulation softer. Right? And then you don't allow a lot of intermediate follicles to grow up because that LH accumulates and then they stop growing. Your OHSS chances are less. You get a better endometrium. You don't get an asynchrony because of a high estrogen levels. The estrogen levels are moderate. And lastly, the day of HCG progesterone rise is not so common when you use LH. If you use an RFSH stimulation alone in PCOS, obviously that's again not a very important story today because we are doing freeze-all.
Yeah.
So we are taking that progesterone rise more as a marker of a good stimulation rather than something which is harming the patient.
Thank you, sir. So it will be like RFSH plus RLH or HMG for these PCO patients.
That's a big debate. There's a very nice paper published by Raula Orivito, who has done a comparative study of RFSH plus RLH versus HMG-HP. And he titles it very beautifully that the source of LH matters. So if you use HCG as a source of LH, it is better from the ongoing pregnancy rate, clinical pregnancy rate, and less miscarriages. Okay, but it is not statistically significant. So if I remember correctly, in the group, here about 45% pregnancy rate in the RFSH, RLH, and about 48% pregnancy in the HMG-HP group. But the 3% has a value to you and me and to the patient in front of us. Okay, so and a lot of these papers are pharma driven. Okay, the Ferring and Merck, they are at head on with all these things. So, but the take home message is whenever you use a small amount of HCG in your stimulation, your miscarriage rate drops down, you have a better endometrium and a better pregnancy rate.
Thank you so much, sir.
So we have always heard of a 5-day washout period, but with 48 hours, would the FSH be still in the lower range?
So in 48 hours, the FSH will go up and you will still have asynchronous follicular development if you start your stimulation beyond 5 days of stoppage of ossicles.
So why 5 days was?
I don't know. I don't give pre-treatment to anybody, madam. So my use of ossicles is in a year 1 prescription or 2 prescriptions, that too only to girls who want contraception. Otherwise, OC pill is out of my prescription totally, almost totally.
Right.
Same thing. So am I to get the message that no OCs for stimulation? It's only progesterone or estrogen?
You're right, actually. But then you commonly, Kursar, get outlier patient, and you being a senior patient consultant, you will get more outlier patients in your practice. Outlier, what I mean is, an FSH, an LH of 36. Now, agreed. To what extent are you going to increase your FSH dose? So when we kept discussing about, we had recently one patient had a LH of 102, another patient had 36 or 38 LH, one had 40. So we were also debating that when we teach, we'd like to increase the dose, but how high you can go, and will our 600, let's say I give 600 IU of HMG combination, 300, 300. So will it be enough to override this? And if not, if it doesn't happen, our patient is spending a lot of money. So, one patient, this I'm just quoting off the track. I used Degarelix. 2 patients we used Degarelix. Degarelix is a long-acting antagonist. You give about 40 milligrams of Degarelix. In one patient, I used 40, 20, I suppose. Sure, we used 20, 10 and 20. In one patient, we used 20, another patient, we used 10. So Degarelix immediately gets the LH down and it remains down for a pretty long time. And we stimulated these patients with Menopur alone because we knew we are working on a low LH situation. So in both the patients, I've been able to get embryos. I've not transferred them, but we are about 2 cycles we are able to do. We have 2 sets of embryos for both these patients. But these are real outliers. Let's talk of somebody between an LH of 10 to 18. And these are not outliers. They are common PCOS patients to us, wherein what I'm telling you will apply. You don't have to worry about the LH levels and get it down.
Sir, about synchronization.
What?
Synchronization. So even in some patients, even we use a Lupride agonist for a down regulation, still on day 2, day 3, we see follicles not synchronized, like many follicles more than 5 mm. So why it happens in such group of patient, and what is the line of treatment in next cycle?
That's a very, very interesting question. I think a lot of that answer will be Shari will be giving in her talk, but let me just answer it briefly. In old age women or women with diminished ovarian reserve, the luteofollicular transition could be taking place 7 to 10 days before. And if your GnRH agonist has not matched with that, let's say you matched it. The luteofollicular transition has occurred 7 days before, and you started agonist also 7 days before. With first 2 doses of agonist, there will be flare. With flare, whatever corpus luteum is regressing, it will move ahead. Am I right? And then the down regulation will start after the 3rd dose further. And a few follicles would be there, and these follicles will could be available. So our E2 levels could be little high for a few subgroup, till about 14 days after the first Lupride. These are studies done with Lupride depot, not with our day-to-day Lupride. Till 14 days, they have noticed a little higher E2 levels being there. So you could have these patients this way. You could be rescuing the corpus luteum also. So a few outliers would be there. There will be generally very obese ones and one with a very diminished ovarian reserve. They would have that. Anil, you want to explain this any further? Yeah, same here actually.
Remember that if you believe, let's put it this way, when you do research, you use a confidence interval of 95, which means that it never becomes 100% because people respond differently. So even in the long protocol, you'll see decline in ovarian reserves, you'll see decline in, and that happens, when you use a long protocol, poor responders, so women on the periphery of good to poor reserve, you'll see follicles disappear. And that can happen. And you also see in synchronous. Secondly, in older women, remember that they're already firing at a low LH. So it's easier to downregulate older women than younger women. So, and the reason is that the pituitary shuts down faster. And in those women, you tend to see follicles which are larger also. And I don't think you can do anything. What I would do is not downregulate her. See, if you can't synchronize, then what's the use of using the long protocol unless you're batching? And when you batch, I think you're treating 80% of patients, not the 20 difficult %.
And my observation in such patients, even I stimulate and we go further with a OM pickup, we don't get much eggs. The yield and the quality of embryos are poor.
Actually, see, we are just getting one information that you are not having a synchronized follicles on day 2. We don't know much about the hormones, what their AMH, you need to subgroup them, you need to analyze them better, and probably you will yourself come to know in which patient it is not doing well. It is, I feel, and what he feels is in patients with a diminished ovarian reserve or old age patients and a high BMI, it may not do well.
So next plan will be the antagonist cycle for those patients.
Why not the first plan is antagonist cycle?
Right. Like once I now see, whenever we decide on one protocol, but I decided for an agonist protocol. And when I start down regulation, but she's not getting down regulated. So I'll cancel that stimulation and then I'll go for antagonist next, or I can stop and go for antagonist like you are saying.
You're right, actually. There's nothing wrong in changing. But I just want to know why you're making agonist protocol as your first protocol.
For a synchronization.
Synchronization. Okay. Well, you are right then. Yes, sir. Yeah, actually, no, I don't give, sir. I've completely come out of OC pill. Like even if you see on day 2 residual follicle, I don't give OC pill. The residual follicle will disappear in 15-20 days. From where God knows, people have got that habit of seeing a residual follicle, OC pill lo, baad mein wapas chalu karenge. Sheer stupidity. It just goes off by itself. So in my practice, OC pill use is only for drawness of crimson or things like that, for acne and things like that. It's never in stimulation at all, unless you are using.
Stop using OC pill.
A lot of people 12 to 16 days.
See, I think this problem, sir, will come more with egg donors.
Yes.
Our agencies have a stupid habit of putting those egg donors onto OC pills. So we need to go all egg donors on random start. And tomorrow we are going to tell you how random start can be fantastic. You just don't have to bother about it. So we have to train our agencies to stop using OC pills. Well, if it is going to affect the oocyte quality, it's going to affect the recipients. So we need to come out of it completely.
Just one thought, sir. Few of the patient I did like that. I give the 12 days of OC pills. Then once they stop the OC pills, day 13 I started on the Proganova twice a day. And few of the poor responders that on the day 2 or something that we got the higher bigger follicle, they are very much synchronized, and I think 10-15 patients only of that experience.
Actually, there's one paper by Garcia Velasco who has used OC pill in Spain.
Yes.
He uses OC pills and he says doesn't make a difference from the live birth rate.
So, sir,
only one paper.
Yes.
But Garcia Velasco is a cyclist. He does French and Spanish cycling. So they need a lot of scheduling.
Yes.
And they can't prove that OC pill pre-treatment is bad. They have to say this scheduling is getting the results.
They do 12 to 16 days, sir.
Yeah.
See, if you're giving the pill, it usually takes around 10 to 12 days to start the process of lowering the FSH. And that's from a physiology point of view. So when you give the pill for 8 days, so you're doing it mainly for programming, not for synchronization. You're programming because you want to have, it's for your IVF batching. Does it help? To a large extent, yes. When we used to use the pill about 10 years ago, 8 to 9 days also helped. And we didn't see a large number of problems. But when you have a shorter period of a pill use or even Proganova use, Proganova downregulates in a worse manner than, it's a poorer downregulator than the OC pill. Because it takes longer to switch off the pituitary when you use estrogen. When you use the pill, you switch off the pituitary faster. So I don't think it's a problem. I think a lot of people do use it. It's not wrong. In egg donors, also, I believe that a lot of people across the world use it. It's not only India. And there's a logic behind it. And if you're doing egg donors, I don't think it worsens live birth rates. So if you're getting results, do it. See, if you want cranky women and you want women and depressed, then progesterone protocol is the best. Because long-term progesterone causes a lot of problems. So if you want to use a progesterone pre-treatment, remember, progesterone pre-treatment is a programming. It's nothing to do with synchronization. Progesterone does not synchronize. So you can use it only for a short period. If you use it for 10, 15 days, you'll have very cranky patients. You put a woman into depression by giving long-term progesterone. It's not a fantastic drug. And I think it's, I don't think we should use it. Use it for short term. You get somebody who is a date, you want 5 days, she's come to you and you've done batching and you want to start 5 days later.
Yes. Yes. Okay. So we stop Proginova, wait for 48 hours and. Okay. Thank you.
So you all had a good lunch. It was quite good, wasn't it? I always believe, I believe we want to keep people happy in a meeting, have a highly packed, carbohydrate diet, have a lot of sugar, and generally people are smiling after that. Because, you enter a zone of light sleep and unconsciousness. And that's why, in X-ray, everyone writes 1 mark or 2 marks for food. Because it's such bad food. Have you been to X-ray recently? Come on, sandwiches, is that food? Cold sandwiches, they should learn from Indians how to give good food during conferences. Such a lot to learn. So we'll talk of PCOS, and so we'll use what we learned from the previous talk, and we'll talk of PCOS. Now, what do 90% of PCOS need? 90% of PCOS need a dose of 150, and it works very well. And what problems do you face? You face excessive response, you face low fertilization rate, higher number of immature oocytes. Oh, no slides. Yes. So what problems do you face? You face excessive response, low fertilization rates, high number of immature oocytes, reduced cleavage rates, low implantation rates, higher miscarriage rates. So I'll say, I have a habit of simplifying everything. So I'll say, well, let's simplify this into good PCOS, which you can stimulate well, and bad PCOS, we're going to face a challenge at stimulation. Again, count your follicles, look at your theta, because there'll be some women who will have AMH, which is slightly on the normal side, who will have multicystic ovaries with less theta. And these are those who are transitioning from hypo-hypoc condition. And be careful about it, because here analog triggers don't work. Again, have an AMH, have an FSH, have an LH, because a high LH also tells you it's going to be difficult. Estrogen, very few hypogs will be there with PCOS. So what's the usually starting dose? And the usual starting dose is to use 150. So again, this is how I put the chart, and I'll say higher the AMH, higher is the threshold. High volume ovaries, higher is the FSH threshold. Very small follicles, higher is the threshold. So that tells you it's going to be difficult. If your LH is high, it's a high threshold. So LH is a surrogate marker for theca cells. And again, that will tell you. And as Sachin was saying, if LH goes very high, I think they're very difficult cases. I don't know if giving the pill or giving the antagonist helps, because you cannot change the quality of oocytes. All that you do, you can help in stimulation, but there's a quality problem with mitochondrial function in polycystic ovaries. Now, when there are lower AMH and lower is the threshold, larger follicles. So what is it? As soon as you see larger follicles, what is the ovary trying to tell you? It's trying to tell you that the inhibitory nature of AMH is less, which means that these follicles can be stimulated far more easily. There's less theca, again, lower is the threshold. So often I'll say the ovary will tell you what's happening. It will tell you what dose works for it very well. So you have this typical nice appearance of good follicles, the necklace type of pattern or whatever you call it. And then you've got this packed ovary with a lot of follicles inside, which is a very difficult PCOS. So I call this a good PCO. Very easy to stimulate. If you do IVF, it gives you fantastic results. And you'll be able to get a very good result. And you've got this bad PCO, where you've got 30, 40, 50 follicles. And these are a big trouble. Whatever you do, you're going to face a challenge trying to stimulate these ovaries. So again, we look at the fat triangle, and you decide what type of ovary are you going to be working towards. And that helps you to plan the dose. And the reason why it's important is that your starting makes a difference. And I'll say one is use the antagonist protocol. Why? Because it allows you to correct your errors. And in medicine, we do make errors in planning the dose of medications. And what the antagonist protocol allows you to do is to allows you not to compromise on her care, get more eggs, and also reduce the risk of overstimulation. So in PCOS, again, there are ovulatory PCOS. Remember, women can be Rotterdam PCOS classified with regular periods. And these are the women who will respond very well. They'll over-respond, they'll have good blastocysts, they'll have good metaphase 2 oocytes. And with the analog trigger, they have a lower risk of ovarian hyperstimulations. Those women who are metabolic, again, when you look at PCOS, what is the treatment of PCOS? It's twofold. It is metabolic, it's lowering insulin resistance, and it is trying to get follicular growth. So follicular asynchrony or follicular dysfunction is one problem. So while you're doing IVF, what are you doing? You're not treating the metabolic aspect. You're treating only the ovulatory dysfunction. So rather than doing ovarian induction, you're doing ovarian stimulation. But the metabolic changes remain. And that is what causes a worse response. What we also know, if you look at Helen Mason's paper, she's a phenomenal basic sciences researcher in St. George's in the UK. And what she demonstrated is that even at follicle sizes of 4 to 5 millimeter, in PCOS women with irregular periods, you start noticing progesterone, which means those follicles itself are far more difficult to stimulate, and they give a worse response. Then you also see follicles which are very bad. You see 60, 70 follicles in each ovary, high androgens, hirsute, step up almost always fails. And these cases go into overstimulation, whatever you do, except that in the analog protocol, they may do better. So the question is, what do you use? Always the antagonist protocol. There is no role for the agonist protocol. Don't think of using it. First of all, remember, what is your primary job? Is to cause no harm. And using the agonist protocol in PCOS women, you are intentionally risking causing harm, and that is not correct. So what is the usual protocol? You can start stimulating, let's say you're pre-treated, that day one becomes a day one of stimulation, start them on FSH or HMG, whatever you want, 150, and add the antagonist day 4 or day 5. The earlier you start the antagonist, the better is your chance of lowering the LH levels. So if the later you start, your risk of having premature ovulation, premature partial luteinization is higher. Now, if you're trying to do a step-down protocol, which means that you think that 150 is not working, or you've already decided from your experience that this is a large ovary, this is an ovary which has a lot of follicles, there is a high AMH, high LH, and then you say, well, what should I start on 150? And then you say, no, let's give it 300 a chance. And then I give it for 3 to 4 days, because you don't know how an ovary will respond. There's some ovaries which have a huge LH, a huge AMH, but you respond very, very fast, because there will be follicles which are over-responsive, explosive. We just don't know which of these metabolic cases have explosive or over-responsive follicles. So I'll say, give it for 3-4 days. And by day 4, do an ultrasound scan. And that will tell you how many follicles have got recruited. Then if you've achieved it, then drop the dose steadily. And that is what is called as a typical step-down protocol. The aim is to break the threshold of multiple follicles. Now, it's only in PCOS where I use the dose of 450 when you try every protocol and the ovary just does not respond, which basically means that you have everything in front of you. You've got an AMH that is high, you've got large ovaries. One option is you can cut down the size of the ovary, which is drill the ovaries. So that's the only way you can drastically reduce AMH and you can reduce LH. But again, that is quite a drastic procedure. The other cases, you have to push up the dose. But you have to warn your patients that when they look at metabolically challenged polycystic ovaries, you see poorer oocyte quality, you see poorer embryology quality, and that is one of the biggest challenges which you will face. What we also know that high doses during IVF may impair follicular number and function. And what they wanted to look at is they want to look at the hypothesis. And this was just a very good study. It's a retrospective study, but they want to look at, as the AMH rises, what dose would work out better. So this was a single institute study, and they had 3 groups of AMH, 1.8, 1.8 to 4.2, and AMH 4.2, and nanogram, and that's what you use, and above. So they gave everyone a dose of 220, less than 225, a dose of 225 to 450, and a dose of 450 and above. So what they're doing, they're saying, let's see where the protocol works the best. So if you look at it, the number of oocytes retrieved in poor responders, it seemed that when you gave a slightly lower dose, you got more oocytes, and you got a better, the oocyte or the usable embryos was the same. But have a look at a high AMH, as when you use a very low dose, you tend to get lower number of blastocysts. So there is some role of using a higher dose of FSH when you know that the ovarian reserve is very high, and all the indicators look at a difficult stimulation. But again, one is, these are difficult cases. It comes with experience, and you need to be courageous enough to believe that you'll be able to give an analog trigger and salvage this treatment. In low AMH and normal AMH, if you give high doses, they demonstrated in study that you get less oocytes. That's not always the case. With high AMH, the higher the dose, you get more oocytes, but it's not for everyone. It's for that subsect of women with high AMH where you feel you're going to stimulate badly. The other problems that you face is there's premature luteinization and premature ovulation. And those are the genuine problems faced with PCOS. Next is what trigger do you use? So let's have a lecture on the trigger after in the late afternoon. So let's say we have 3 triggers. I'm not going to talk of LH because it's slightly more difficult trigger to use in day-to-day practice. So we're looking at nature. So first you come to nature. Nature has an ascending arm of LH which lasts for 14 hours, a plateau which lasts for 14 hours, and a natural decline that lasts for 20 hours. So to some extent, it is a 48-hour LH activity at a rise. So that peak of LH usually takes a period of 48 hours, and that is adequate luteal phase rise. When you give HCG, your rise is for 7 days. So you have LH-like activity for a prolonged period of time. When you use the GnRH analog, you see a spike in 4 hours, and by 24 hours, the LH has disappeared. So that is what you see is you see an advantage of using short-term LH. So what causes hyperstimulation of ovaries? Sustained LH activity. What gives sustained LH activity? HCG. So if you have bad stimulation, that will go on for 7 to 10 days, and in fact, make it worse. So if you use the agonist trigger, what happens? You see a defective luteal phase. Why? Because you have lost natural LH of 7 days. So you see a defective luteal phase, and there's disruption of luteal phase. And whatever you do, you can add estrogen and progesterone, pregnancy rates are never good. You always need a small amount of HCG to rescue this cycle. So if you use the agonist trigger and you do a fresh transfer using estrogen and progesterone, your results will be very poor, and that should not be done. The luteal phase is disrupted, HCG rescues the luteal phase. So in nature also, what happens? You do a day 21 progesterone, and then the progesterone starts declining. So what saves the corpus luteum? It is an ongoing pregnancy. So as soon as the uterus detects a pregnancy, a signal goes to the corpus luteum where LH activity continues through HCG, and the progesterone remains high. So same thing happens here is as soon as your LH activity is curtailed, your follicle also, the corpus luteum starts dying. So primarily the use of the agonist trigger is primarily to prevent ovarian hyperstimulation. The prevention is often total, but not entirely. There will be women who will go into severe ovarian hyperstimulation even with an analog trigger. The main reason is to use antagonist and to use it in high-risk cases. So you come up and say, hang on, I am not entirely certain about my freezing protocols, and I'm not entirely certain about how my freezing protocols will work. And that is key to it. If you want to do this treatment, your lab needs to be of a very high standard where you are able to freeze embryos and also keep a very good quality of blastocysts or even day 3 embryos. So you want to do a fresh transfer. So what you can do is, and this is what Peter Humadian tried, and he says, well, if you give estrogen progesterone, but on the day of ovum pickup, you add a small dose of HCG of 1,500. So what you're doing is you're saying, I don't want to trigger ovulation with HCG. I want to give the analog trigger, but I want to support the luteal phase. I want to support the endometrium. So let me add a bit of HCG, around 1,500 of HCG. And what they noticed is that the pregnancy rates were very much similar, but if you did not use HCG, the clinical pregnancy rates were much lower. So I think I did that. It's coming again. Now the question is that you can do a fresh transfer, but again, you run the risk of having overstimulation, though at a lower level. Can you use metformin for IVF? And the logic is that there's a metabolic syndrome going on. You want to lower insulin resistance. Let's use metformin. But it doesn't seem to have made a huge difference in adding metformin in a PCOS cycle in terms of egg quality. This was one done again in Leeds, and where they looked at starting metformin and placebo, and the total number of oocytes and fertilization rates were very similar. This was a follow-up from the same center, and they looked at short course of metformin, did not reduce the risk of ovarian hyperstimulation in an antagonist protocol. And here they saw again, the live birth rates were lower with metformin. So there was no clinical significance. So again, using metformin for some reason, that short-acting metformin does not seem to help. The reason why it's important is that 20% of women in this study were that of South Asian origin from India and Pakistan. There seems to be an endometrial dysfunction. And again, the role came up is, does metformin lower the endometrial dysfunction, which is metabolic? We don't know, we don't have that answer. So there'll be people who will give during FER cycle metformin, but we just don't know that. Can you do in vitro maturation? Some people do it, I don't. And it is still an ongoing process in which we are gathering more information. So what problems do you get with fresh IVF? You see high levels of estrogen and progesterone leads to endometrial advancement. And what we do know is that when you push ovaries very hard, you increase progesterone. So whatever you do, the higher number of follicles, your progesterone levels grow up. As follicle size increases, your progesterone levels grow up. So you're causing a certain amount of advancement of the endometrium. It also causes increased contractility. High progesterone may decrease live birth rates. And so there is this role of freezing embryos. And again, it's controversial. There's some laboratories, especially in Europe and United States, where they have got good results even with high progesterone levels. Now, my policy is to freeze them because it allows us to manage a much more quieter and a well-balanced luteal phase. So stimulate the ovaries, step down, wait till the follicles reach 18 to 20 millimeter, freeze all embryos, and then replace the embryos in a frozen cycle. And the aim is that you take the embryos from a hostile environment, and it allows you to get a better quality of embryos. So when they looked at the HCG versus the frozen thawed embryos, and this was quite earlier, they got reasonably good results. This was what we tried out on our NHS hospital, and that was years ago. And we were one of the first hospitals in Europe to go do it on a mass scale. So we used the analog trigger and we froze embryos, and we saw clinical pregnancy rates go significantly higher. What I do now is I allow the ovaries to settle down. What you can also do is post-collection, you can give the antagonist for 5 to 7 days. If you see, there was a paper which I presented, which was, do you increase or do you hasten recovery in an IVF cycle with an agonist trigger in PCO patients by giving cabergoline and antagonist? And about 5 years or 7 years ago, I argued online. I was younger and I could argue a lot more. And I argued that cabergoline has no role in an antagonist cycle. But in fact, I think I've been proven wrong there, because the study was very good. If you give, even in an antagonist cycle, cabergoline and the antagonist, the ovary seems to decrease in size faster and luteolysis is faster. Avoid giving long-acting GnRH analogs at a short period, because you create another LH rise, and these women end up going back into ovarian hyperstimulation. So now the controversial subject is, which drug is good for PCOS, FSH or HMG? And the general concept is a pharmac-driven concept, that you give HMG is wrong. I remember when this was in the 90s, when Merck Serono had just got the patent for Gonal-F. So it came in, and every lecture we were told, hang on, if you women with PCOS already have high LH. So if you give FSH, if you give HMG, you're in fact making it worse. And so everyone moved, and it is something which remains in print and it's very difficult to remove. So what happens when you give LH? So when you give HMG, initially it does increase the LH levels. So if you have a look at PCOS, you see higher LH levels as soon as you give HMG. So what this does is this knocks out some follicles, and you see a lower follicular recruitment in PCOS when you give HMG. And then you say, why do I want it? And I'll show you in a different study that lower follicular recruitment seems to be good in terms of its outcome. So that initial rise of LH, and it recruits fewer follicles. Why? Because you have a high LH, which knocks out follicles, and it is slightly better at lowering progesterone levels. Also, there are fewer smaller follicles, which may also lower progesterone levels. So what we'll do is we'll look at the evidence which has looked at this concept. So this was a study where they used highly purified HMG versus recombinant FSH in treatments combining fresh and frozen IVF cycles. So they looked at the economic aspect. So when they looked at live birth rates, HMG had a significantly better live birth rates than using recombinant FSH. So the HMG gave you a live birth rate of close to 49.2%, recombinant at 39.9%. Looked at the costs were lower when you use HMG. So, and these are quite older studies. When you looked at the MERIT and the MEGASET study, what you looked at is you looked at progesterone on a day of HCG, and you saw a higher progesterone on a day of HCG when you used recombinant. Why? Because follicles, you see more follicles, more smaller follicles, more larger follicles. As soon as you see the response, you're marginally increasing. But remember that when your progesterone rises, in some women, it will trigger premature luteinization selectively in some follicles. So, and that is what you'll end up seeing when you use recombinant FSH. So they looked at your AMH, and here what they did is they looked at the long agonist protocol and the antagonist protocol, looked at AMH, and they saw, hang on, what happens when you give HMG versus FSH? And so if you look at the progesterone, even in a long protocol, your progesterone rises when you give recombinant FSH. In antagonist protocol, also the progesterone rises. And when you, if you look at the ovarian response, it seems to be slightly lower when you give HMG. And so, you know, it is significantly better. And if you look at the live birth rate, you're very much similar. So your HMG gave you a slightly higher live birth rate compared to recombinant FSH, even in an agonist protocol. So what is it telling us? It's telling us probably that adding that HMG in an over-responder may help you in getting fewer number of eggs, better quality of blastocysts. So this was a randomized controlled trial which came in August 2020, and it's a very big trial looking at over-responders. Two-phase, 2 RCT trial, high responders versus low responders. So the women were 21 to 25 years, cycles between 21 to 48 days, high AMH. They did not include stage 3-4 endometriosis, recurrent miscarriage, HMG versus menopause versus Gonal-F, starting dose of 150, day 1 to 3, and dose adjustment on day 6. Remember, you can do that in PCOS when there's no recruitment. Maximum dose of 300 is not costing, its costing was not allowed. And HCG for fresh transfer was planned, or loop ride if there was a risk of ovarian hyperstimulation, and genetic screening done as an independent marker. So if you have a look at, it's quite a busy slide, but in summary, what they said is, so if you want to confuse people, you can put this slide up, but I've summarized it. When you use HMG, you saw lower estradiol levels, lower progesterone levels, less number of oocytes, number of blastocysts were lower with the HMG group, number of top quality blastocysts similar, aneuploidy rate was also similar, and higher ongoing pregnancy rates per cycle started. And in a fresh transfer, it seemed to be very similar, and live birth rate in a frozen transfer. So it seems that embryos which are frozen with HMG seem to maintain a better quality even when they are frozen. OHHs also decreased when you use highly purified HMG. So what does this study tell us? The study told us that when you use highly purified HMG, it has a lower pregnancy loss in fresh and frozen transfers. Differential pregnancy loss was observed in frozen transfers. HMG, you had fewer oocytes, but a similar number of top quality embryos. And the significant differences were not observed between fresh and frozen, even though aneuploidy was known. And there was a lower incidence of excessive response. In conclusion, they said in high responders, HMG treatment is associated with moderate stimulation, lowest incidence of complications, lower pregnancy loss, and higher ongoing pregnancy rates. So what does it give you a chance to do? It gives you a chance to go back and say, let me use a good HMG, and there are some very good HMGs everywhere around the world, which have less batch-to-batch variability. Let's give it a trial with high responders. You can up the dose a bit. Also, when you looked at, this was another paper which looked at oocyte numbers. So what gives you more oocytes? Highly purified recombinant FSH. What gives you more M2 oocytes? High recombinant FSH. What gives you embryos? Similar. What gives you a better implantation rate? HMG. And what gives you a better live birth rate? HMG. So when you look at the outcome measures, HMG seems to do much better. When you look at the indicators of having more eggs, recombinant FSH does better. So I'll say, have a rethink about when you use high PCOS, and it's worth looking at that. Again, human-derived FSH shows a complex heterogeneity. Its actions are different on granular cells. Recombinant FSH is more potent, so more follicles grow. Elevated progesterone on the day of HCG affects prenatal luteinization, and HMG causes a lower high response. So what do you look at? You look at, in summary, I'll say you have somebody with PCOS, you look at age. Older women do worse. Younger women do much better. Younger women have a higher risk of going into ovarian hyperstimulation. Look at the AMH. Is it high? Is it with highly irregular cycles? Is this going to be a difficult ovary? Is this an ovary where we would benefit from a step-down regime? Or is it in a normal range? Does it have a good AFC? Or is it less? Is it a low AMH? Again, even in PCOS, sometimes you see a variable AMH. Has there been a low AFC? Is the AMH going up and down? And maybe it may be good postponing the cycle to a different time. Always measure the volume. Review the thecal element, because the theca gives you an idea of LH. It tells you how difficult your stimulation is going to be. And remember that in Indian women, the theca declines faster. And it declines much earlier in the early 30s rather than in the late 30s that happens in Caucasian women. And don't be scared of using a step-down protocol. Give it a try. Use an antagonist. It allows you to start making an error with your starting dose. Use HMG. It allows you to be more courageous in going a bit higher. And you are lowering patient burden if you cancel early. So all this happens, and by day 5, you realize this protocol is not working. Cancel early, scan early, cancel them and say, hang on, this is not working. And thank you very much.
Any questions, please? How do you combine gonal menopause?
There are multiple ways. It all depends on which side of the bed I wake up. So what happens is, if on Monday, I normally start recombinant. And Tuesday I give HMG.
मीठी comment करना था
And
तो।
Wednesday I'm joking. It doesn't matter. It just does not matter. I'll tell you what the Americans do. The Americans give recombinant and they give HMG. So the Americans give recombinant in the morning and they give HMG in the evening. My logic to that is, I don't think it makes any difference when you split the dose. I think women tend to, it's good to keep women busy. So when you split the dose, they tend to, you know, or men get more confused when you keep them busy. It doesn't matter. There's no doubt. See, what we don't know is if you combine this, do you have a better blastocyst culture? We don't know that. But the logic is that by combining, you may be getting a better number of oocytes, and you may be balancing that effect by using HMG. So the American clinics use a lot of this combination. But what they do is they use either 75 of FSH and 150 of Menopur, or they do the other way around.
Actually, what I would suggest is just because we are suggesting, just take us for granted and do 10 cases of IVF with 150 IU Gonalef and 150 IU Menopur. Okay, see the results and then take a decision how you're going to go ahead. And believe me, you wouldn't look back.
There's a Gonalef rep sitting outside.
Yeah, he's sitting outside. he just filled my bag. No, nothing to do with that. We don't have any shares with Ferring or Gonalef, nothing. But this is, if we are enjoying good results in our practice, it's one of the main reasons of enjoying good results is this. This is a contributory reason that we use 150, 150 in both the things. Or sometimes I shared with a few people, rather, let's go evidence-wise. Taltaris et al. Has done meta-analysis of the different dose combination studies which have been published in low ovarian reserve patients. There were only 2 studies published on 150 IU dose. Most of the studies, rather there are 12 studies on something like 300 IU, there are 13 on 450 IU, and there are about 5 studies on 600 IU. And a lot of them, those studies have used combinations. Right? So just do an experiment of your own, just doing 5 to 10 cases with 150, 150, realize for yourself, and then put your foot forward.
See, now we have taught you about 50% of the problem. Now, the rest 50%, you will get tips that will get you to 80% success rate from male infertility. You know, the cause of all the problems is the sperm. Okay.
So Sherry will be talking to us about male infertility, cause of all problems, the sperm, and the man behind the sperm. This is going to be a little longish lecture, obviously. And after the lecture, probably we will have coffee being served in the hall itself. And by that time, we expect Dr. Mohan Kamath to arrive and allow us to spare some 5 minutes felicitating Dr. Anil Gudi and Mohan Kamath. Thank you.
Yes, sir. Okay. So as sir mentioned, like what has happened in the last decade, the male infertility incidence has been increased, and it's an observation that since last decade, the sperm count has almost declined to 50% because the advanced age, the lifestyle problems has added to this problem. So for male infertility, the choice of the treatment should not be ICSI. Why the poor female, being young and having good ovarian reserve, should carry the burden of going through the ICSI procedure when it's a male factor of infertility? So let's understand, like it's a need for the hour that we should understand what is the male factor infertility causes and how we can go about the evaluation and treatment. See, elaborating slide where there is there are causes of male infertility. It can be explained causes of infertility, which we can derive conclusion from semen parameters, which is your azoospermia, oligospermia, necrospermia, grovazospermia, teratozospermia. And there are internal semen analysis parameters. So in my next lectures, I'm concentrating mainly on this undetermined male infertility factor. That is nothing but a combination of idiopathic male infertility, which contributes almost 23%, and unexplained infertility. So as I said, we have extracellular system and intracellular system about the sperm analysis. So extracellular system is all about your analysis in the semen parameters, and intracellular system is all about the genetic thing behind that. So that is about the DNA fragmentation, about the centrioles, about the reactive oxygen stress, and let's see how we can make it simplify. I want to imply from this figure that to a live birth rate, the maximum contribution is from female, that is almost about 70 to 80%, and the sperm contributes only 10 to 15% when it comes to live birth rate. Now we are focusing on the abnormal sperm parameters, which we can benefit for the lady not to undergo through the ICSI treatment. As I mentioned that since last many times, like, in India, it is a common scenario. Many times in urban area or rural, suburban area or rural area, even to get semen analysis will be a problem. And because of the male predominant society, it's very difficult to convey them that you have a problem and let not burden to be carried by your wife. So what this paper beautifully explains that we are for everything, ICSI should not be answer. ICSI is a paradox because it's not treating an infertile male. It's just a manipulation of gametes. So women carry whole burden. And what we are not aware, it's about the andrological ignorance. Very nice concept that we are not evaluated any male on the andrology point of view, and we are not having the corrective factors for it. So this is a typical reproductive history, which will take with the infection, varicocele, long-standing medications, so on and so forth. I want to concentrate on this slide. Like this is a very recent paper in 2022, which tells about the evaluation in the era of advanced ART treatment, how male evaluation role it's been played. I want you to go through this paper because nicely this paper has given elaborate information that what could be the components, and they have from the endocrine point of view, from psychological aspect and history, all the points they have touched and nicely explain about the like theory behind it. Whenever we are in our practice, we are doing semen analysis, we are always doing it with HbA1c. So we are, as we know that, like, in India, we are a pre-diabetic country, and many of us are like, either pre-diabetic or going to be in the diabetic problem. And that is how the semen parameters are going to affect. So every patient of us who is coming for, like, we are advising semen analysis, we always tend to combine with the HbA1c. So now let's talk about the semen analysis. The semen analysis, when we are, that is the most common and basic investigation we are advising for a male. What it tells about the testicular and endocrine function, ductal patency, and diagnosis of reversible medical conditions. If we look in the semen analysis in detail, only 5% of the semen ejaculate is contributed by testes, then 40 to 80% by seminal vesicles and other gland. So the testicular contribution is only 5%. Then I'm taking to this paper just to give an idea, like the patient who are not comfortable to give semen sample in the lab, many times we are advising at home and we are sensitizing them that you have to get the semen sample within half an hour, otherwise it will affect the semen parameters. But this is not a story. This paper tells that it conveys that when in the pandemic situation, when they asked home collection, which was high in the like maximum population, and within 2 hours, even if the semen analysis is done after 2 hours, the semen parameters were not affected greatly. So 2 hours time is okay, but 3 to 6 hours is detrimental to sperm motility. And they found there is not much difference between sperm concentration, motility, or total motile count when it comes to collection side. Coming to the semen analysis, we have biggest fallacy about semen analysis is what? It's semen analysis, like WHO semen analysis, which is currently in 2020 has been, it's not a much difference from the last 2010, but WHO talks about accuracy, but prognosis to pregnancy and choice of treatment is not suggested with semen analysis. And it does not differentiate male into intermediate male infertility, in like a fertile male and infertile male. So WHO criteria, when it comes to a pregnancy outcome, there is no correlation, and this is been proven by these authors. Then when I'm saying, like, semen analysis is just an analysis, but it's not giving much information, how we can go about with the treatment. So Hamilton, this is a very, highly quoted paper in 2015, which came with the concept of TMSC, that is total motile sperm concentration, calculated with volume into sperm concentration into progressive motility in percentage. So he categorized the TMSC into 1 to 10, 1 to 5 million, 10 million, and more than 20 million. And what has been observed, that the spontaneous pregnancy rate were higher when it is more than 20 million, but the spontaneous pregnancy were lower in case when the sperm count is 1 to 5 million. Then recently, the TPMSC and TMSC is nothing but the same, but it's only about pre-wash, where the sample, the volume we are taking as a pre-wash sample, and in post-wash, after the procedure, the volume will become less, so it is they have considered as a 0.5 ml. It was a retrospective analysis of IUI study, where they studied about anovulatory factors, about unexplained infertility, about endometriosis, and male factor of infertility. So when they calculated TPMSC, what they observed is for mild male factor infertility, when the TPMSC cutoff is going beyond 55 million, in that patient, the spontaneous ongoing pregnancy were higher, and that statistically significant. So let's say, to give an example to apply in this clinical scenario, when I have a patient of oligospermia, then let's have like TPMSC less than 55 million is there, it's better to undergo hormonal evaluation. To summarize this, like when the insemination motile count, like post-wash motile count is less than 1 million, the ICSI will be a choice of treatment. When the TMSC, which is pre-wash, is less than 5 million, we have two choices, it's ICSI, and like if at all we can go ahead with IUI. ICSI in the patient where it's a severe factor, male factor infertility, and the female is also advanced maternal age or low ovarian reserve. And in young patient, I mean the female pattern is normal. So in those patients, we can ask patient to give 2 ejaculate, and we can double the sample, because the sperm per ejaculate, that matters a lot rather than only sperm concentration. To give an example, a male could be having 1 ml semen volume, and where the sperm concentration is let's say 18%, 18 millions. But the same patient, if at all he's having 3 ml volume and the sperm concentration is 10, so it's like like into 3, so it's almost 30 million. So always that is a better parameter. The sperm per ejaculate is very important compared to only sperm concentration. So now I told about from the TMSC paper of Hamilton that when the more than 20 million sperm count is there, there is more chances of spontaneous ongoing pregnancy rate. But there is a gray zone area when I'm telling that TPMSC should be more than 55 million to achieve increase the rate of pregnancy. So what we can do about it, like when the TMSC is more than 20 million, but TMSC, but it is less than 55 million, it's an unexplained cause of infertility, or maybe these patients could be having multiple IVF failures. So we can go about how hormonal evaluation treatment and medically treat those patients. As I mentioned that, we are living in the country where is a diabetic is very much predominant. So how the diabetes will affect the semen parameters and the sexual dysfunction part of it. So at testicular blood barrier, there is a pyruate metabolism, and where the insulin is very much important for to have spermatogenesis and Sertoli cell function. So if at all we look at the sperm parameters, the low motility and sperm concentration will be there. There will be high DNA damage, so SDF level will be high. Normal sperm but high chromatin damage, and there is increased oxidative stress. The epididymis will affected more because there is loss of stereocilia, and inflammatory infertility will be there. Then how the sexual dysfunction, the patients with diabetes can have retrograde ejaculation, erectile dysfunction, they could be having less offspring, the low volume, and that is because of the low peristalsis of the vas deferens. And they found in animal studies, like in the seminal vesicles also decrease weight in case of diabetic mice. So what will be the treatment? Like, early insulin therapy, like you have to make the patient sensitized that diabetes is having such abnormalities, and why not to start treatment? So insulin therapy will be your first treatment. Along with insulin, do add metformin, because metformin restores spermatogenesis and it reduces germ cell apoptosis. Coming to the obesity. So in obesity, the mean scrotal temperature is high, and that is how there is decrease in the semen parameters. In obese patients, we generally find that the hypopituitary testicle malfunction is there. The sleep apnea, decreased nocturnal testosterone rise. The fat accumulation will increase the oxidative stress, and pro-inflammatory substance that will also lead to increasing oxidative stress, and that will be a reason for increasing sperm DNA fragmentation. So when we have that tendency, when a couple walks in and the lady is obese, even the male partner will be obese. So we are just sensitizing the lady, you lose a weight and you have more chance of pregnancy. But you have to take into consideration this parameter where we can work on the weight loss in the male partner and improve the results. Now about oligospermia, like this is the evaluation oligospermic male can go, like hormone evaluation, FSH, LH, E2 testosterone, the scrotal ultrasound, and TE ratio. Let's talk about TE ratio in oligospermia. So this TE ratio will guide us about which therapy to be given for male factor of like oligospermic patient. When we have a ratio of testosterone to estradiol that is less than 10, what it indicates that estradiol is on the higher side, and that is why it is less than 10. What letrozole will do, if at all we are giving aromatase inhibitor and letrozole is our choice, then what letrozole will do, the letrozole will take the estrogen level down, and then it will make the hypothalamic pituitary axis sensitized, that release more amount of FSH, and that will the initiating factor for spermatogenesis. The aim behind giving clomiphene citrate and letrozole is same, that we want to increase FSH, and then we want to increase the testosterone, and that will induce a spermatogenesis. As I mentioned, when it's less than TE ratio less than 10, our treatment of choice will be letrozole. And when the TE ratio is more than 10, where the testosterone is on the lower side and the FSH could be normal or low, these patients are candidate for clomiphene citrate therapy. And these are the published papers where after the clomiphene citrate therapy, there is increase in the sperm count, like 10 to 20 million. And like, some of them achieved spontaneous pregnancy. With the letrozole, when the TE ratio, as I mentioned in detail, the letrozole markedly increased FSH and testosterone. 2 out of 10 oligospermia conceived and 4 out of 17 sperm in ejaculate in patients with azoospermia. So to summarize, when we are starting treatment with like either letrozole or CC, we always have how the treatment is going to be beneficial for the patient, and what we are asking the patient to do semen analysis after 3 months of starting treatment. But the patient also will be impatient that, whether this therapy is really making any difference or I'm just taking that. So when we are having decided that, we are going to go ahead with the CC treatment, we are starting with 25 milligram dose, 3 months, and the FSH, we are repeating FSH after 1 month. When the FSH is less than 10, means we have not crossed that threshold. So in in those patients, it's better to increase the CC to 50 mg and continue treatment for 3 months. If at all FSH has already gone beyond 10, no need of stepping up the dose. You can continue the same dose. In letrozole, it's a 2.5 milligram daily for continuously 3 months. And a very important thing is, don't ask repeat semen analysis within 1 month, because the spermatogenesis will take that much time. So repeat semen analysis after 3 months. So to give an evidence how the clomiphene citrate works. So clomiphene citrate increase the hormonal levels of testosterone, FSH, and LH. And particularly in this study, when I'm giving you an example that there is FSH rise, just to substantiate that, after 3 months, when they did testosterone level and FSH level, the standard deviation shifted almost 2 times what was in previous. So increase LH, FSH, and total testosterone, improve the sperm count in contrast to suppressive the effect of exogenous testosterone delivery system. I have to talk about the medical treatment part of it. But whether we have any predictor where we can say like in which patient this treatment is going to be a beneficial. The obvious answer could be intratesticular testosterone. But problem with intratesticular testosterone, it's not measurable. And as we understand that intratesticular testosterone is almost 50 to 100 times more than your serum testosterone. And we don't have predictor like, how this therapy is going to be beneficial in such patients. So this paper beautifully explained, like if at all we take 17 OHP as a predictor in which the patient is going to benefit. So how they went about it, the patients with idiopathic infertility, where there is testosterone deficiency, secondary hypogonadism, or low normal testosterone with low total motile sperm concentration. These were the population they have selected in this particular paper. And they found like when it is the 17 OHP is less than 55 nanogram per deciliter, it's a better predictor to start medical treatment. And when we can counsel, like as your 17 OHP is less than 55 nanogram per deciliter, you are the patient where it's going to be beneficial with the medical treatment. And it increases your total motile sperm concentration also. We all are interested, well said and done, when the medical treatment is received to any male partner. We are more interested rather than improving sperm parameters, what could be the pregnancy rate. So this was a meta-analysis published where with the forest analysis, where it is crossing this line and it is favoring this estrogen antagonist. So pregnancy rate did increase after the after the clomiphene citrate therapy in this particular study, though the increment is only by 2.5 to 6.8%. We should not take this point as negative aspect. What we can actually say, like the patient who is having oligospermia and now the sperm concentration has been increased, we can always store that semen sample for the further use of, let's say, IUI or next advanced medical therapy. Okay. Now, many times we come across a patient, like they will be coming for second opinion, and from the general practitioners or from the other gynecologists, the patient is already on clomiphene citrate therapy. And they have started clomiphene therapy without evaluating and without titrating the dose of about FSH and testosterone. So what happens, like generally it's observed when the patient is taking long-term clomiphene citrate therapy. This particular systemic review published in 2020, what they found out, like patient on long-term CC therapy, there will be actual decrease in the semen semen parameters and TMSC. It's almost 20% of the patients, and 17% of the semen analysis deterioration is there. So they didn't recover even after stoppage of clomiphene citrate. These are all hypothetical and plausible mechanisms which they explain to. It could be a technical errors in semen analysis. It could be a direct effect of CC on testicular histology and increase in E2 concentration. As the E2 concentration increases, obviously the GnRH pulse frequency is going to come down, and that is affecting the sperm parameters. So in our clinical practice, if at all a patient has taken long-term clomiphene citrate therapy and to your surprise the sperm count is on the lower side, then ask the patient to stop the treatment and repeat semen analysis after 2-3 months where the semen parameters can be normal. And the caution here is the long-term continuation of clomiphene citrate without monitoring is not advisable. So don't give empirical treatment for longer duration with clomiphene citrate. Many times we come across that the OATS, that is oligoasteroteratospermia, where the sperm count is low, there is low motility and abnormal morphology. So like in the treatment of OATS, the paper has given how to go ahead about the diagnosis, which I mentioned just now. How we can go about evaluation is clinical examination and just rule out varicocele, and on the ultrasound see whether the testicular volume is normal, and hormonal evaluation with blood tests like FSH, LH and testosterone and estradiol. Those patients who are having severe oligospermia of less than 5 million, the American Urology Association and ASRM guidelines does tell when it's a severe oligospermia, there could be a genetic problem, and these patients to be evaluated for Y chromosome microdeletion and CFTR gene abnormality. So the oats could be low testosterone and low normal FSH-LH could be of pituitary origin, low or normal testosterone and high FSH-LH, which excludes Klinefelter syndrome. And we have idiopathic oats where the normal testosterone and normal FSH-LH are there and they're having normal gonadal axis. Still, the oats is present. This is the area, like this is the point which I'm targeting in my next lecture. And these are the patients who will present to us with idiopathic oats. So as I mentioned, like, the oats could be only because of the lifestyle factors. So how we can modify about the life factor? So lifestyle modification, quit smoking, reduce alcohol consumption, physical activity. If it is a diabetes, better to treat and then go ahead with the treatment. In medical treatment and surgical treatment, what options we have? FSH, aromatase inhibitors, clomiphene citrate, all these three things are actually improving the FSH and indirectly testosterone, and that is how the spermatogenesis will increase. And antioxidant, wherein patients with obesity, antioxidant will help. Varicosilectomy, a patient with mild varicocele, where the sperm DNA fragmentation high, and that could be the reason of oats. We can advise varicosilectomy in such patients. And other patient, when it's a severe oats, the fertility could be with ICSI rather than going around with the treatment. So what options we have? It's same like oligospermia. In the letrozole, already I covered the topic. The only highlighting point is it increases sperm concentration, motility, morphology, significantly increase after letrozole treatment of 3 months. And they found like it can be effective treatment for idiopathic oats when TE ratio is less than or equal to 10 and 20% spontaneous pregnancy with letrozole treatment. Now, coming to the FSH therapy. So now the question is whether the FSH therapy is going to be beneficial. Initially, the empirical treatment with FSH was a common practice. And we went through many papers where, like, whether the FSH is making any difference to these idiopathic oats. What are the FSH level? Though it's normal, there could be reduced FSH activity depending on the circulating FSH level because of its glycosylation, its expression, and FSH receptor function. So clinically deficiency, FSH is unable to attain its clinical effect independently of its circulating levels. So what FSH therapy does? It stimulates the tubular function, bringing about the increase in spermatogenesis. In idiopathic oats, the FSH treatment is going to be beneficial to patients who are having normal gonadotropin level with normal inhibin B. It was a practice prior, like, they used to go and ask the patient to undergo testicular biopsy, then histopathology, and they used to analyze what will be the effect of FSH therapy in those patients. And those papers published was before 2000 or 2005. And they found out in the patients who will be true responder in patients with idiopathic oats would be a patient with hypospermatogenesis without maturation defect and normal FSH. This is the group where the maximum FSH response we will get. Patients obviously with elevated FSH, then there is a negative factor for FSH therapy. We can't help these patients with FSH therapy. When we went through so much of literature, because as I mentioned earlier, we are more interested in the pregnancy rate rather than just improving the semen parameters. So all these trials are conveying that improvement of pregnancy rate and live birth rate after FSH administration to the male partner of infertile couples, it increases your result both spontaneously or in case of ART. So again, I'll repeat, if at all you're giving FSH therapy, obviously the patient has to take multiple injections and you can't extend treatment for months and months. So when you found that the sperm concentration will increase, please reserve the sample or cryopreserve the sample, which we can use for IUI or ICSI. So recently in 2020, the FSH therapy in idiopathic oats, as I mentioned, the patients who are going to benefit with the treatment are normal gonadotropic patients. So these normal gonadotropic levels could be having permutations and combination depending on the testicular volume and serum total testosterone. So this paper grouped these patients into four groups, And testosterone, depending on the testosterone and testicular volume, whether it's abnormal and one of them is normal and one of them is abnormal. I'm concentrating only on this B group, where the testicular volume was beyond 12 ml and testosterone was less than 350. So in this patient, when they found that testosterone is on the lower side, how they treated? They gave first HCG, because HCG will increase the intratesticular testosterone and the spermatogenesis will initiate, which is followed by FSH treatment, if at all there is no response in 3 months' time. So beautifully, if at all see or look at this slide, in B group, there is increase in the normalization parameters was almost 45%. The pregnancy rate increases up to 30%. And there is correction of DNA fragmentation in this group, which is statistically significant, which is almost about 50%. So overall, there is increase in all the parameters when it comes to FSH therapy. The ideal FSH level to correct spermatogenesis is usually between 4 to 8 IU, but this study is not giving that association. When it comes to Y chromosome microdeletion, as I mentioned, the patient with less than 5 million will evaluate. We have 3 things in YCMD, that is AZFA deletion, AZFB deletion, and AZFC deletion. We are all aware that AZFA and AZFB deletion, there could be a patient with Sertoli cell only syndrome and maturation arrest, where donor sperm is advisable. Patient with AZFC deletion could be having only impaired spermatogenesis and they will present to us only with oligospermia. So in this patient, the detection of sperm is almost 50 to 75%, and we can use for the treatment. So what if at all we look at the incidence of the prevalence of YCMD, in azoospermia, it's 8 to 12%, very severe oligo 5%, severe oligo 0.8%, and when the sperm concentration is 5 to 20 million, the prevalence is 0.5%. Now, I had given fair idea about oats and oligospermia. Let's move about teratozospermia. And teratozospermia is nothing but abnormal morphology. So teratozospermia will be having effect only on the spontaneous ongoing pregnancy rate. It won't be having effect when it comes to IUI method or ICSI method. So there is in Devani et al., there is no statistical significant difference in rate with sperm morphology less than 4% or more than 4% in IUI circles. That was the conclusion. So a common question asked by male partner that when we are sensitizing them, well, you have severe teratozospermia. So the question will be whether it will affect the embryo quality, whether it will affect the pregnancy rate, and whether there will be any defect in the embryo generation. So when the blastocyst formation rate is been analyzed in severe teratozospermia, so retrospective study, they considered strict Kruger's criteria, and ICSI was done for this patient. And what was the analysis? That they have high quality of blastocyst in teratozospermia group rather than normozospermia. I just want to give an information that teratozospermia is not making any difference when it comes to a blastocyst quality or pregnancy rate, because we are correcting it by ICSI. The embryologist is always going to pick up a normal morphological sperm when it comes to ICSI. These patients will be were having maximum blastocyst rate formation in teratozospermia, but reason could be it's a male factor of infertility where the female was normal. In normozospermia could be a female factor of infertility also. So about globazospermia. So globazospermia is nothing but round-headed spermatozoa with cytoskeleton defects around the nucleus and no acrosome. It's a very rare condition which we come across in India. And what could be the therapy? The treatment is nothing but ICSI. But what are the problems when we are doing ICSI? As there is no acrosome, there is no oocyte activating factor. So 3 reasons for the failure of ICSI. Oocyte activating factor is inhibited or missing, and we may have to use oocyte activating factor when you are doing ICSI, like with calcium ionophores. Poor sperm chromatin condensation and high sperm DNA fragmentation, and sperm aneuploidies will more in case of globazospermia. Let's talk about necrospermia. So necrospermia, where you have dead sperms in the semen sample. Like complete necrospermia is very rare condition. Many times we come across with partial necrospermia, where 5 to 45% of the sperm could be alive. So these are the tests which we take into consideration when it comes to necrospermia. That is EN10 and HOS10. I just want to give a message when we are taking the patient is having necrospermia and we are taking that patient for the ICSI treatment. The HOS test is not actually affecting the sperm. So that sperm is not damaged with this test, and that we can select and use for ART treatment. In EN10, the sperm got damaged. We just get an idea which is the live sperm and which is not live, like a dead sperm. So this is not a test which can correlate with the ICSI treatment. What treatment of necrospermia? So I said, in many times we are coming across with partial necrospermia. So in those patients, 2 consecutive sample with short interval can help, because the second sample will be having more live sperms. So in the epididymis, sperms are stored for a longer time, and that is why it could be maximum amount of dead sperms are there. But in subsequent sample, it won't be a story. Avoid and treat risk factors like infections and varicocele. Frequent ejaculation does help in necrospermia. When it's absolute astenospermia with flagellar dyskinesia, HOS test will help to select the viable sperm for ICSI. When it's absolute necrospermia, consider SDF level. This patient will be having high SDF level, and when we are guiding patient for ICSI, the testicular sperm will be having low DNA fragmentation compared to ejaculated sperm. So we can advise to go for testicular ICSI in such patients. Coming to a pyospermia. So pyospermia is nothing but presence of more than 1 million round cells. And these round cells, as we know, it could be immature germ cells, it could be WBC. So when we are staining them with peroxidase stain and more than 1 million WBC per ml is there, then we diagnose those patients as pyospermia. So WBC in semen is a marker of inflammation than bacterial infection. Higher WBC, acrosomal damage, midpiece and tail deformities will be there, and that is how the pregnancy rate goes down. What could be the treatment of pyospermia? So when the patient is symptomless, it should be we have to concentrate on the anti-inflammatory part of it rather than treating with antibiotics. So pyridoxine 1 milligram BD for 3 months and 25 milligram rifacoxib or OD for 30 days, or valdecoxib 20 milligram daily for 2 weeks. In patients who are presenting with infectious symptoms, in those patients of pyospermia, we are going with antibiotic treatment, and the treatment of choice is doxycycline BD initially for a week, followed by OD for next 3 weeks. In pyospermia, frequent ejaculation also helps in correction of pyospermia because it clears the storage and antibiotics acts better in such patients. Even the process of semen sample, if at all the patient is, we are not very much keen on having spontaneous pregnancy rate and wait for that. So in this patient, if you are going with IUI or other treatment, the semen processing, the sperm selection does help to clear pyospermia. Any doubts till now? Because the lecture is going to take very long with all parameters. Can I move on? So, as we understand that some oxidative stress is, semen culture we are not advising. If the patient is symptomatic, he is having symptoms, let's say he is having bronchitis or pain is there, prostatitis is there, in those patients we can directly go with antibiotic treatment rather than. So moving towards antioxidant, some amount of oxidative stress is important for sperm functioning, but too much of oxidative stress is actually causing damage to sperm integrity and SDF levels. So these are the causes before ejaculation and after ejaculation, how the reactive oxygen stress is increasing. But with all said and done, we lack the prediction of pregnancy when it comes about the antioxidant treatment. I'm not going to detail of this. I just want to give a message that the sperm DNA fragmentation does increase with ROS, and ROS affect IVF fertilization negatively, but we can actually overcome with ICSI when it comes to high DNA fragmentation. So what parameter we should have? We should not give empirical treatment to every male who is coming with low motility or the reactive oxygen stress is high. It's an empirical treatment, and everybody right and left giving prescription of antioxidants. So we should have a measure for oxidative reduction potential, and that analysis will correctly guide us in which patient is going to be beneficial, in which patient it's not. ASHRAE has given clear-cut guideline about antioxidants. They are not recommended since no measures of oxidative stress is available. But this machine gives oxidative reduction potential with the semen sample, and the reference values will give how much oxidative stress is there in that particular patient. And then we can guide about the treatment. In which patient this can be useful? These are the patients with unexplained idiopathic oligospermia and sperm donor patients where we want to give more result. So coming to how long we should give antioxidant therapy, definitely not beyond 3 months, because there is no clear-cut evidence about the selection criteria and duration of treatment. And clinicians should know that we should not waste a precious female time just treating the male partner with antioxidants. And antioxidant does come with few side effects, and we don't have any existing standards for the treatment. It could be natural or synthetic. L-carnitine, it increases atherosclerosis. Vitamin A, lung cancer and cardiac diseases will be invited. Vitamin E in excess will cause cardiac problems and prostate cancer, and all mortality if it is 400 IU. So when we are advising antioxidant therapy, let's not advise and continue for months and months. It's restrict ourselves for 2 to 3 months therapy. So in oats, I mentioned varicocele is one of the factor where we can correct with varicocelectomy. In India, maybe we are not doing the varicocelectomy in a correct way. So many times we find that after varicocelectomy, there is decrease in the semen parameters rather than improving it. And then finally, the patient blames that I went through so many things. And finally, you are again advising ICSI treatment. So in which the varicocele surgery will be helpful? In clinical palpable varicocele and infertility patients with low semen parameters, except for azoospermia. In these patients, is going to be beneficial. No surgery is advisable for non-palpable or only imaging-based diagnosed varicocele. 40% of the patients will be infertile patients will be having this. What is important when you are advising varicocelectomy treatment to any couple? It should be a holistic approach. Do consider the female age and ovarian reserve when we are going ahead with the treatment. And varicocelectomy does improve sperm DNA fragmentation and correct the oligospermia. We came across a very beautiful paper, as I mentioned, that we are not doing varicocelectomy in a proper way. So how the microsurgery surgery technique will go about? So this particular paper explains that inguinal incision or subinguinal incision with 20 times of magnification, 3 millimeter microdoppler, and throughout the surgery, when we are maintaining the temperature, when we are maintaining the blood pressure beyond 100 millimeter, if at all we are following all these steps meticulously, your varicocelectomy is going to give beneficial result. And many of us will be behind the laparoscopic correction of varicocele. Trust me, this paper had given a very beautiful evidence. The laparoscopy rate, when it comes to the pregnancy rate and recurrence rate was higher in those patients, and pregnancy rates were lower compared to a microsurgical technique, which I mentioned just now. The pregnancy rate was 41.9% and the recurrence rate was low. So in varicocelectomy, the microsurgery technique is going to be an important point when you are advising the therapy. And these are various papers which are talking how the pregnancy rates been improved after varicocectomy. There is increase in the pregnancy rate almost 42%. Cochrane also says the same thing, it improves the sperm parameters, and it does increase the total motile sperm concentration also. Coming to sperm DNA fragmentation, there are many factors which actually cause sperm DNA damage. It could be from your lifestyle, your BMI, weight, There could be pollution, increased testicular temperature, varicocele, so on and so forth. How we can go ahead about the treatment of SDF? So nice guideline is given by this paper where we are evaluating an infertile couple, and these are the indications for doing SDF testing: unexplained idiopathic infertility, recurrent miscarriages, lifestyle risk factor, varicocele, and recurrent IUI or IVF failure. If at all we have these patients, we can actually ask them to go for sperm DNA fragmentation. If the sperm DNA fragmentation is high, what could be our treatment approach? So if at all it's a correctable factor, then correct with recurrent ejaculation, antioxidant, lifestyle modification, control of infection and inflammation. And varicocelectomy, as I mentioned, that it does improve the SDF levels. And even if after all these modifications, still the sperm DNA fragmentation is high, then ICSI is the better choice with high DNA fragmentation. And it does help in patients with recurrent miscarriage. When the SDF, when high SDF is there and we want to go ahead with ICSI, we have to select a sperm with less DNA fragmentation, and microfluidic analysis will give a less DNA fragmented sperm, and that sperm selection method we can use. Otherwise, when there is high DNA fragmentation with recurrent pregnancy loss or recurrent implantation failure, testicular sperm is having low DNA fragmentation compared to ejaculated sperm. And in few patients, we tend to advise going for surgical sperm retrieval rather than using ejaculated sperm when it comes to sperm DNA fragmentation. So why not do this SDF level for everyone, but for ICSI, because ICSI corrects the sperm DNA fragmentation. The methods available with us for sperm DNA fragmentation are sperm chromatin dispersion assay, SCCA and SCD, they are in poor predictability. Tunnel and comet assay is having better predictability. This paper does tell that we all are using SCD method in our practice because it's more cheaper. At the reliability of SCD test, we can take 2 semen samples with 3 months apart, and the mean of that will give a good predictability in sperm DNA fragmentation. Coming to the SDF level, the normal SDF level is less than 20%, intermediate 20 to 29%, and high is more than 30%. What is important, we won't be having any semen sample with 0% sperm DNA fragmentation. There is always a DNA fragmentation comes along with semen analysis. And how in semen analysis we can correlate with DNA fragmentation? The motility is real-time indicator of viability and is indirectly then related to sperm DNA fragmentation. In idiopathic infertility, 1 out of 5 men will be having high SDF level. Low sperm DNA fragmentation does not guarantee more pregnancy. And this is very important. Like we can't counsel any patient that you have low DNA fragmentation, there are more chances of getting pregnancy. And high DNA fragmentation, it's very difficult you to go for achieve pregnancy, because the female does correct some percentage of DNA fragmentation. Clear association of SDF to unexplained RPL has been analyzed with this study. So to our surprise, when we were dissecting this topic of DNA fragmentation and how we can go about therapy and improve the results, there were almost 52 meta-analyses published on this sperm DNA fragmentation and outcome. We went many of that, and what was our, we wanted to analyze what will the results, what exactly the semen DNA fragmentation treatment is going to beneficial for the patient. So there is clear-cut association of sperm DNA damage with pregnancy loss. But when it comes to effect of sperm damage on ART success and effect of sperm damage on embryo development, we have conflicting results in these 2 areas. This is because the heterogeneous population which is selected and various methods which has applied in the studies. So to summarize, is the only association of sperm DNA fragmentation currently is only with recurrent pregnancy loss. And if at all we are going with ICSI, and those patients will get more benefit out of in case of embryo development and continuation of pregnancy. Then what are the assays which I have mentioned about the sperm DNA fragmentation? Can this test is advised to distinguish couples and who need medical therapy and who does not? The study does convey association, but limited capacity to predict the chance of pregnancy in context of medical assisted reproduction with DFI results. And this is mainly because heterogeneity data with ART outcomes. As I mentioned that some part of DNA fragmentation is corrected by oocyte, and oocyte having that ability to repair sperm DNA fragmentation to extend, and it all depends on the oocyte competence. So age of oocyte determines the outcome since it retains the capacity to repair paternal genome after fertilization. ICSI works best in SDF cases because ability of egg to repair this sperm DNA damage will determine the progress. What is not known to the science that we don't have that threshold or threshold, like, what is the threshold damage which egg can repair in, it is not known to the science. So obviously a patient with advanced maternal age or low ovarian reserve cannot correct the sperm DNA fragmentation as the normal and young lady could be. So ICSI has fertile eggs, IVF sperm in media. It is like firefighting in all ROS media before entering in egg. So one sperm, one egg acts like a typical female, spending all her energy to make that sperm neat and clean and giving the pregnancy rate. The recent annual meeting of ASHRAE, the paper was published depending on the FSH therapy, which I quoted just now. So it was done in idiopathic male infertility patients, and retrospectively they analyzed what the FSH therapy do for sperm DNA fragmentation improvement. And when they analyze, so they found with the FSH therapy, the testosterone level does go higher and it was statistically significant. And the SDF level improved from 17% to 15%, and that was also statistically significant. It does improve the sperm parameters also when after the FSH therapy. But if at all you look carefully, the sperm DNA fragmentation, the levels here in major is almost normal to intermediate. So I can't give you the advice like FSH treatment will definitely improve the sperm fragmentation, but definitely it will help in patients with oligospermia. As I mentioned that when we have a ICSI as a choice for high DNA fragmentation, the question is whether it's testicular ICSI or ejaculated sperm ICSI. Like as mentioned earlier, that testicular sperm will be having low DNA fragmentation. The patient, we have choices to go for ejaculated ICSI and testicular ICSI, and how we can choose patient which therapy we should give. So we can use ejaculated sperm in patients with primary infertility, young couple. The female is having normal ovarian reserve and normal other sperm parameters. In those patients, we won't subject those patients for testicular sperm retrieval. In testicular sperm retrieval is advisable a patient with very high DNA fragmentation and advanced age, low ovarian reserve female, and unexplained recurrent pregnancy loss with high DNA fragmentation. So as I mentioned, that DFI of 8.3% in testicular sperm versus 40.7% in ejaculated sperm. Herein, the major confounding factor is a female, and that is why a young female and normal ovarian reserve will correct the DNA fragmentation better. This is a summary which I had already conveyed you, how we can go ahead. You can just take picture of that. Then coming to the sperm selection method. So whether the sperm selection methods are giving a sample without a DNA fragmented sperms. So we have density gradient and we have swim up method. Density gradient, like in the sample which is collected at the last and when we are doing insemination, the DNA fragmentation sperms will still get selected. So the density gradient method does not decrease the DNA fragmented sperms, and they will still get selected. Same with the swim up method, where it all depends on the mitochondrial intact, and the sperm will travel. So these patients, when we are advising swim up, they are also not very much helpful when it comes to DNA fragmentation. The DNA fragmentation sperm still gets selected. Then this is the typical procedure how we go ahead about the density gradient. What important point to be noted is all the media to be equilibrated at 37 degree when we are doing a sperm processing or sperm selection, whether it's for IUI or whether it's for ICSI. Then, as I mentioned, the microfluidic device. So herein, when we are selecting a sperm, there are chances that we can actually, rule out the DNA fragmented sperms. And this is the theory behind it. When that sperm travels through all these channels, and finally, when the sperms arise here, that sperm is having less DNA fragmentation, And that sperm selection method will help to select the sperms in ejaculated sperm where we are not advising testicular ICSI. Thank you for the patient hearing. Questions? DNA fragmentation is not correlated with the sperm concentration. Yeah, so like when it's a severe oligospermia, less than 5 million, the DNA fragmentation. Yes, sir.
But the labs refuse. If the counts are less than 5 million, they say they will not be
Even
able
with
to
flow
do a
cytometry?
DF. Yeah,
Even with tunnel assay, tunnel is allowed.
it's allowed.
I don't, it's only the SCD method and SCSA methods we suffer. Otherwise, I don't think there is a problem. But I'm not using tunnel because it's not available to us.
But again, you're doing it only for those cases where there is recurrent pregnancy losses or the IVF
The
failures
main
or
indication is
implantation
recurrent
failures.
pregnancy loss. As I mentioned, like we have conflicts of results when it comes to embryo development and implantation failure. Because in implantation failure, it's more over the implantation and the further part of it. So the DNA fragmentation, when ICSI is the choice, it's already get corrected. So we are not helping those patients with recurrent implantation failure.
But one small question is like when we just or list out everything on the list or whatever investigations available. In your clinical practice, when a patient walks into your chamber, what all will be the basic investigations will be advising for the male partner?
So it should be a holistic approach when we are taking the couple into consideration, and like the male factor of infertility is the only parameter and the young female is there. Then we can go about the analysis of DNA fragmentation and whether, because we should not waste her precious time also. So in that patient, we are advising. And as I mentioned, why not advise this sperm DNA fragmentation to everyone? Because like the couples are trying since long and then they are coming for consultation. So many times we come across the patient where they're having high DNA fragmentation and which we can advise to go ahead with the ICSI rather than just treating those components.
I think your question was also about what
Yes, sir.
what square of investigation
Yes,
should you?
yeah.
So let me
So
just tell you.
not to do everything
Yeah,
possible for a patient, like what I meant
I would
was.
say, number one, if your TMSC is coming less than 20, it's
Yes.
better to know the whole profile. Because unless you do the whole profile, you wouldn't know. Mohan, please come. Mohan, please come. Unless we do the whole profile, we wouldn't know which is a modifiable factor and which is a not modifiable factor. So at my place, we do a estrogen, testosterone, LH, FSH. We'll be doing a scrotal scan because not many of us do clinical examination of testes, which is ideal actually. And depending on all these parameters, we'll take a further call. And if there is a treatable thing, if the wife is young and her ovarian reserve is good, because we are all guided by the wife's ovarian reserve here. Whether we have ample time for the male to improve on his count and everything. And then we'll put across what kind of therapy we want to view, what could be a success rate, and what will be the future plan. Like we don't promise them your count will get going and you'll get a spontaneous pregnancy. Very few of them will get it. But we do all the tests, and it's also a part of research because what we have identified is we are giving treatments and evaluation to TMSC less than 20 or less than 5, which is again, yes, we have to do it. But then there is from TMSC 20 to the TPMSC 55 is another range, which could be suffering from unexplained infertility or multiple IUI failures. And we are just trying to find out by getting evaluation of done and giving treatments, can we push these clients beyond 55? And we can, if we can achieve spontaneous or IUI pregnancy, that's a part of work which prospectively we are doing. And actually, we want more and more people to participate in this work also. So if we can make it multicentric, but that could be a very mild factor, male factor, and which will be modifiable very easily, and we can have more success.
Like, I just wanted to ask, like, whether you're still recommending varicocelectomy for patients who are having varicoceles, or you're directly going for PISA?
I think that's a very important question.
Because that's a total waste of time, I feel, most of the time.
at least because we are ART consultants, we'll end up seeing a lot of clients on our side of the story who have done varicosilectomy and not been successful over 6 months and 1 year, and they come to us. We don't know about the people who undergone varicosilectomy and have been successful. With the varicosilectomy, there are two things I would like to say from the technique point of view. A lot of youngsters feel that they could go for a laparoscopic varicosilectomy. It's a big no-no from us. We'd like to go for a under microscope, traditional varicosilectomy. And again, the kind of methods which Dr. Sharif just mentioned, using those, micro Dopplers, keeping the systolic blood pressure to 100, all those smaller things are possibly not practiced in a particular way, or taking a subinguinal or suprainguinal incident or subinguinal incident. And that could be one of the reasons why varicosilectomy we don't see very often giving us good pregnancy rate. Whereas Anil and Mohan, if you could just comment on varicosilectomy giving spontaneous pregnancy rates in your practice.
I'm just a little jet lagged, if I say, but the thing is, it's varicocele is the question whom you asked. Okay, so the urologist will swear by, but at least in our institution, the urologists are not at all happy to do any varicocele. But then I am also in touch with groups. There are specific groups, especially in the US, which are big time into male infertility and the sperm DNA fragmentation, and there's a big movement on that. And there is a school of thought which believes that it helps. But my only problem with all this is that these are all observational studies and they are heavily biased. So they have not been able to plan a trial which is large enough and has the right parameters to prove this. So unless you have that kind of a trial, like I know that even for ICSI, for non-male factors, now the large trials are coming. Like all of us, at least I know that we have been doing now ICSI even for non-male factors. This is a fact we all know. Like a lot of countries now, the ICSI rates have hit 90%, 60% and things like that. But now I know that certain trials are coming from Vietnam and China, which have shown that ICSI is not showing that benefit. So similarly, the problem with varicocele is we haven't yet identified who's going to benefit, and that's a real problem. And I feel it's because we are not able to diagnose it the right way, and there is, those kind of things. So I would be very wary of there is no high quality trial or a study which has supported varicocele. And I don't know why my urologist colleagues are not able to do that. So if you believe that this is really working, it's all about putting a trial in place. And there's been just so many papers coming out, but it's not, there is no single randomized trial which has shown it to be beneficial.
Wanted to know just my own thoughts. It's not like a major doubt. What are the important parameters you're looking into the semen analysis when you take it as a cutoff that this is the patient, I think I can try an IUI, or this is the patient, I think I wouldn't be trying an IUI, I'll go for an IVF, ICSI. So I mean to say in terms of the motility, numbers, and the morphology, what are the cutoff borders, like where you decide that this patient is not eligible for an IUI? Because most of the time patients come from other centers, they're pushed for IUI, they're asking for IUI. In spite of you explaining them that, no, this is not, you're not going to benefit from IUI, they're not ready to listen to you. So is there any cutoff parameters where we can absolutely with confirmation, we can say that, no, this is not going to work for you?
So in semen analysis, the single parameter we can't target. So as I mentioned, that semen parameters is having so many fallacies. And when we are taking into consideration about the total motile sperm concentration, and when the total motile sperm concentration is beyond 10 million, we can go for IUI. And as I mentioned, when the insemination count is less, in those patients, like when it's less than 1 ml, it's ICSI the choice.
No, but at that time, you're not looking at the motility aspect. Suppose the patient is having asthenol.
Total motile sperm concentration.
Like you are having somebody who is having a motility is, let's say, progressive motility is 20%.
Yes.
Let's say progressive motility is 20%. but that doesn't tell you a complete picture. Because if this person has a semen volume of 6 ml, and even the count, let's say, is 15 million, his total motile sperm concentration could be very good because he has a good semen volume. So we have to go holistically at a total motile sperm concentration as the research stays today. Okay, and that would be a guiding factor because just the WHO parameters were basically done to standardize semen analysis all over the world. They were not telling us the fertility prognosis. We'll have 100 million wala patients who are not pregnant, who are not achieving pregnancy, and there will be many little lesser count also they are achieving pregnancy because the wife is fantastically from the fertility point of view. So semen is a very surrogate marker of fertility. Actually, it only contributes to 10% of the pregnancy.
Now, clinical practices where patients have been put on this chronic medication on letrozole and clomiphene citrate, and they come to your clinic and their sperm counts are in the range of 450, 500 million, that range. What do you do with such patients? Like,
this could be very sporadic cases, but let me come to another question. When will you stop your clomiphene therapy? That could be a question.
So the clomiphene citrate therapy, we can titrate with the testosterone dose. And it's like, what are the studies have been published? 3 months of clomiphene citrate therapy is necessary, as we know the spermatogenesis point of view. But whether to continue beyond 3 months, the base marker will be testosterone level and the FSH level. When we are crossing the FSH level more than 2 standard deviation, when we are the baseline is with us, in those, it's if it is not crossing that line, then continue the therapy. So the FSH level increase will be a parameter where we can actually stop the treatment, and testosterone increase, we can stop the treatment. And obviously, we are going to repeat semen analysis, and what difference is making in the semen analysis also will matter.
Have a cutoff there of a serum testosterone of 600 and 17 hydroxyprogesterone of 55. If 17 hydroxyprogesterone is 55 and serum testosterone 600, you just stop the treatment. You're not going to make any difference by increasing FSH or putting anything beyond that. So that would be a cutoff.
That will also be a
Now,
point. for
FSH
stopping
beyond 10
CC.
just tells you that whatever treatment you have started is pushing the pituitary enough
Yeah.
to make a difference to a testis. That's it. Suppose your treatment is not pushing the FSH beyond 10, that means you can improvise on your
Increase it,
treatment. That's what it is. But if let's so the FSH cannot go beyond 20, but all the receptors are anyway saturated by this. So nothing.
So one more question: with all the side effects of possible adverse effects of antioxidant, which Sharaya had just displayed, what would be your ideal regimen of antioxidant? Yes, it's of course there are ample evidence to suggest that it should not be given for more than 3 months. But what would be your ideal combination that?
Thank you so much for this question, because we are facing such huge number of combinations. And you know what happened historically speaking, about 3 decades back, WHO came out with a recommendation that we should be using only folic acid, zinc, selenium, vitamin C, and vitamin E as the antioxidant combination for improving semen risk. And that came under DGCA control. The moment it came under DGCA control, this was being sold at 50 rupees, 50 paisa a tablet. Because it came to 50 paisa a tablet, the whole pharma industry in India stopped it. They added astaxanthin, they added submutase, they added some CoQ, and because they wanted to make it a 6 rupee a tablet or 40, 50 rupees a tablet thing. So in my practice, I feel I would use just coenzyme Q and vitamin C. Then why people make so many combinations? Because the oxidative stress in semen, some oxidative stress will be there in the transit because it becomes semen, because the semen is only outside. Inside it is prostatic secretions and seminal vesicle secretions, etc. So, and after let's say seminal vesicle secretions, the seminal vesicle is infected, it is having more ROS, it is not making any difference to the sperm and the testis there. Sperm and the testis is very happy. The moment it comes out as semen, now it is exposed to ROS. So they came out with, having multiple things together. I think coenzyme Q and vitamin C are pretty safe. I don't venture into any more, and ESHRE guidelines clearly say that there is not a great evidence. And again, we just bought our MOSI machine just 6 months back. So we really don't know how to analyze these upstream. We don't have any data ourselves. Probably we will be able to generate some data and we will be able to inform. We don't know. We really don't. Tell them to give you, make the pricing low and probably.
Ma'am, you talked of repeat ejaculate samples for IUI. So you do different. IUI twice with the sample or just combine the two samples together?
Combine the two samples, and that area, like when the sperm count is between 5 to 10 million and where the female is young, in those patients we are advising. And as I mentioned, that sperm per ejaculate is more important. So when we are increasing the volume, we are indirectly increasing the sperm concentration. So that will help in case of IUI. Right, thank you.
The study says 40 grams. Sample will always be less in volume, but it will be better in morphology and better in the quality. The volume and the count would be little less, definitely. Well, thank you so much, all of you. And we're just taking a small break because we want to felicitate our faculty, which has traveled all the way from London and CMC Vellore. So I request Dr. Anil Guri and Mohan come here, please. Mohan, please. Anil. Pune is a seat of culture and education, not just in Maharashtra, but all over the world. The Puneites you will see all over the world, like half of Seattle could be from Pune. So Puneri Pagdi, the Puneri turban, is the culture here, and that is a felicitation to celebrate your knowledge and to honor your academic commitments to all of it. And Anil, you know very well, and Dr. Mohan Kamath is the best researcher I've ever met in India. When we talk about Mohan, he feels very humble, that he's such a humble personality, excels in academics. His CMC Vellore seat is something people chase for to work under him, do their 5 years course in fertility. He is the Cochrane reviewer, and he is on editorial boards of many journals. There is one person, if I want to follow in my life, is this man. For every small thing. Because, as a private practitioner, I sulk and I feel, oh shit, this is the way to go ahead in life. So whenever I meet youngsters, young fertility consultants, and I keep telling Shari also, follow this person, be like him. Because academically, once you start excelling, then it's a different world altogether, and there's so much to do. And you're not only helping the couple sitting in front of you, you're imparting knowledge to such a huge community, making difference in policy making, everything, and probably making difference to so many infertile couples to get their pregnancies. So thank you very much, Mohan, for giving great contributions to us in India and making India proud. He's one person who's making India proud on international platforms all the time. Last so many years I'm following. Well, Guri has made his distinctive mark on the whole fertility world. And Guri, I'm not going to say anything about you. Definitely no, because I will fall short of words, definitely. He's a very close friend. I'm so lucky, I feel, that I have these 3 people by my side who are helping me out to learn more and impart it to all of you. Please, Guri. हम टोपी पहनाने में एकदम एक्सपर्ट हैं, प्यार से टोपी पहना. Yes, yes.
So I think it would be injustice if we don't say a few words about Sachin. I've known Sachin since probably close to 35 years. And while he stays in India, gives phenomenally good clinical care. And that's very important. As a clinician, I think we require good doctors. And that's very important that, a man of his clinical acumen is rare to find. He's a phenomenal teacher. And through the years, we managed to produce very good studies. And his commitment, even with a very busy private practice, has been huge. And as much as I try telling him, it's why should we teach? We should teach because it creates the next generation who's interested. And I realized that when in my daughter's school, the principal called me up and said, "Oh, our children listen to your YouTube videos." And I said, "That's scary." And they said, "Oh, some of them want to become doctors." Because it's a difficult branch. Being a doctor is not an easy branch. It's not a branch which you take to be rich, or it's a difficult branch to follow because it takes a lot of your personal time. It takes a lot of your family time, and success that comes at a huge price. So as doctors, I think we give a lot back to society, and we do it at a personal cost. And so it's very important that we teach what we know, and that's the way we create a next generation which is good, which can offer good treatment, because somebody should be there to treat our sons and daughters, and when we are all gone, and that's very important that we do it. And lastly, I think it's if you don't do research, you refuse to innovate, and nations become great not by copying, but by innovation. And that's why people like Mohan stand very tall, because they represent an ancient nation that gave much to the world in originality, and that is very rare in modern times. And I think if we need to become great, as our Prime Minister wants us to be, then it is very important that we match up to China in terms of how much research they produce. You credit to China because it dominates medical research today. It's very important that we do that. So who knows? The next generation will have a new breed of people who believe in the concept of India and will push it high and make it mighty. And so let's start on ovulation trigger. And again, I'm not going to tell you which trigger is the best. That's not my job. My job is to tell you how triggers work, how you can mix and match triggers, what is the minimum trigger that is effective, and how can you use this information to help your treatment cycles to be more successful. And then, as I said earlier, it's very rarely that I tell you what you should do, and I may tell you what you should not do, but I will not tell you what you should do. You take up all this data and see what you can do well for your patients. So what is final oocyte maturation? So you want the oocyte to resume meiosis from metaphase 1 to metaphase 2. You want nuclear maturation and cytoplasmic maturation. Remember, both occur independently. And again, this is an explanation which we often find difficult when we see metaphase 2 oocytes and poor quality embryos. Remember, oocyte gives only half the genetic material, though it provides 100% of membranous and cytoplasmic determinants of embryogenesis. And for nuclear maturation, the resumption of meiosis is signaled by the germinal vesicle breakdown. So the GV breakdown starts occurring. There's LHA receptor activation in the first stage of meiosis, and we think it lasts for about 18 hours. And we think that's the minimum duration required post-trigger to allow for maturation. And the total duration of nuclear maturation is between 20 to 22 hours. And we think if you collect an egg before this, it's very unlikely you'll get any maturity. And the oocyte then gets arrested in the second phase of metaphase until fertilization. Now, cytoplasmic maturation is much more difficult to detect, and I don't think we understand it very well as yet. It involves organelle redistribution, cytoskeletal dynamic, calcium releasing activity, and a lot of things. And I think this is a fascinating place where we will end up seeing how we can improve success rates if we can start understanding how the cytoplasm behaves. So why is the LH rise important for oocyte maturation? So what does the LH do? And the LH results in decrease of cyclic AMP, and it starts that process which is needed to initiate meiosis. The fall of cyclic AMP starts the process of resumption of meiosis. So if the cyclic AMP does not decline, then the second meiosis does not start. Now, some researchers believe that that forms a primary reason why immature oocytes occur in some cases. But also what we don't know is that why some follicles continue to harbor immature eggs and why some follicles show mature eggs, even with the same large follicles. And we still don't know whether there's a variable response that tends to occur. The mid-cycle LH surge signals series of intracellular changes, and thus starts the process. So what triggers do you have? We have recombinant HCG 250. Then you got HCG, which is urinary, which is 5,000. You've got the analog trigger, which has the ability of giving you a rise over to such an LH. Then you got kisspeptin, which when I was discussing kisspeptin, but it's not available. And then you got the dual and double trigger concept, where you combine HCG with the analog trigger. So we look at all these, and they act at different places. So kisspeptin acts at the hypothalamus level, the agonist acts at the pituitary level, and the HCG or LH will act at the ovarian level. So different levels at which it will work. So traditionally, why did the HCG come into play? Because LH is inconsistent. It's not a very good trigger to have. You cannot use it as a part of your treatment. And the LH surge is inconsistent. HCG is uniformly has been adopted, and HCG and LH share the alpha subunit and 85% the beta subunit. And there's good evidence now that it can help you to resume meiosis. But equally, both have different receptor binding, and they are not equivalent in receptor kinetics in intracellular signaling. So we all know that HCG falls short, and we even today don't know with all the combinations why some follicles end up being empty in certain women and why the response of follicles is so varied. So for HCG's actions, you need follicles to be pre-ovulated. So as soon as you administer HCG, it causes granular cell luteinization. The synthesis shifts from an estradiol synthesis to progesterone synthesis. Meiosis resumes, and uterine maturation occurs. And follicle rupture then occurs over a period between 36 and 40 hours later. Now, that will occur only if follicles are at appropriate size. So granulosa and theca cell receptivity is adequate, and it then depends on electrical status. So that's the theory of it. And then let's come to the half-life. If you look at the half-life of HCG, it's quite large. And LH half-life is very, very small. The terminal half-life, again, HCG is quite huge, and LH is very low. And there's the LH disappears very, very fast from blood. So that's again the reason why you can't use LH as a treatment. Now, certain points that we should know is that the LH does not inhibit spontaneous LH surge by the intact pituitary. So it seems that the ultra feedback of LH with its own secretion is not functional. So what you'll often see is you'll see that sometimes when you have a 18 millimeter follicle, and you see often in IUI, you have an 18 or 19 millimeter follicle, and you've got a lot of 14, 15 millimeter follicle, and then you trigger ovulation. And sometimes you will see ovulation occurring, but 2 or 3 days later, there'll be an LH rise, and you'll see again ovulation occurring. And this has been quoted to occurring because the LH rise can still occur even if you have given your HCG. And progesterone levels seem to start rising immediately after HCG trigger, not after ovulation, but you see that rise occurring much earlier, and it starts inducing pituitary LH surges in clomiphene and HMG cycles. So the question is, which trigger do you use? Or you can, what there is evidence is that you can use two recombinant has similar oocytes to 5,000 of urinary HCG. Now, how much is Ovitriol equivalent to, or recombinant equivalent? So 250 has equivalence to 6,500 of HCG. So we think that 5,000 seems to work as well as recombinant HCG. And the oocytes seem to be very similar with recombinant, that's HCG and urinary HCG. Follicles ratio with recombinant HCG is the same, everything I said, but that's HCG. Whether you use 250 or 500 versus 10,000, you don't seem to get a huge number of increase in number of oocytes, but you end up seeing a significant increase in ovarian hyperstimulation rates. And the Cochrane reviews have found no difference in rates of oocyte maturation, pregnancy outcome, or ovarian hyperstimulation. So, I have never used a 10,000 HCG dose in my routine IVF cycle. It's generally not required. And almost all there is good evidence that 5,000 is adequate, and that's BMI dependent. So what should be the minimum dose of HCG? And we think for between 2,000, 5,000, and 10,000, and there's no difference in oocyte recovery. But with 2,000, there's a significantly lower number of oocytes. And we think that the minimal dose of HCG is 3,000 international units. Oocyte yield does not increase beyond 5,000. And if there is an increase of BMI, and that is again American-based data, remember that in the United States, BMI ranges right up to 45, 50, where they treat women. In the UK, we cut off at 35, but the Americans treat, and in those cases, we know that higher dose of HCG is required. So should you do 1 Ovitriol or 2 Ovitriol? I'll say 1 Ovitriol is more than enough. The evidence is not there on giving 2. And I think you will push a huge amount of LH activity if you're giving 2. The recombinant 50, 250 gives you more. There is only one study which looked at 2 HCG, which they got more oocytes. But again, you are risking a higher ovarian hyperstimulation rate. What is the only a benefit? I'll say the recombinant is easier to administer and gives less local side effect. Now, there's been a fantastic paper, and I've not presented it because I've not had time, on the unphysiological role of HCG. It's been published in Fertility. It's worth reading that paper. It's a good review into what HCG does in the IVF protocol. So what does HCG do? So let's look at the side effects of HCG. There's a sustained leukotropic effect. It's development of multiple corpus luteum, high levels of E2 and progesterone. It causes increase of LH-like activity, but does not give the physiological rise of FSH. So ovulation in nature gives you a rise of FSH, which is small, and a rise of LH, which is, and it doesn't give you that. High E2 and progesterone levels may be responsive. Remember, high levels of estrogen shifts the implantation window. And in nature, we just don't know where the correct implantation window lies. The trials that doing the ERA tests are all based on frozen cycles. And again, there are single center trial, and tomorrow I think we'll discuss about all the add-ons. And it may be responsible again for implantation failures. But also, HCG acts on all factors. So if you are having the courage to do a dual stimulation, I've stopped doing it because I think I'm not entirely convinced about it. And it can cause delayed ovulation, prolonged ovarian hyperstimulation. And that's the reason why it's non-physiologic. And the question is, are we overusing? And that's something which you have to have a think about. So when you look at the triggers, we mentioned that. So what do you have? You have nature, a rise of 14 of LH, plateau of 14, and a drop of 14. GnRH, a spike of LH, which goes down within 24 hours, and HCG, which continues to have its effect. And I'll always ask this question, is why do you need that sustained rise of HCG? Is it warranted? Does it make your patients feel better? Because even normal responders will have ovaries that are large and take longer to go down. So it's all about LH activity. How long is LH activity is continued? So for a pregnancy, it requires sustained LH activity in nature. And if you want to do a fresh transfer, you cannot do it without HCG. That's straightforward. It doesn't work. So then we look at GnRH analog. So its half-life is shorter, and the half-life seems to last 48 hours, and the surge seems to last for about 24 hours. So what does this create? It creates an effect in the luteal phase because it's not following nature. In nature, you have a 48-hour, exposure to LH, and here you're getting a 24-hour response to LH. And you require that sustained LH activity if you want implantation to work. Why? Because that is what fuels progesterone release. Without that, you're not going to see a change. So what analog do you have? There are a lot of analog triggers. And in fact, as I said, that we use Biserelin, and across Europe, there are no stocks of Biserelin. So a lot of us have stopped our treatment cycles. And you can use Piprolin, Biserelin, Lupron acetate, intranasal, and there's no difference in LH profiles. And surprisingly, there's no dose-finding studies done. So let's look at a few studies where they used triptolin 2 milligram, 3 milligram, 4 milligram, and the number of oocytes has been similar. Number of metaphase oocytes are similar too. So people are trying to look at what could be a dose-finding study. And it's difficult to find a dose-finding study because when you start using it in such large numbers, people are not going to step back and do a proper trial. So the dose seems to be between 0.5 milligram to 1 milligram dose. The question is oocyte maturation rate associated with triptolin dose? Again, when they looked at 1 milligram, more than 2 milligram, or 4 milligram, it seemed that the oocyte maturation rates were very much similar. So it seems that even a small dose of a rise of FSH and LH seems to be quite effective. So no differences were observed among 0.1, 0.2, or 0.4 milligram. So the clinical use of an agonist trigger, why do you use it? You want to prevent ovarian hyperstimulation. See, again, I'll say, why are you doing reproductive medicine? Because you want to sleep well. Why do you want to ruin your lives by having somebody with ovarian hyperstimulation, which causes a lot of stress? Now, all of us have been there. You have expanded tummies, you have somebody who's goes into renal failure, and it's not what we are trained for. We're not medics. We're gynecologists, and we don't want to see those cases. And this almost prevents it. It's almost total, and the reason why I use it is to be able to treat the high-risk patients safely. So what happens in the luteal phase? You see a defect in the luteal phase. You see a significant defect. Now, as I told you earlier, and this was when Numedin did it, and this was the first study, it requires courage to be able to know a concept. Now, I've got huge respect for Peter Numedin because much of the luteal phase studies have come up from him. And if you see, when you look at the ongoing pregnancy rates, when they gave estrogen progesterone, it is 5.6%. As soon as you added HCG, the results were much better, but also you had ovarian hyperstimulation. So if you do not give any support, you disrupt the luteal phase, and you also have a lot of biochemical pregnancies. So it's that concern of what causes biochemical pregnancies. And again, I have a lot of signal. You have HCG reaching 60, 70, and then becomes negative. Why? We don't know. We don't have the right answers. We screen embryos, we do endometrial tests, and the rate of biochemical pregnancy marginally decreases but continues. So that's something which we still don't know. In fact, we wrote a review about 10 years ago on biochemical pregnancies and published it, and nothing has changed since then. Which means we are still at sea about biochemical pregnancies. So don't use just an agonist trigger. You can rescue it, as I told you in the earlier lecture. If you want to do a fresh transfer, you're courageous enough, but also you don't have a lab that can freeze embryos, then go ahead and do giving HCG on day of ovum pickup. So here what you're doing is you're saying, I'm willing to take that small risk. I'm willing to give a small dose of HCG and give it on the day of ovum pickup. And in Peter Humaydon's study, there were no ovarian hyperstimulation. But this was followed by a Turkish study which showed that the rate of severe ovarian hyperstimulation was about 3%. And again, why? Because phenotypically we are different, we react differently, the metabolic syndrome affects us very differently. And some bad PCOS who have large ovaries, with that small amount of HCG will go into severe ovarian hyperstimulation. So that's what you can add. But again, what is the best option? The best option is to freeze them. You know, you can de-link this process. You can separate it into two. Now, you know, it takes a slight courage to be able to say, you know, how do we check for the result? Now, and I think this is fascinating because what it has told us, it has allowed us to understand the luteal phase better. And it allowed us to understand the early luteal phase significantly better. So can we check if the analog trigger has worked? And I'll tell you my concepts. We are desperately trying to prove it. We've written one paper which is going for publication, and we haven't been able to prove it. So we're trying to collect data for another paper, which with a different lab, and that's for my private practice, to see whether we can understand these concepts. So you give the LH peaks after 4 hours, and then you can repeat your LH test 12 hours later. So at present, we think that if your LH is less than 15, then the trigger may not have worked. So but if the LH is more than 30, then the accepted failure rate was around 1%. So how do you check for LH? So you have a successful Heron's figure. So you see the LH rise, and you see the LH which is low. And you think, oh, that's it. That confirms the triggers work, but that's not so simple because this gives you a confirmation that there's been an LH rise. It does not tell you that you're going to get eggs. You're more likely to get eggs, and we think that the failure rate here when the triggers work is 1%. It means that in 1% cases you still don't get eggs. But here we still think that some women will continue to get mature oocytes, which again tells us is that how much LH rise do you need? We don't know that too. But it seems that even a small LH rise may be sufficient to give us some amount of oocytes. So again, they looked at this study where they said that if your LH was low, it's not that you don't get oocytes, you may not get, but you also get lesser number of oocytes. But see, this is the challenge is, do you go and collect the eggs or not? And what I tend to do is I collect eggs on one side, unless there is no rise of LH, where I know that trigger hasn't worked, but if it's gone to less than 15, between 10 and 15, so let's go and collect one side and see. Maturation rate is also possible when the LH is low. And the oocyte yield also happens in these various studies, which means that we've not yet come across, we know when the trigger has worked, we can be more confident that we are able to get eggs. But when the LH is low, we still don't know at what stage we can safely tell the woman, I'm not going to go and collect your eggs, which means that we may still get eggs. So this is how it will look. This is a post-LH trigger from one of my patients. So you see a rise of FSH. And I feel nice when I see a rise of FSH. You see a rise of LH. So you see a rise of FSH, it tells us that the appetitive response has occurred. You see a rise of LH, and I like it, that has worked. But I'm beginning to believe that the progesterone holds the key. Researchers don't agree with it, and it's my job to start looking for, we're collecting data to try and show whether we can convince us. Now, let's look at physiology. What happens to granular cell if there's luteinization that occurs? The higher your progesterone, my logic is that it also tells you about the follicular phase. So if the progesterone is high, your your maturity of eggs may be better. That's my theory. But at present, there are many papers that have come up which have not convinced it, but I'll say keep a watch out at the progesterone. If progesterone is low 12 hours post-trigger, I am quite certain that maturity is affected. And you tend to get a lesser number of mature eggs. And I think that is something which is important. So is GnRH effective? The failure rate of a trigger is between 2 to 3.5%. HCG failure rate is between 1.5 to 2.5%. So when you see HCG hasn't worked, why is it? Is it bad? Well, that's the failure rate of HCG, that in times you will not get it working. Where, again, there was a very good review on unlocking infertility study, which said, what are the risk factors? If before stimulation, the baseline LH is low, masking a hypo. And remember that in modern times, women are slimmer. They are more likely to lose that poor fat and switch off the pituitary. And you will be seeing more and more of these women who there's no reason to switch off the pituitary, but they're switching off the pituitary because they're dropping critical body weight because they want to be very slim. And they had noticed in this review that the failure rate is higher when there's a very, very low BMI. So if you compare the efficacy of GnRH with HCG, again, studies have been very. Some cases have shown more mature oocytes. Fertilization rates have been very similar, and that early pregnancy loss was only when we gave GnRH on its own. And meta-analysis have demonstrated similar maturation, shorter luteal phase, and everywhere, we know that there's disruption in the luteal phase. So it seems that the maturation rates is very similar to each other, and it also shows that fertilization rates when you give HCG or analog is very similar. And people started thinking, why don't we combine triggers? That is the beauty of medicine. You can try and work and try and mix and match. And you can, when you go home, you can try and mix and match and see how it helps your patient. But there has to be a logic. It's not wrong to be mad. There has to be a logic in that madness. See, people like Hitler, Mussolini, there was no logic in their madness. That is dangerous. But otherwise, you can work and see. So, what is the combination? So, what they combine is HCG and with GnRH analog. Now, where did this concept come from? And this concept came from the Israelis. And I saw this paper written in 1975, where the Israelis came up with this phenomenal idea and said, let us give a bolus of FSH. And there's a recent paper in Fertility, where they've given 1,500 HCG and a bolus of FSH on the day as a trigger. And that has shown to see slightly more oocytes. So it seems that in some women, having that addition amount of FSH rise is beneficial. If you have a look at that paper in Fertility, I've written it down, so I'll probably present it sometime when I go back. Now, what is a dual trigger? A dual trigger is one after another. Which one do you choose? Toss a coin. I tend to, on a Monday, I give GnRH first. And Tuesday, I do that. So it keeps me and the patient entertained. A double trigger is when you do a rescue, which means you give analog as a trigger and you give HCG as a rescue. That's 36 hours later, and that's different. So it's just a play of words. So where is the role of dual trigger? Again, there are few researchers who very solidly believe that a dual trigger works. And the concept is that when you want to have a better meiosis, when you see a large number of immature oocytes, and HCG, which is given, does not mimic the FSH rise, and FSH seems to play a good part in maturation. So this is again a paper we looked at combined agonist in poor ICSI outcomes. So this is a retrospective study. Again, patients with fertilization rates of less than 20% in 2 prior ICSI cycles, more than 5 oocytes, young patients, normal FSH, They gave again another cycle. And when they gave HCG to 74% of patients, and they gave a dual trigger to the next group of patients. They gave a slightly higher dose of HCG. And what they saw was the live birth rate was much better in the dual trigger, which is the normal response. For some reason, they were not getting adequate mature eggs. And so the metaphase 2 sites, very similar. They implantation rate significantly more, live birth rate significantly more. So it seems that in a certain subgroup of patients, giving a dual trigger seems to work. There seems to be an improvement in oocyte yield when you add HCG, and certain studies have shown that this concept seems to work. So now, how do you find out whether there should be a general consensus? So you combine all the studies and you look at meta-analysis, and it says, well, again, giving a dual trigger did not make a difference to oocyte rate, seemed to improve the live birth rate. So it seems that there's some role in using a dual trigger. It doesn't seem to benefit all patients. Again, we don't know where it benefits. So I think in poor responders, we don't have that data yet. My way of dealing with it is to give a double trigger because there's not much to lose. Studies suggest that endogenous FSH may have a stimulatory effect on oocyte competence. It increases the gap junction. Low FSH levels may increase in mature ooplasm and mature oocytes. And again, this was based on giving the bolus dose of FSH, and that did show slightly better results. As soon as you see a higher number of oocytes, there have been researchers who have shown a higher 2p embryos, and granular cells have shown a higher RNA rate. So dual trigger may seem to work in those cases where you have seen in previous cycles a low number of oocytes, low number of maturity, poor fertilization. Again, these are younger patients who seem to produce a reasonable number of embryos and not at the risk of ovarian hyperstimulation. So next we come to, we don't know much about the analog here. So let's, HCG, there is better data. And we'll say, what is the interval between HCG and oocyte retrieval? And it seems that LH rise to ovulation, the median interval is 32 hours. And as Sachin just showed, that the LH in nature is quite variable. The peak of LH is about 16.5 hours, and ovulation occurs anytime between 16 and 48 hours after rise of LH. HCG seems to have a follicular mean time of 38.3 hours. The range seems to be between 34 and 46 hours. So this was a study done again, which quoted that if you looked at giving HCG and collecting eggs before 36 hours, the oocyte was about 63%, 36 to 38 hours, 60%, and 38 to 41 hours, 62%. And there's no change in fertilization, there's no change in oocyte. But what we know is that as you extend it beyond 37 hours, the rate of premature of ovulation marginally starts increasing. So again, you look at maturation rates from HCG trigger, and whether it be 35, 36, 37 hours, it's less, but also as you delay egg collection, the maturity improves. So there are some clinicians who, when you have a poor fertilization, when you have poor number maturity, you collect eggs at 38 hours. Again, looking at darker cytoplasm, I don't think it makes a difference from 35 to 37 hours. So again, a darker cytoplasm, we don't know why that happens. Again, what is the follicle size? And I think I recently presented the paper which looked at follicle size. And oocyte maturation is better when follicles are closer to 23 millimeters. We think that over the age of 16 millimeters to 22 millimeters, follicles are more likely to contain an egg. If you see follicles at 17 millimeter or 18 millimeter, extending the trigger by a day leads to more maturity, but also leads to increase in progesterone levels. Kisspeptin again is a new kid on the block, and it acts on kisspeptin receptors. Trial has been promising. Endogenous LH life is 1 hour, and the doses vary. And in fact, this may be good for those patients who have was so bad PCOS that even the analog treatment will push them towards ovarian hyperstimulation, but it's currently not available. So we'll briefly talk about empty follicle syndrome. And this was, I'll quote a paper, and this is, I think, a very courageous person who published it in 2012. So now what is empty follicle syndrome? It is no oocytes are seen, and empty follicle syndrome seems to vary between 0.4% to 3.5%. So it's a huge range. And it's either a genuine empty follicle syndrome, where you see a failure to retrieve oocytes from mature follicles, good follicular development, optimal HCG, or a false, in which there's a low HCG. So there is either an error in administration or a problem with bioavailability. So this was a 24-year-old patient, 8 cycles with no eggs. Would you present this? Like saying that to a patient, but I would give credit to the patient who stuck to the doctor, and the doctor who said, "I'll try something different." But remember, this was almost 10 years ago, when you had to look at what else will you try. And 9 OPU, they gave 1 ml of decapeptyl 40 hours before, and HCG 34 hours before. 16 M2s, 2 transferred, 9 blastocysts preserved, and a singleton pregnancy. And I think that's brilliant. That was in the 9th cycle, which means that there would be cases in which you would see young women going through empty follicle syndrome, and that could be because HCG was not working. And in some cases, you do require that rise of FSH. So how does the mechanism of empty follicle occur? Either premature ovulation, or there is a low bioavailability of HCG. You're given 10,000 HCG, but there seems to be less HCG available. Time of HCG administration to maturation complex, so you collect eggs slightly sooner. Sometimes there's a mild torsion of the ovary, and that has also been known to increase the empty follicle syndrome. As women get older, follicles tend to be empty, and there seems to be more defective granular cell function. And this for some reason, especially as women age, there's faulty oocyte development. Almost all the empty follicle syndromes seem to have occurred in downregulation cycles, not because it causes downregulation. It happens. It probably happens because those were the maximum number of cases which have been studied. So many options have been suggested. One is to re-administer HCG from another batch if one side is empty, and changing HCG from urinary to recombinant. That's what's been done. But remember, this was the long protocol. On the agonist protocol, I'll say antagonist cycle. I use analog as a trigger, and then prolong the interval between oocyte triggering and OPU, which means that if you see persistent empty follicle syndrome, then you can take a risk of collecting eggs 38 hours after trigger and not 36 hours. And that has also been tried and tested. What does the analog do is it creates a rise of LH and FSH, and we still not understood what role FSH plays. It may possibly help in luteinizing granular cells and increase plasminogen receptors. But again, we just don't know. And these are all possible mechanisms where the FSH seems to work. Now, the FSH surge seems to have a direct action, but equally, people say, what happens to the LH pathway? Now, we have a habit of giving the antagonist in the morning and giving the trigger in the evening, because we believe that if you give trigger and the antagonist close by, it doesn't seem to work, and that's not true. So there's a very good study, and I think I presented that one online too, where what they did is they looked at giving the antagonist at various times, and you noticed that there was no difference even if you give the antagonist and the agonist trigger on the same line. We think that the agonist trigger uses a different pathway to start the ovulatory process. You can prolong the stage to 37 hours or 38 hours. And again, meiosis begins 18 hours after LH surge. And the threshold of LH needs to be between 14 and 27 hours. It's a time-dependent process, and it varies from person to person. In some women, and we don't know which women, that cumulus expansion takes longer and seems to happen when aspiration is done slightly early. And so if you are going to see repeated, I would say one option is to just delay the oocyte collection and allow for more time to pass. In summary of empty follicle syndrome, genuine empty follicle syndrome does exist. Follicles may not be empty, oocyte may be retrieved during standard practice, and it does represent a syndrome of granular cell impairment where cumulus expansion and cumulus oocyte disruption does not occur. So the next time you plan to shoot and plan to trigger, think again what you want to use. Thank you. Any questions? You know, when you don't have questions, you're being so convincing that there are no questions, or you have confused people so much that you don't want to ask you questions. Yes. Yes. Yes, I think, and I've done it. I've tried it too, and I think it doesn't seem to make a difference.
No difference. Sir. And just, I think it's little off. How many days of antagonist can you really give? See, normally, how many total days? Is there a cutoff that you should not go beyond 5 days, 6 days, 7 days, 10 days?
I don't think so. I think there are some women where you have ovaries that take longer to stimulate, and you start antagonist around day 5, and then this can go on for 10, 12, 14 days of antagonist. And that doesn't seem to affect oocyte quality. It doesn't have an impact on oocyte quality. I think the stimulation may have an impact, not the antagonist. And poor responders also, it takes time. And their oocyte quality is affected because they're old. And age then has an important factor rather than the antagonist.
So number of days doesn't make a difference.
No, it doesn't.
Thanks.
See, there is some evidence that if you push ovaries very, very hard, then oocyte quality may be affected. And there's some evidence there. I'll say, I don't think, I am of a firm belief that when you stimulate poor responders with a very high dose, you stimulate women who have a low reserve. I don't think gonadotropins cause a poor quality of oocytes. I think you cannot change oocyte quality. So stimulation does not change oocyte quality. It may give you more oocytes with poorer quality because you're trying to scrape oocytes which are not very good. But oocyte quality is rarely changed. You even get poor oocytes, they're poor whatever stimulation you've done.
Sir, is there any highest limit of the total dose of gonadotropin or not? We can go beyond, like if we have started the stimulation with the 350 or 450, like you have earlier said, according to the patient's situation. So is there an highest limit or not?
Yes, see, there have been studies which say that there isn't much difference between 300 and 450. There is some role in starting women at the dose of 450, and in some cases. So there's a very good book called Debates in IVF and Reproductive Medicine. You should read it. It's a book by Professor Homburg and Adam Balin and Casper. And where there's a good debate written. It's worth trying it, but doses of 600, 1,200, I've never used. I've seen it being used in India, and I don't think they work.
So one more question.
One minute, but let me just give my perspective on this highest dose, how much you can give. The most of the literature says that once the FSH receptors are satisfied on a follicle, taking the FSH level any further is not going to have more, and only the FSH responsive ones are going to go ahead. But if you go to the Optimus trial and the trials which are published on a lower dose, they all are saying the cycle cancellation rates are pretty high. Now, there are two arguments on the cycle cancellation rate. People will say the cycle cancellation is high, but your live birth rate remains the same. And the other argument is, and cycle cancellation should not be viewed as a decrease in the live birth rate. The other argument is, in a private setup of practice in India, suppose you announce a failure and cancel the cycle before you do an OPU, it develops a different doctor-patient relationship. Rather than using a high dose, getting that one egg, putting an embryo, and then failing, which is a common failure all over the place. It's a consensus based failure. So you shift the failure from pre-pickup to post-transfer, and that is more acceptable to the patient and to you, and then that becomes good. And that is one of the reasons when I quoted a Talteriz's meta-analysis. He analyzed all the studies. There were only 2 studies done at 150 IU dose, but most of the studies were 300 and 450, etc. So it is a highly individualistic decision. It's a shared decision making between the patient and you. You need to discuss this in detail with the client, look at the history, what kind of stimulation they have received, what it has resulted into, and then take a call. Rather than, so let's go to another paper by Raula Orivito. All these publications come from Israel because any number of IVF cycles are free of cost there. So cost is not a concern. And Raula Orivito said, after obtaining 0 oocytes, what is the success in the next few cycles? And he stimulated it for 9 more cycles. Until 5 cycles, the cumulative live birth rate kept on increasing. And it was proportional to the egg opted. And when I looked at the dose they gave, the total dose stimulation was 5,000 IU or more, 5,000 to 6,000 IU. But that's only Israel. It's very difficult to practice that kind of therapy because the cost of therapy will go very, very high.
Thank you, sir. Sir, one more question, please. Sir, is there any difference of yielding of oocyte in step up or step down? Like if we have started the stimulation with the 450 and we scan on 4th day and we are getting like towards the OHS patient may go, then we step down the dose. Is there any difference or we slowly increase the dose on 4th day or 5th day? Sir, like I have read in somewhere also ki when we are decreasing the dose, then the number of eggs are also affected. The quality is also affected if we decreases the dose of gonadotropin.
Sir, just want to know why you want to step down the dose. What makes you step down the
So
dose?
in resistant PCOS, as you tell, we should start with a higher dose and then go a step down.
So that would be generally for ovarian stimulation and IVF for a bad PCO. Do you step
Bad
down?
PCOS.
You step down. Okay. I never step down. I'm full throttle.
We have not done yet.
Yeah, because I believe in those
We have
papers
learned
which are
today.
published by, I think, if not mistaken, there were papers on egg donors, wherein they have given high number of stimulation, they got high ovarian response, and they looked at the euploidy rate. In Edwards' era, Professor Edwards kept on saying that when you're stimulating full throttle, you're generating more aneuploid embryos. And when they analyzed this particular paper in egg donors, they had more euploidy rate with more number of eggs obtained. So I think I wouldn't hesitate going full throttle, getting as many eggs as possible and as many embryos, because the chance of euploidy would be high anyway.
What should we do in resistant PCO? If we will not getting the response, we will step up.
Ovulation induction or ovarian stimulation?
Mission for IVF. Stimulation for IVF. Not getting response, even with 525 high doses of HMG. Many times we face this.
Stage comes when, so there are two options. One is that you just tell the patient, go and see somebody else. I'll tell you why that is a reasonable option. Is because by the second or third trial, the patient has lost confidence in what you're doing. And the confidence is plays a huge part in fertility treatments. So I think patients eventually say that this doctor doesn't know what they're doing. And that's true. I tend to tell patients, hang on, see somebody else. And then now, if there's a resistant PCOS, what is resistant PCOS? You have to define what resistant PCOS is. If you give a dose of 115, there's no response, that's inadequate FSH. So I'll say, hang on, and there have been cases where I put somebody on 450 and continued it, but the outcome is generally poor when you start pushing ovaries so hard and to generate follicles.
So one practical question of mine. When you use HCG as a trigger, what time do you time your OPU? And then when you use your GnRH agonist as a trigger, what is your timing of OPU? And when you use a dual trigger, what is your timing of OPU? And when you're using your dual trigger, is there any time gap between the GnRH agonist trigger and the HCG orbital? Do you maintain any particular hours of gap?
So
between the doses?
I collect oocytes between 35 and 36 hours.
That is
Because
post HCG?
all the data on trigger and OPU is HCG based. It's not analog based.
Yes.
So we don't know that yet. So I use a safer route and I say collect between 35 and 36 hours. Which do you give first? Your choice. What do you like to give first? Give it.
No, because there was a slide you said where they tried 8 cycles, they didn't get retrieve any oocyte, and then the 9th cycle they tried.
That was one paper. One paper doesn't.
Yeah. So do you prefer to give a GnRH agonist trigger earlier than the HCG?
No, I give it at the same time.
We do give in our center like
patient
with a
asks
gap
me-
of an hour actually, but I don't know
It
how
doesn't-
much difference it's
I don't
gonna
think it
make.
makes sense. I tend to give around the same time. If a patient asks me a lot of questions, then I tell them to take it 1 minute apart. Because my general rule is if you irritate me at night, I'll make your life difficult. So that's what I do.
So this 35 to 36 hours post trigger remains the same
Yes, I
irrespective
think
of the trigger.
That seems to work in a large majority of cases.
Right, sir. So one more last question. You were mentioning about the use of FSH 450 units along with the GnRH agonist trigger. I didn't quite understand that bit.
With HCG trigger. So so initially it started with the Israeli study when there was no GnRH analog, and they gave a bolus of 450 as a trigger along with HCG and seemed to work better. Very similar concept with GnRH analog. And recently there's a paper in Fertility, and it's good to read it. It says giving a bolus of FSH with 1,500 HCG, does it work? And it seems to work.
Any particular patient group of patients we select for that, or it's just a
If you
trial?
got GnRH analog trigger, give that. It increases FSH. See, what you need not do what all other people do. You have to do what is good for your practice and what puts you, makes you less stressed. And using something like the novel trigger, I will still be a bit stressed when I go to collect it. See, what I want is I want to get to a collection. My blood pressure should be stable. I should not be worried if you're going to get eggs or not. At the end, remember, why are you doing it? You have to make your life simple. We are all clever till the age of 30. After that, our IQ declines. So let us not complicate matters. It's only people like Mohan who continue to maintain a high IQ.
So in your,
Mohan, would like to comment here.
in your clinical practice, when you had this scenario of empty follicle syndrome where you had to pick up from one side and you found that there were no oocytes picked up, did you give the second dose of trigger and then waited for more than 36, 38 hours for the
No.
next pickup?
It does happen that you're given a trigger. So you've given analog trigger and you're not got any eggs. So what I do is I give them an antagonist on that day and ask them to take a trigger at night. Don't give a trigger straight away because you have to wake up at 3 o'clock in the morning to collect
Exactly.
eggs.
Yeah.
So I do that. Mohan.
Yeah, the same. For us, we never had the post HCG. Obviously, we never had an empty follicle syndrome, which was false because we always test. So that scenario, what Professor Guri has said, that post GNR channel lock, if we got, then we kind of give HCG and take a pickup 24 hours later. Otherwise, that pickup will come in the night.
24 hours.
Yeah, we don't really wait for 36 hours.
don't
We
wait for
plan it
36
next, and we've got away with that a couple of times. It happened rarely, but suppose that day morning I do a pickup and I don't find one side, we kind of stop there, give HCG, and go for the next day. We've got two sides, but overall outcome hasn't been great.
But sir said the other way around. He said if you don't get the oocytes, he's going to give an ant tag. He's going to give the trigger that day night so that he picks it up after 36 hours.
It's a style in UK. That's a UK
These are
style.
all anecdotal. Let's just.
And
get
that's a
this
Vellore
right.
style.
These are all
So which
anecdotal.
one
We
is
just
better?
want to.
They're
No,
real
that's what-
outliers. That
See,
we
how
were
do
really
you-
discussing such outlier clients, which
No.
will be 1 or 2 in the whole
See,
year,
please understand, these are all anecdotal things, because for me or for Dr. Pudi, this kind of empty follicle syndrome post-GNR is once in a year phenomenon.
And we also had one case.
That's what I'm saying. These are anecdotal. At best, you will just use your whatever little bit of knowledge and kind of give something. These are all desperate situations, and I can tell you that even after getting insights, we didn't manage a pregnancy. Okay, so that it's not so easy just to fund
it's
HCG
absolutely
variant
uncommon
things.
in our day-to-day practice.
Yeah.
Absolutely an outlier.
And the other
You
comments,
wanted to comment here.
3-4 comments, quick ones. For us, we never go beyond 300 international units in our practice. Because we can argue it out 450, 500 and all, 450, 600 and all, but we never go that way because of whatever the evidence is. Step down protocol is quite a risky protocol, if I may call it, because you have the risk of stalling. So we don't really know where the FSH threshold is. So if you climb down suddenly, you will have stalling. Like that's what we were taught, and we have seen that couple of times early in our careers. And we never go for step down for the same reason. I think with the current GnRH analogs, there is no reason to fear PCOS, and step up should be the way forward. Some of these patients are masquerading are hypo, and that's why probably they don't respond to the dose. Then the only way we salvage them is adding HMG or LH component, because otherwise traditionally for us, it's all recombinant FSH for any patient. We hardly add HMG, but for this group, couple of times, if they are resistant for some reason, there is an underlying hypo, which even Dr. Goody had pointed out, and probably an LH would salvage that. We have seen growth picking up after adding LH. Now, whether it was addition of FSH and LH or only the LH, I'm not able to figure that out, because we don't do biochemical monitoring in IVF samples. Those are my quick thoughts. And the HCG on OPU day for a GnRH analog. So one of the things is, like, we sit on fence for very severe male factors. Lady is like 23 and PCO, and we would like to freeze all because they are typically high risk cases. And we have given a GnRH analog, and we want to wait till the fertilization. So that's why sometimes we defer the HCG for the next day, not the OPU day. We wait for the FERT check, and if FERT check is going fine, then we forego the HCG. Otherwise, if you give on the OPU day, there's always a risk that you will get caught in early OHSS. You can always, of course, get away without transferring, but that is a practical point which we always had a problem. That giving a HCG on OPU day when you want to avoid it, you can defer it till the next day morning till your FERT check is there. That's another practical point. I thought I'll stop there. Yeah, we got No, these are all anecdotal, once in a year phenomena. We got away lucky, but as I said, we didn't get lucky with the pregnancy. So, you don't, but the only way next time is you'll have to change the protocol and get on with the, straightforward long protocol. Yeah, that typically happens quite a bit in agonist trigger. No. No. It's just that is the problem with agonist trigger. I would agree.
Now, I'm quite certain a majority of those follicles are between 14 and 16, and a few are over 20. So when you start pushing 30 follicles to 18 millimeter and above, patient becomes very uncomfortable and goes in pain. So we get scared. So as soon as he starts complaining of pain, we intervene a bit early. Analog works only when follicles reach a good size. So the follicles need to be between 18 and 20 millimeter. So if you go back and you check your folliculogram, you'll see that there'll be only 10 follicles above 18 millimeter. And the majority will be at 15 to 16. That's a complicating part of PCOS. And you will see more immaturity.
A lot of asynchrony is what happens. So that probably is the reason.
We'll take this last question.
Let's take a step back. How do you prove that a follicle is not ruptured?
Next cycle on 30, there was residual follicles.
No. Have you done have you done a progesterone to confirm?
No, sir.
See, there will be some corpus luteum which will appear completely like a follicle.
Okay.
See, without if you start scanning somebody post trigger,
yes,
you are wasting your time. You're
no, so on 30 of next cycle.
Why do you want to do it? Do a progesterone.
Yes, sir.
If your progesterone is low, that's a poor luteinization.
Okay. On the day of trigger, you are telling.
No. Progesterone 7 days after ovulation, so 9 days after trigger. If your progesterone is low, then there's a problem with ovulation.
Okay.
See, otherwise, you're going to ask 10 people, somebody will say, give another HCG. Somebody will say, give another HCG. They will say, no, use this company's HCG.
Yes.
And you're wasting time. I think if your HCG is not working, next time around, give a dual trigger. A progesterone holds a key to tell you whether there's retrospectively whether ovulation has occurred. More than 40. So it's more than 40 nanomoles. So it's 7 days after ovulation. 3 nanogram.
3 nanogram. It's a.
So, hello, sir. But actually, I've tried all three of trigger. I also tried with Busac and Hucago also in third cycle. But why the ovulation is failing in that patient?
Madam, come out of letrozole, go to gonadotropin, have more follicles. 2 will rupture, 2 will not, and it will solve your problem. Let's not go back and keep sitting on that letrozole HCG, Go ahead in life. Go with gonadotropins, have more follicles. They will do well, madam. Don't worry. Because this scenario cannot be dissected so much.
Okay.
I feel this can happen to everybody. Everybody is having one
So
case
sorry,
or the
one
other.
more
So
question.
no point dissecting that again and again. Best is to move ahead in life. Don't, instead of changing to urinary to RFS HCG, just come out of letrozole, add gonadotropins, have more follicles, you will succeed.
It was combined cycle, sir. Letros plus HMG.
Then how many follicles you got? Just for
3 follicles, sir.
They all did not rupture.
That's why I'm
give your
asking.
trigger little early, madam.
Okay.
Give her
So
trigger
for
little.
that, I tried also
Yeah,
urine
probably
ovulation.
what could have happened is your her LH has gone up, that has luteinized, then your trigger has gone. And that could
I
also.
did urine ovulation test also, sir. It was negative. Then I gave trigger for
I
that.
think you have done everything right, madam. It's just a misfortune. Yeah.
Sir,
Can we
one
move
more
on
question, sir,
later,
last.
madam, please? We are really taking a lot of questions. Can we move ahead now? Yeah. Yeah. Mohan, please. Just before we go with Mohan's lecture, there is our friend, Mr. Nilesh. He just wants to do a cake cutting ceremony to celebrate his Built by Mass Technology HMT introduction in India. Nilesh, please go.
Okay, very good evening to all my colleagues and friends. I think it's indeed a pleasure to be back in Pune. I'd like to thank Dr. Sachin for inviting me over here. This is my current Bhumi. I did my MD from Pune University, AFMC, a couple of decades back. So it's indeed a pleasure to be here. I did spend my childhood in Viman Nagar, so it's quite a bit of nostalgia for me. So I think you are all very brave people who have been here from morning 10 o'clock. I really am very happy to see that you are still interacting. So I won't really make it very difficult for you to endure this session. I'm going to keep it very simple. Just touch upon the evidence. So I call myself a clinical researcher. I'm not a researcher. I'm not a clinician alone, but I'm more of a clinical researcher because we do get to see a lot of cases, but we kind of try to decipher where the evidence stands. So this is very close to what we practice. So I'll be happy to take questions on this anyway. So this is timed for 25 minutes. I don't have any conflict of interest. Whatever studies have been quoted and so on. Of course, some of the Cochrane material will be quoted because they stand for the high quality evidence. So I'm just looking at the practical clinical aspect. So I'm not going to discuss the lab aspect because that's been covered. Moment I came, I saw a lot of discussion on andrological aspects of IUI. So I'll quickly rush through a few of these points, indication, and then single versus double, timing, number, and tag, when to move, and our own data, which was published almost 1.5 decades back, and what we learned from there. So if you are quoting your IUI success rate beyond 15-20, then clearly that is something of an achievement, because I quote our rates at 10 to 15. Okay, so this is all about autologous IUI. I'm not talking about third party. So worldwide quoted rates are between 8 to 22, but they differ for various reasons. Now, contrary to what many believe, PCOS or anevolution is not an indication for IUI. But I routinely see that it is added in most of the talks and so on and so forth. IUI mainly is for unexplained infertility, mild male factor, because that borders on unexplained in practical terms. Sexual dysfunction, cervical factor anyway no longer looks around, people hardly look around for that. Probably early endometriosis, you can argue for an IUI. As I reiterate, PCOS and anevolution is not an indication unless it's a combined indication. So why does the literature give you such a wide range of success? So between 10 to 20, that's because every time you look at the population, it could differ. What's the female age factor, and whether are you giving it for good prognosis cases or prolonged duration of infertility? What kind of stimulation protocol? Gonadotropin usage has its benefits, sperm preparation, single versus double, and so on. So many times the studies quote cumulative pregnancy rate. So I know at least a couple of studies which came up with IUI success rate of 25 versus 35%, and all. I was wondering why 35% they're getting on IUI, I don't get in IVF. And then I figured out that that's because it is cumulative. So you have to really get into the methodology to figure this out sometimes. But so I'm just touching upon very practical points, which are backed up by whatever evidence that is available. So when do you plan an IUI? So there is a trial which was way back, 2 decades back. Nowadays, if you start doing trials on IUI and expect it to get published, it's very difficult, okay? Because people have lost interest in the editorial on IUI. So if you are looking at IUI studies, you'll have to look at the bottom rung of the journals. So this trial actually looked at 32 versus 38 to 40 hours, and they did not find a real significant difference, you could call it. So then there was a Cochrane 2014. And if you look at the pooled analysis here, so broadly they have looked at, people try to do IUI at 24 as well, and some go beyond 36. So if you can look at the diamond here, which is more in favor of long protocol, long interval, and that's where the current evidence stands. So if you are looking at an IUI, I think it's safe to go beyond 36 hours, 34 to 36 hours, and it will be fine. But what it tells you is that it gives you flexibility. So if you have a busy practitioner, jostling between your OP and IUI and stuff, so between 34 to 38 hours, it's fine. If there's a delay, you just ensure that the husband collects the sample as close to the plan of IUI. It should not be that the sample is sitting in the morning and you do an IUI in the afternoon. That's where the pregnancy rates do go down, because the sample is sitting in the lab for too long. But otherwise, you have some flexibility in terms of evidence. Between 34 to 38 hours, it's fine. This is what we do. We kind of plan it around 10 o'clock in the morning when the trigger has been given somewhere at 9 or 10 in the night, 36 hours before. Now, what is the size? Again, somebody did venture out trying to do a trial, and they looked at giving a trigger at 16 to 16.9, 18 to 19, if you call it. And they found similar pregnancy rates. Now, what it tells you is, first of all, I was still wondering how they did this kind of a trial. There's so much of inter and intra-observer variation in measurement. If you ask me to measure at 9 and go back and measure the same follicles at 12, I might give you a different. So that's why I read all this with pinch of salt. This is simply, just for the sake of a trial, there is a trial. But that's fine. Anyway, it's got published in a decent journal. So To me, what it tells you is that if you plan a trigger at 16, 17, 18 mm, for an IUI cycle, it is really not going to make any difference on ground. That's the take home point for me from this trial. For me, where I'm from a training institute where I have students, DM students all around, I let them do the scans on all this because I know that even if they go wrong, we have a margin of error there. That's how I take it, these kind of studies. Now, there is a school of thought which strongly believes in double IUI. So what's the evidence for double IUI? So unexplained infertility, this particular systematic review meta-analysis pooled in and found out that double IUI does not have an advantage in unexplained infertility. So if you're planning in a double IUI in your practice for this group, definitely no real reason. Now people went on and dug around the trials and they found that double IUI is working in the male factor. Now, what is the male factor on all these trials? It's very difficult to figure out. There will be a lot of heterogeneity. That means they are not really similar, but whoever the reviewer was, he planned to pool them. And if you see here, this particular study, Liu from China, actually has got the maximum weightage. So when you're looking at these kind of forest plots, it's important to go and dig into it. So only because of this one trial, the whole diamond got shifted on this side, that is favoring double IUI. If you take out this trial, the final results are that double IUI or single IUI does not favor even in male factor. But that's the criticism. And overall, looking at the whole evidence, this is a very beautiful paper from Colhen, who is the absolute authority on IUI. So most of the work and has been published is from his group. So it's worth going through. If you ask me, practical considerations, cost will go up. Psychological burden, asking the guy to come back twice in 2 days and giving sample. Increase in workload. See, for me, we do around 500 IUIs in a year. Automatically, it becomes 1,000 IUIs, because you're processing twice. So it doesn't really make sense. And what is NNT? It is number needed to treat. So after that review, they said that you have to actually perform 81 extra IUIs, like extra 81 couples are needed to get that one pregnancy. So many times when we are asked, what should I do or not, which is increasing and so on, you will have to treat 81 couples with double IUI to get that one additional pregnancy. It's your call whether you want to go ahead or not. I would not recommend that. And that's why taking all these considerations, it's never the medical alone. It's the cost. It is a lot more to it because our couples are already psychologically quite distressed. So that's why none of the recommendations have gone beyond single IUI. I think it's a very reasonable decision from them. This I will not touch. I think Dr. Goody has touched this. If you're looking at IUI again, this is urinary recombinant really should not make a difference. The Cochrane evidence also is very clear. Now, this was a big fad a decade back, adding antagonists. So we want to make life more complicated. We will. So this is the study I was trying to mention. 37%, and then I started digging around and figured out that actually it is a cumulative pregnancy rates of 3 IUI cycles. And they got a pretty high rate of 53%. Another trial also kind of. So Antag became a fad at even for IUI. So it had come in for IVF and then people felt, let's add Antag and get higher pregnancy rates. But as most of the interventions in this specialty and maybe in other specialties, something is introduced and there is something called publication bias. So the editorial will be very keen to publish all the positive trials. So what will happen is you'll have a flurry of positive trials and then there'll be a plateau and then you'll have all the negative trials coming. So this was the big trial which got published in Human Reproduction, and it was a very well designed trial. So actually it's a blinded trial, which obviously is good. and they found clearly no benefit of adding ANTAC. So overall, adding ANTAC, then people started cooling in and trying to somehow find a reason to use ANTAC. So you can see this meta-analysis is showing some benefit. So it's very difficult for clinician to figure out which way is the evidence flowing. Then people started looking at a subgroup. So as I said, PCOS is a very controversial topic for IUI, but people do this thing, and this is a subgroup. So this is non-PCOS trials, and this is a PCOS trial. So there seems to be some benefit in the non-PCOS group, not in the PCOS group. So you can go on dissecting this, but if you ask me, practically avoid ANTAC in IUI because the cost factor will go up dramatically, and there is no real gain in terms of benefit. You can once in a while, we use it only for patients who've had a premature rupture, who have a tendency, by the time you call them on day 9 or something, the follicles have already ruptured. Those are the cases, or in case you have a weekend and you want to have a scheduling issues, your lab person is not around or something like that, then you can use ANTAC. Otherwise, definitely stay clear of ANTAC in IUI cycles. It's really not going to help much. Now comes whether you should wait for HCG natural surge to occur or go for an HCG trigger. So Dr. Goody has given us a good overview of what's the problem with HCG. So in an IUI cycle, so this was the evidence available till 2014, where there is no clear benefit either way. So whether you go for waiting for a natural surge or you go for an HCG trigger. I think this was the largest trial from our group, which got published in BJAR, which actually looked at waiting for spontaneous ovulation in IUI versus giving an HCG trigger and doing an IUI. So this was our results, and we did not find much of a difference. You can see 8.3 versus 9.3. So approximately almost the same. And we relied on LH kits, and we did figure out that the LH kits had around a false negative rate of 9%. So overall, if you are looking at waiting for a LH surge, or you want to give an HCG trigger, either way, it's fine because the results don't really seem to change. Now, this is the dilemma that we face. So there's very little data on what happens in IUI context, let's say when patient is beyond 35. There is some data that people have put up there, where after 40 also people have ventured out and tried IUI, and these rates are actually similar to our live birth rates in IVF. So I'm not sure, but then it is a different group. Some people, they would have just got married maybe at 40, and then probably you can still consider it as a one-off case. But routinely, I would say once it is 35 and beyond, you have to be very wary of continuing to offer IUI, especially if the duration of infertility is on the longer side. It's time to start moving away. There is now some data which has come, I think recently also it's been published, where the ethnic related differences are there, and we do have some data to suggest that the Indian women, especially the South Asian region women, have a faster aging. So if you go to UK and practice, it's very normal to get fantastic pregnancy rates at 38, 39 with IVF. Whereas for us, by the time they are 36, 37, we start wondering things, it's a downhill. So there is the ethnic difference that we have to start taking into cognizance, but I can always, I can tell you that there's some data as well now, which is shown that. So be very wary of continuing to offer IUI after the age of 35, 36. Now, slides have got a little, I think because of the formatting issues, it just got changed, but how many times IUI? So this is a question that is asked often. So recommendation is up to 3 to 4 cycles. Beyond 4 to 5 cycles, you have hit a plateau. You really can't go beyond that. So if somebody has already finished 3 to 4 good stimulated cycles, and then you still decide to start again with IUI, then you really need to have a rethink, because the recommendations are that by the time the couple hit around 4 cycles, it's time to start looking beyond it. So that's the magic number, but People do argue and go up to 6 cycles. Now the context can vary. You can have a CC-IUI cycle, 6 cycles, that's fine. Now, where can you offer a CC-IUI or a letrozole IUI is something that you need to think, because CC-IUI or a letrozole IUI is typically for male factor, where you just want to, because the pregnancy rates do not differ between a gonadotropin stimulated IUI versus oral ovulagens for a male factor. So remember this difference, that indication is very important. Whereas in the context of unexplained infertility, there is a difference in pregnancy rates if you use a gonadotropin versus an oral ovulagen alone. So if you are looking for an IUI in a male factor, a clomiphene or a letrozole is fine to stimulate. Whereas if you're looking at an unexplained, you need to have some gonadotropin. You can use a combination of oral versus plus gonadotropin, that's fine. So in our practice, frankly speaking, because our tertiary center patients come from far away, and I really don't push them beyond 2 to 3 cycles, because by the time they travel to us and go back, the cost of logistics is actually more than the treatment. So beyond 3 cycles, we really don't go. This is something that is a very recurring thing in our practice, and this is only limited to this part of the world. If you move beyond this, nobody is going to ask you this question. Because really there is no need to scan people and chase the ovulation. That is not something that is practiced. Only in this part of the world, this is practice. I would really advise to stay away from this, because it really increases the multiple visits. Patients start getting a little frustrated, because the more your visits to your clinic, more is the mental pressure. It increases the cost, workload. You keep on scanning, you increase your workload, stress for everybody else. So this really hasn't been shown to improve results. So we really don't time our IUI based on whether ovulation has happened or not. And it is not supported by any kind of study. So please, I would really have to find a real strong reason to do this kind of a practice. Okay, now whether you want to do an ultrasound guided IUI or not. So there was a trial which did this, and they found exactly the similar results. Now, this is not surprising. This is very different from the evidence for ultrasound guided embryo transfer. So in a IVF context, ultrasound definitely has shown to improve the IVF success, whereas in IUI, there is no difference. And it's not very difficult, In real life, if you have a difficult IUI, in the worst case scenario, I'll do an intracervical injection and get on with it, because the pregnancy rates are not nil. You will still get away with 5 to 10% rates. Whereas in an embryo transfer, you can't really stop doing, you can't do a transfer in cervix. You have to get in and negotiate the internal loss. So that's why ultrasound has a role in IVF, but it doesn't have a real role in IUI. So that's not recommended. And again, this is very different from what the evidence is for IVF. Bed rest after IUI, there is a trial which has shown increased live birth rate following IUI. So if the patient had an IUI, 15 minutes of bed rest is fine. But this is opposite of what the results are for IVF. Bed rest after embryo transfer, in fact, has shown reduced pregnancy rates in IVF. Whereas in IUI, it has shown the opposite. So these are subtle, differences in the evidence, the way it comes in. And it's been recommended in this is the landmark paper, Human Reproduction Update by Coholen. So everything you can find out, because it kind of links you with the original trial. Progesterone support. There is no role to give progesterone for CC or a letrozole stimulated cycle. If you are adding gonadotropin, you can consider adding progesterone. Otherwise, just keep it simple. There is no need to add progesterone. And this is from data from systematic review published almost a decade back. So we don't give any luteal support for any CC or a letrozole stimulated cycle. We only add probably 200 BD for micronized progesterone if you're giving a gonadotropin stimulated cycle. Do you want to do a hysteroscopy to remove polyps before IUI? There is some evidence if you find polyps better to treat them before IUI, which is the case for any fertility treatment. If you find the polyp, you kind of remove this. Actually, but if you don't find any intrauterine pathology in the uterus, then there's no role of doing a hysteroscopy before IUI. I'll just share a data which was published almost 12 years back, and it still continues to be one of the highest cited papers, at least from our unit, which was in our ISAR journal. And we actually at that point looked at our own data. So if you ask me, there's a lot of learning in this particular paper that we had for our own practice. So typically for us, because it's a training institute and patients are coming from far, we are not very aggressive in stimulation. Why? Because if you have a situation where you have 4 or 5 follicles, my patients after the IUI go back home 2,000 kilometers away or 1,000 kilometers away. So I don't have a mechanism in place to figure out if they land up with multiple pregnancy or a triplet or a higher order. So for us, safety is very important. We are not very aggressive. So 75 to 80% of our cycles were actually monofollicular. The pregnancy rates were around 8.5%. Some of our cycles had 2 follicles dominant, and the pregnancy rates climbed up to 13.5%. Some of them had 3 follicles, and the pregnancy rates went up to 20%. So this is actually a very important thing. So the pre-trigger dominant follicles will decide your success rate. If you are into aggressive stimulation, you are likely to have a higher pregnancy rate. But it will come at a cost, and the cost is multiple pregnancy and, more worryingly, higher order pregnancy. This was a question discussed in the evening when I came. So at that point of time, when the study was not done, we had been offering IUI for anybody who had a TMF of more than 1 million. And if you go back to literature, there has always been argument, shall we offer at 1 million, beyond 1 million? So after this study, we raised the cutoff. So if somebody is really looking at the TMF, they should not go by the studies. They should probably look at their own data, because you will have to look at your data and figure out what is the cutoff at which things are working and what is it not. So for us, anything below 5 million, the IUI pregnancy rates were 2%. And we stopped offering IUI for this group. Okay, we hovered around for 5 to 10 million. And between the highest pregnancy rates were between 10 to 20 million. As it goes beyond that, it really plateaus, and beyond 50 million, it actually starts coming down because of more of reactive oxygen species and so on and so forth. So my practical point when I'm ending this talk here is that age beyond 35, duration 5-6 years, you should start getting worried and probably start moving on. In practice, really very less benefit beyond 4 cycles. If you have a patient with moderate to severe male factor or endometriosis, especially beyond minimal to mild, you should avoid looking at IUI as an option. We do not do any biochemical monitoring even for IVF cycles, save the last day. So for IUI, it is out of question. Don't complicate life for patient by going for E2, P4, LH and all that in IUI cycle. Really no need for all this. Trigger, as I said, it's flexible. You want to plan it at 34 hours, 38 hours, doesn't matter. Avoid double IUI. Clearly evidence is not showing it helps. Antagonist, avoid progesterone only for the gonadotropins. If you ask me, what is the way forward to increase the pregnancy rates? You have to look at your stimulation protocol carefully. We go at 75 international units as a maximum, but if you want to, you can start looking at between 75 to let's say 112.5 and so on if you want to stimulate. So first cycle can be a little low dose, and then if you are seeing a monofollicular development, you can consider increasing it for the next cycle, not that cycle. And then obviously you will have a risk of higher order pregnancy and twin pregnancy. So both of these things go hand in hand, the risk benefit ratio. And if you land up in those kind of situations, obviously you need to consider strongly cancellation, or a rescue IVF facility should be there. We have done that like beyond 6 follicles coming up 14 millimeters, we offer change to IVF. You can just start antag and go on with conversion to IVF. That's a possibility in an IVF center. I would stop here and happy to take questions. Thank you.
Thank you. Thank you so much, Mohan. That was a great insight into IUI. I myself, I have two queries to you. Because you come from a teaching institute and a tertiary care center, I think we would like to have a few advices from you, very direct advices which we can put in practice. Do you use only RFSS stimulation for IUI? Because a lot of our patients cannot be able to afford it. And we may have to go to
Urinary.
urinary. Then what is your standard IUI protocol which you tell to follow in urinary for your patients?
So for unexplained infertility, I'm okay with the clomiphene gonadotropin stimulation.
So
Or
does it go hand in hand or one after the other?
see, most of our patients will not last beyond 2 or 3 cycles. So it's very rare.
No, not that way. Clomiphene first and
Yeah,
then
so
gonadotropin
clomiphene day 2
together.
to day 6, day 2, 3, 4, 5, 6, and day 5, day 6, days 5, day 7, day 9 is the HMG 75 international, and day 10 onwards the scan. And then we will keep giving HMG till we find it's there. Letrozole, the only thing is CC-HMG versus letrozole HMG, you will have a slightly higher follicle development for with CC-HMG as opposed to letrozole HMG. So that's for unexplained.
Okay.
But for male factor, I'm okay with the CC-IUI.
Two more small queries. What is the commonest sperm washing method in your view?
We stick to double density for this.
For everyone.
Yeah,
Whether it is
yeah.
normospermia
Yeah,
or any kind of.
we really don't.
So alone swim up, you're not doing it.
I'm okay with that, but in our institution, by protocol, it's double density because then we get this, TMF, and at that point, many times during IUI, we figure out that the TMF is really low, and then we start looking at changing the decision for the next cycle. That's the way we take it.
Thank you so much, Mon. Any more questions?
It's full bladder for IUI. No.
Really, because we are not planning to do ultrasound anyways, unless you land up in trouble.
So you said you wouldn't do an ultrasound scan on the day of your IUI. How do you document the cases of LUF in such scenario?
We don't really need to document that.
We don't have to?
No.
At least to decide what we have to do next for the patient?
See, that's what the thing is, somebody needs to give me the literature on this. We don't have any of these things. So this is what I'm trying to tell. This LUF thing is overhyped because we are banking on our visual impression of the ultrasound. That's why Dr. Goody was trying to tell us you do a serum progesterone and so on. See, we also need to understand, are we in a gynae onco field or we are in fertility? What is the cost of missing this? What are we missing? End of the day. You might just offer another couple of IUIs, it becomes failure and you move on. But what is there to correct this? It is not going to correct. So trying to track this LUF is a very, very, I would say, controversial thing. It's not supported by any kind of literature that I know, especially. So we don't really do that. And see, the thing is, we also keep on getting our data peer reviewed. Okay, when it gets published, it is the peer reviewers are also going to see what kind of success rates we are offering. So it is in consonance with the current world standards. So that's the way it is. So we really don't need to get into that. I would say that. Yeah.
Excellent talk, Dr. Mohan.
Thank you,
A
sir.
lot of take-home messages. Just one small thought. See, we use letrozole, we use clomiphene, and most of the times, as you have said, it's only one follicle. And therefore, probably a luteal phase support is really not required.
Yes.
Just like what happens in nature.
Yeah.
But in case you're using gonadotropins,
I added that.
I agreed. But still, many times we have just one follicle. And then probably the need for luteal phase support is
so
still
again-
there or not? Not there.
So I would still, because you've given gonadotropins, the E2 levels are higher, but you can argue it out. I would say there is insufficient. You can not give also, but see, it's the same story of IVF. We know that probably by 2-3, once the beta HCG is done, and somewhere around 5-6 weeks we can stop progesterone. But how many of us are actually stopping progesterone for an IVF pregnancy till 12 weeks?
No, because I'm reminded of my discussion with Professor Evers some years ago.
Yeah.
He said that they had done studies in their unit, and they said whenever you have a single follicle, that
I would back that.
ratio of estrogen progesterone, whatever he said, gets skewed when you have more than one follicle. That's the reason you require that
That's why
support.
I would be okay with that, but you can argue it out, but I'm okay with not giving a progesterone for a gonadotropin if it's a monofollicular. But because it's an institution, certain protocols are followed, I can't do that fine tuning. Plus, there is no data to suggest either ways.
Thank you.
Because one more thing is, it's not like one dominant follicle here. There'll be always one more lurking around there, which is around 13, 14 mm, you know, so there is a problem. Plus, we don't do any biochemical monitoring. So, you know, those are the things.
Sir, you use alternate day HMG all through or you make it
No,
daily
we only
later
start
on?
with alternate days,
Okay.
but once the scan starts, we take over and do it daily.
Daily.
Yeah.
Acha, just
HCG, we are giving 5,000 units. Sorry, I didn't get you. 5,000 is more than enough, even for IVF. We don't. I would not. Please, that's what these are all anecdotal. For IVF only, I don't go beyond 5,000. So there's no question of going for, you know, more than 5,000. Please just keep it simple. There is nothing to suggest giving 20,000 and all.
Acha, just
So-
your thoughts on reverse stimulation, means giving gonadotropins first so that you have more follicles recruited initially and then give probably letrozole later on.
We just continue with that. You know, I will not. But ultimately, if you start giving gonadotropin early, let's say day 2 and all, you are likely to get more follicles and going to hyperresponse. See, one thing we have to remember is it's little difficult to control a IUI cycle. You know, here you will get more follicles, you are in a troublesome problem. Whereas in IVF, you get more follicle and get away. So we have to be really decide how fast, and so that requires a lot more involvement of the clinician. Like for me, that's a little difficult one because I can't start going and looking at every IUI cycle. My trainees are looking at it, but that's why we have to go a little safe. But if you're an individual practitioner who is going to see that case again and again, you can fine tune it. But remember that it's a difficult one to control in IUI. IVF, you get away with hyperresponse. In IUI, it's going to land you in trouble.
So since it's an institution where you're working, if
Yeah.
you have a case of bicornuate uterus, are you doing IUI under ultrasound guidance for such cases or you're directly offering them IVF? Because I had a case in my clinic recently and the patient was actually not diagnosed to have a bicornuate uterus. It was just diagnosed as an anomalous uterus query R28 where she had already tried 2 cycles of IUI elsewhere, came to me, then I got an MRI scan done and it turned out to be a bicornuate uterus. So
I'll treat her the same way as
would
any
you-
particular, because bicornuate should not worry me too much. If it's a septum, it will worry me. Then I have to correct. But bicornuate, I would not be too worried, and it should not have an influence on your IUI treatment.
But wouldn't it be a difficult procedure to do a bicornuate, I mean, to negotiate and
See, in that case, if you see, those are like those typical one odd case and all, you can always see. I'm not preventing you from using an IU.
Use ultrasound.
Use ultrasound. See,
Ultrasound,
I'm
use
not, see,
MRI.
these are routine things we
Outlier.
are talking. If you land up in a soup, you might as well use everything that is on your disposal. I'm just telling you, don't do it routinely. Okay, see, the operational word in all these talks is routine. When things are difficult, okay, Baba, take an ultrasound and do it. It's not a problem. But routinely, it's not advised.
And if there is a patient who's had a previous history of hydrosalpinx, unilateral, or
Yeah.
maybe a history of ectopic where she underwent a lap salpingectomy and now she is having only one tubal status, are we
I'm
supposed to
wary
give
of
them?
doing IUI for
Yeah.
this kind of thing.
Yeah, that is what I wanted to know.
I am
Would you-
very, I usually don't advise unless there is a clear documentation, laparoscopy, unruptured ectopic, pelvis is clean and the other tube, I don't know, whoever has checked it at whatever point of time it is clean, then you can argue about it. But otherwise, if there is a tubal factor, whichever, you should stay away from IUI. I would
Because
say.
there are 2 schools of thoughts. Some people do give an IUI as an offer.
I would
but
stay away, just time and cost.
I don't
That's-
give, so
Yeah,
I'm just
because
asking
I
your
would not.
opinion on this.
If somebody's got hydrosalpinx, definitely there's no case of going for IUI. But if somebody's got a ectopic previously and you have worries about her other status tube, see, tubal patency is different and tubal disease is
Disease,
different,
yes.
and that's something that people confuse.
Yeah.
So if I have no clear information about the peritubal adhesions, it's just tubal patent, I will not go for IUI.
Sir, any take on vaginal sildenafil citrate or even prednisolone that
people are giving in the peri-ovulatory and post-ovulatory phase in routine IUI cycles?
See, there's a Cochrane which I was a part of. It just got published a couple of weeks back. It is on steroids in IVF, and there's no evidence even in IVF. So forget IVF. There is nothing to. These is like, see, I don't know. We don't have to give these things. Definitely. It's not.
No,
Acha,
for
sorry.
for
I
endometrial
thought it was a
endometrial.
woman.
Yeah.
मैं sorry, मेरे को लगा कि woman का वो.
नहीं मैं woman का ही बोल रहा हूँ.
अच्छा सर ठीक है.
More
मेरे
just
दिमाग
taking-
में गया. Sorry.
More just taking you away from IUI.
Sir, I have a question.
Yeah.
So would you do a tubal patency test before doing an IUI?
Definitely. You have to document patency before you go for IUI.
So
That's the
would you
first thing.
do an HCG or?
That depends upon what you're looking at. If you are not finding any reason to suspect endometriosis or peritubal disease, then you are fine with an HSG. Otherwise, you go for a lab. But I must add that the role of diagnostic lab is very minimal in
Yes.
today's fertility workup. So I'm okay with an HSG.
With an HSG?
Yeah.
Okay, thank you.
More just taking you away from the IUI. In ovulation induction for PCOS in your institute,
Yes.
how many times you follow the so-called chronic low dose protocol?
No, we don't do that at all because that actually mandates that you start at 37.5 and
Yeah,
then
maybe-
change at 14 days and all. So we kind of modified with the Indian context. We start looking at a jump around 9 to 10 days of stimulation.
Okay.
So something like instead of waiting
So
for 14,
75 IU for 9 to
yeah,
10 days.
we kind of go by the 9th day. If there is no response, then we take a calculated risk and hike up around that point of time. But remember that these are those resistant cases, and then you can always expect a big response. So otherwise, 14 days is just too long.
Yeah,
Most of
that's
the
what
patients
has
run
been our
away.
practice, but the literature, the olden literature.
Because the
which is
people we have not made an effort to document our
Yeah.
protocols. That's been a problem.
Well, thank you, Mohan. Thank you so much. It was a great
Thank you, sir.
presentation. Thank you so much. And we are looking forward for some Mohan's presentation tomorrow. One request is before Dipen is here. Tomorrow we'll be starting our sessions at 8:30 in the morning because we have a long day to go. Mohan has to catch his flight in the afternoon also. So we are starting with the investigations before embarking on active. Be followed by Mohan's lecture on recurrent implantation failures, and we'll go ahead from that. All of you are welcome to join us for dinner, which will be starting now. Thank you so much.